A very good morning to one and all. Am I audible?
Yes, ma'am.
Unmuted.
Okay, am I audible?
Yes, ma'am. I can hear.
Okay, okay, thank you. Thank you. Very good morning to one and all. After successful accomplishment of first day of Rehab-E-Con 2021, we are heading towards the most awaited session. Yes, research paper presentation in musculoskeletal physiotherapy. I, Dr. Shweta Paspute, Professor and Head of Musculoskeletal Physiotherapy Department of LSFPM College of Physiotherapy, accompanied with me Dr. Shruti Muraukar, Assistant Professor, Musculoskeletal Physiotherapy Department, welcome you all. We are fortunate today. We have two eminent and esteemed personalities of our noble physiotherapy profession, Dr. Chaya Verma Madam and Dr. Seema Saini Ma'am. I welcome you, ma'am. Now, I take this opportunity to introduce today's esteemed judge, Dr. Chaya Verma ma'am. Madam is professor and head at Physiotherapy School and Center, TNMC and Nair Hospital, Mumbai. She has 35 years of huge experience. She has completed her PhD from the esteemed Dr. D.Y. Patil Medical University, Navi Mumbai. Her main specialties are hand rehabilitation, brachial plexus injuries, and all musculoskeletal specialties. Ma'am has been awarded by Dr. B.R. Paithankar Memoration Oration by Narcot Research Center, Nagpur for contribution of efforts towards upgradation of rehabilitation of hand conditions, especially leprosy. Ma'am is research enthusiastic and keen interest in qualitative research. She has numerous publications on her name in international and national journals. Her recent remarkable work has been done during the COVID pandemic, which is seen by her 14 publication in esteemed journals and being appointed as member of Government of Maharashtra State Task Force for Post-COVID Management Strategy Planning. And she is a coordinator for rehabilitation team. So we are very lucky, ma'am, that this session is chaired by you. So I welcome you again, ma'am. Now I request Dr. Shruti Muraukar to introduce a versatile and affluent personality, Dr. Seema Saini, ma'am. Shruti.
Thank you, Dr. Shweta ma'am, for giving me this opportunity to introduce our eminent speaker, Dr. Seema Saini ma'am. Welcome, ma'am. Dr. Seema Saini ma'am is a professor in the MSc department in the Dr. D.Y. Patil College of Physiotherapy, Pune. She is having a wide 15 years of experience as a clinician and academician. Ma'am is a cognitive behavior life coach. He is certified in cognitive behavior life coaching. Ma'am is having numerous awards like a Rashtriya Shiksha Ratan Award in the Best Teacher category at Global Teacher Conference 2019 at Mumbai, India on 22nd December 2019. And also she was awarded by Global Teacher Role Model Award 2020 at Global Achievers Conference on 5 September 2020. Ma'am is having numerous international publications. Currently, since 2018, ma'am is pursuing her PhD. Welcome, ma'am. I have hand over it to Dr. Shweta, ma'am.
Thank you, Shruti. I welcome our enthusiastic participants for senior and junior category. We are going to start first with senior category. We have already displayed all rules and regulations for paper presentation, but it's my sincere request to all the participants to strictly follow for the time adherence. If you are exceeding time, then we will have to make you stop in between, and then question answer session by the judges will start. And for this, we will give you a prior intimation before 2 minutes. So even I request all the participants to keep your video off. and don't disclose any identity, because I can see here names of the participants. So I request them that they should put codes instead of their names. All the participants, please change your name and put it coding. Okay, for all senior category and junior category. Okay, so we are going to start first with our senior category, that is senior category code 01, and we are going to display your presentation. Senior code 01, please start your presentation. Are you able to see the PPT? Please unmute yourself. Senior category 01.
Hello, ma'am. Am I audible?
Yes, you are audible.
Ma'am, I
Are
can't
you
see the PPT.
Okay, wait for a second.
Yes, ma'am.
Yeah. Now are you able to see?
Yes, ma'am. I can see. Ma'am, if I have to change the next,
Okay,
will it
please
be done by
start.
your side? Good morning, everyone.
I will change it. I will
Okay,
change.
ma'am. Thank you, ma'am.
Yeah.
Shall I begin, ma'am?
Yeah,
Yes.
start.
Good morning, everyone. My title for today's presentation is Added Effect of Short Foot Exercise on Risk of Fall, Mobility, and Functional Balance in Older Adult with Pronated Foot. It is an experimental study. I start with my introduction saying that balance is an entity and a process through which the center of gravity is maintained, which helps to maintain the base of support of the body. Similarly, as posture is maintained by the balance, good balance, there has to be a good foot posture to maintain a good balance of the lower limb. So pronated foot, flat foot are the reasons through which there can be increased risk of fall, as pronation of the foot brings pronation of the mid-tarsal joint during weight bearing and reduces or decreases the medial longitudinal arch, which becomes a reason that pronated foot leads to change in the kinematics of the lower limb. So aging and balance has got a relation, as due to aging, there occurs deterioration in the sensory system, that is vestibular, visual, somatosensory, cognitive system, that is your central nervous system, and the musculoskeletal system, that is your kinetics and kinematics. Hence, the ability to control the balance during ADLs is impaired due to aging. So in the study, I'm using Berg balance scale, time up and go test, and functional reach test to assess the balance, dynamic, static, and functional. Next slide, please. Hello, am I audible, ma'am? Next slide. The aim of my study is to study the added effect of short foot exercise along with conventional balance training on risk of fall, mobility, and functional balance in older adults with pronated foot. The objectives are as such that I will determine the added effect of short foot exercise along with conventional balance training on risk of fall, mobility, and functional balance using the Berg balance scale, the functional reach test, and timed up and go test. Similarly, the second objective is to determine the effect of conventional balance training on risk of fall, mobility, and functional balance in older adults with pronated foot using Berg balance scale, timed up and go test, and functional reach test. And the third objective will be to compare the both. Next slide, please. The need of my study. There is correlation between balance and foot muscle strength, that is intrinsic muscle strength. The intrinsics of the foot include the adductor hallucis, the flexor hallucis brevis, the flexor digitorum brevis, and the interossei, which contributes to the stabilization of the foot arch during propulsion and which prevents the overuse injury related to excessively pronated feet. So conventional balance training has shown to improve the balance performance in older adult, but foot muscle strength being very vital as a component of balance is being neglected because foot muscles and foot is a part of the body that we don't pay much heed to, as a focused intervention is needed towards it. Hence, my study is to know the added effect of short foot exercise on balance in pronated foot individuals. Next, please. The hypothesis and the null hypothesis. So H1 and H2 are my research hypothesis, which says H1, short foot exercise along with conventional balance exercise has statistical significant result on reducing the risk of fall, increasing the mobility and functional balance in older adults with pronated foot. H2 will be the conventional balance training exercise will have statistically significant result, whereas H0 will be that short foot exercises along with conventional and only the conventional has similar effect on risk of fall, reducing the risk of fall, increasing the mobility, and improving the functional balance. Next slide, please. That is my methodology. So the population that I've included in my study is older adults more than or equal to 65 years of age. Sample size is 40. Sampling technique is simple random sampling, CHIT method. The study design is experimental study. The research setting is old age and housing societies in and around Pune. The material that I've used is pen, paper, yoga mat, consent form, rural, a goniometer, a stepper, a measuring tape, a chair, and a stopwatch. Next, please. The inclusion criteria of my study, as I told, the population that I've included is more than or equal to 65 years of age. The foot posture index was calculated, which should be between the range of +6 to +12. The navicular drop test was taken into consideration with the difference more than 10 millimeters. The minimum MMSE should be between 24 to 30. 24, that is out of the 30 total score, which says there are completely cognitively sound. The Berg balance should be at the result of 21 to 40, where it shows medium risk of fall, and the subjects that were willing to participate and who were able to walk continuously for 10 meters without walking aids were included in my study. My exclusion criteria, next slide, please. Was any patient with a history of fall or ankle injury was excluded. Vestibular problem like acute BPPV, acute orthopedic conditions, RA, OA, fractures in the lower limb, pain and inflammation in and around the joints of the lower limb, neurological conditions, Parkinson's, where you see tremors or something, and stroke, where there is circumductory gait, and non-cooperative subjects were excluded from my study. Next, please. The outcome measures were the risk of fall. I've shown the two pictures. Risk of fall using Berg balance scale. Mobility was assessed using the timed up and go test. That was the first picture. And the functional balance is assessed using the functional reach test. That is the second picture. Next slide, please. The procedure I've explained through my diagram, where the ethical approval was taken. 40 sample populations were selected according to the inclusion criteria. Informed consent was given in their own language to all the adults. Individuals were explained about, all the adults were explained about the nature, the purpose of the whole study, and they were divided into two groups by chit method. Group A, taking 20 subjects into considerations, were given conventional balance training, and group B, 20 subjects into consideration, were given short foot exercise along with conventional balance training. That was my experimental group. Then documentation of the subject data and demographic data was taken, and the outcome measures were assessed before the beginning of the study. So pre-outcome measures were taken. Then intervention was given for 4 weeks, that is 3 days per week to both the groups. The outcome measures were then again reassessed at the end of the 4th week. The results were analyzed and arranged in the forms of tables and graphs. Next, please. So the control group received the conventional balance training that I have shown you the complete protocol, where flexibility exercises, strength training, postural control, endurance, and cool up, cool down was given. Next slide, please. So I've included the photos of all the exercises that we've given to the adults, like calf stretching, reaching the limits of stability, abdominal strengthening, tandem walk, prone extension for the back.
Only 1 minute is left. Only 1 minute is left.
Even the next, okay, ma'am. And even the next exercises that were given is shown. And the experimental group was given short foot exercises along with the conventional balance training that I've shown you before. So the short foot exercises was given first passive, then active assisted, then active movement. That was 3 sets and was repeated for 5 times. So there's a picture for that. So statistical analysis was done where within the group was one-tailed and comparing the group was two-tailed. So here I show you the difference that blue and orange graph, can you see? So pre and post in group A, group B, that is group A with Berg balance was 30, then which again went to 40, which increased. Berg balance scale in group B before was 38.2, which went to 45.7. Then time dip and go in group A was 26, which went to 23. Then in TGU for the group B, that was 23.2, 18. Then 0.8, then 28. So similarly, there is comparison that I've shown in the next group, that Berg balance scale in group A was 7.11, which went to 7.55. Then TUG was 3.21, which went to 5.22. And functional reach was 3.21, which went to 5.45. So it can be seen that there is good significance. There is extremely significant result in experimental group. And for functional reach test in group A, that was control group, functional reach test showed extremely significant. So here is my discussion that says that there were studies done on improving the stability and strength of the intrinsic muscles. Okay.
401, your time is up. So I request judges to go for the question and answer session.
Very good morning, Dr. Shweta.
Good morning, ma'am.
This is Chaya Verma here. Can
Yes,
I go
ma'am.
on with the questions? Yeah. The participant 1 has said that it's an experimental study. Do you agree with it? It's a randomized control trial.
Ma'am, if I could include more sample size, it can be into a randomized control trial.
That means you had a limitation of sample size?
Yes, ma'am. My limitation is small sample size that I've included.
So what is the rationale of your sample size of including 40?
Ma'am, my rationale was according to the pronation foot, the prevalence that I got, and I included Z square P 1 minus P upon D square formula, which gave me at around a minimum of 40 sample.
No, if your prevalence is very small, then the RCT doesn't stand a value over here.
Okay, ma'am.
You understand? Because you are doing a simple random sampling with RCT with group A and group B. Yes, the sample size limitation is there, then it doesn't stand a value in RCT.
Okay, ma'am.
Are you getting me?
Yes, ma'am.
Okay, my second question to you is, you said the non-cooperative patients were excluded from the study.
Yes, ma'am.
But I think there is you have to give a openness to the patient that whether he wants to include in your study or no, otherwise it's a coercion.
Okay, ma'am.
So the right word would have been those who are not willing to participate in the study. Non-cooperative word doesn't sound appropriate over here.
Appropriate.
Because
yes,
because you had already taken in the sense their cognitive level, whether they are ready to answer your questions or no.
Yes, ma'am. Yes,
So
ma'am.
that time only you should have explained them that this is my study and do you want to include in my study one.
Yes, ma'am.
Okay, so scientifically that word doesn't sound good over here. That is a non-cooperative patients. Okay.
Yes, ma'am. Yes, ma'am.
Yes, I'm done with my questions, Shraddha.
Yes, ma'am. Dr. Seema, ma'am.
Good morning, everyone.
Good morning.
So my first question to you is, you did not consider obesity as a part of your study
No, ma'am. That is future scope. That with more BMI, you can calculate.
because you're taking pronated food and balance. So I
Yes,
think
ma'am.
that needs to be considered, one.
Yes,
And
ma'am.
you said in your exclusion criteria that you have excluded osteoarthritis and your age group was more than 65 years. So what test you have done? Radiological assessment or the clinical assessment?
Radiological assessment, ma'am. X-ray.
Okay. So you did not take any grade one also in your
No, ma'am. Not
hospital?
even grade one.
Okay, that seems little uh, not possible because after 65, 40 samples you got, and that too nobody has grade one also osteoarthritis.
Yes, ma'am.
Okay, I'm done with the questions. Thank you.
Okay, ma'am. Thank you, ma'am. Now, code number 2 should be ready. We are sharing your screen.
Thank you, ma'am.
You can start the presentation. Time starts now. Code number 02, kindly start your presentation. Your time has already started.
Ma'am, please restart the time, please. I had to unmute him myself.
It's okay. You start it now.
Start it now.
Yes. Code number 02. Please start it.
02, please unmute yourself.
Code 02 is.
Please
is it
unmute
there?
yourself first.
Participant 02. Please unmute
Hello.
yourself. Yes.
Yes.
Hi.
Yes,
Yes.
she's here.
Please start. Yes. Please start.
Start it now, please.
Yes, ma'am.
Yeah.
Of my effect of myofascial mobilization using the edge mobility tool on the pain, disability, and mobility in frozen shoulder. Next slide, please.
Is it better?
Unmute.
Hello.
Yes.
Next slide. Characterized by a loss of active passive shoulder range of motion in the absence of a non-intrinsic shoulder disorder. This pathological process is consisting of an excessive scar tissue formation across the glenohumeral joint, which causes a stiffness, pain, and dysfunction. Such changes in the periarticular area adversely affect the activities of the daily living. Next slide. Next slide, please.
Yes. It is changed.
Is a mainstay of treatment in managing this condition conservatively. This edge mobility tool causes the soft tissue mobilization using an optimal force, where the intervention will be directed towards releasing the adhesions, realigning of the collagen fibers, and increasing their further fiber gliding. Its role is more explored in the sports area. So this study was taken to see its role in the frozen shoulder patients and the role on the pain, disability, and mobility specifically. Next slide. This study was taken to study the effectiveness of the myofascial mobilization on the pain, disability, and mobility in frozen shoulder. The objective was to see the added effect of myofascial mobilization given through edge mobility tool in frozen shoulder along with conventional exercises, then to see the effect of only conventional exercises, and then to compare the effect of either of the two. Next slide. Next slide. It was a clinical trial where a simple random sampling using a lottery method was done. Ma'am, I'm not able to see the slide.
Just wait, just wait. Huh.
Yeah, next slide. Yeah, so the participants who were willing to participate, either the genders, 35 to 60 years of age group, patients who were diagnosed by the orthopedic physician as a frozen shoulder condition, and the presence of a capsular pattern where external rotation was more restricted than abduction, followed by internal rotation, were included. Those who have an upper extremity injury in the last 6 months, surgery to the arm, open wounds, unhealed suture, hypersensitivity, a generalized infection, and uncontrolled hypertension were excluded from the study. Next slide. So SPEDI was used to record for the pain and disability, universal goniometer to record the passive range of motion, inch tape to measure the Aplace crash test, and the edge mobility tool and emollient to give the treatment. Next slide. So after the institutional ethical clearance, the participants who fulfill the eligibility criteria and have given written informed consent, they were recruited. Then they were randomized into group A and group B based on the lottery method. And there were 10 samples in each group. After collecting the basic demographic data, recording for the SPEDI, passive range of motion, and the Aplace crash test was done. Group A and B both were given a conventional protocol of hot water fermentation for 20 minutes, Maitland mobilization, pectoral and the posterior capsule stretch, Wand exercises, and the Codman's exercises. But in Group A, along with this, the glenohumeral capsule, pectoral fascia, and deltoid fascia was localized for the myofascial mobilization using the tool. So there were 6 sessions given, 3 days a week for almost 2 weeks. Next slide. Next slide. So here I am showing you the edge mobility tool with the 4 edges that it has. So along with the treatment that was delivered through the capsule and the fascia. Next slide. The results are presented here. Ma'am, next slide, please. Yeah, so the mean age group in the group A was 53 years, while in the group B it was 45 years. Genders were equally distributed in group A, while it was 2:8 ratio in male to female in group B. Right was affected greater in either of the 2 groups. Next slide. Next slide. So for all the outcome measures that were recorded, there was a significant change with the p-value less than 0.05 in either of the group for within group results. Only for the across parameter of Aplace crash test in the control group, no significant result was seen. Next. And when the between group comparison was done, ma'am, next slide, please. Yeah, at that moment, the passive range of motion is especially only for flexion and Aplace crash test for the across parameter have shown the significant value. Next slide. So this study has found a statistically significant improvement in the flexion range of motion along with the horizontal adduction by using the edge mobility tool for the treatment of frozen shoulder. The evidence shows that the frozen shoulder is a synovial inflammation happens followed by a reactive capsular fibrosis. A dense matrix of type 1, type 3 collagen forms and it is laid down by fibroblast. Subsequently, your tissue will contract. Presence of increased growth factors, cytokines, all has been seen in the capsular biopsy of primary, secondary frozen shoulder patients. Pain is worse at the extreme of range of motion, especially when the contracted capsule is stretched. Next slide. The transfer of, ma'am, next slide, please. The transfer of compression and the shear forces through that mobility tool to the muscles, fascia, and tendon causes improvement in the soft tissue extensibility and reduction of the scar adhesion. This results in the pain reduction. Also, the inflammation due to mobility tool will speeden up the healing by increasing the blood and nutrient supply. Joint range of motion is influenced by many factors, such as the stiffness of joint capsule, ligament, elongation of the muscle tendon unit across the joint, a stretch tolerance. So the mobility tool will work to decrease the stiffness by decreasing overall soft tissue viscosity and making a muscle softer. There was a study in weightlifters with the subacromial pain syndrome, and they have found acute effect of the ISTM on the shoulder flexion range by breaking down the soft tissue adhesions, that is limiting the scapula upward rotation. In this study, the glenohumeral capsule, the pectoral fascia mobility might have contributed towards a functional improvement as seen with the horizontal adduction. Next, please. Functional improvement following the shoulder ranges has reduced the disability and has improved the quality of life. Physiotherapy, though, is the mainstay of treatment, still the evidence for the same is less as per Cochrane review. As the soft tissue mobilization was given for a period of 2 weeks and the sample size was less, the further sessions which target better could have been done. Conclusion says that the myofascial mobilization using edge mobility tool with the conventional protocol was able to improve the mobility and function among the frozen shoulder. Next slide. These are some of my references that have been used to prepare for this presentation. Next slide.
Yes, Dr. Chaya ma'am and Dr. Seema ma'am.
Thank you.
Yeah. Can I go ahead, Dr. Seema, with the
Yes,
question?
sure, ma'am. Sure, ma'am.
Okay. It was a good topic you selected.
Thank you.
What I have a question is, you have used a IASTM, that is an instrument assisted soft tissue mobilization technique.
Yes.
And you had a RCT. So did you take any consent from the patient, or did you explain the patient that you are going to use this tool?
Yes, ma'am.
Did you explain
I
him
have taken a
exactly?
written consent from the patient, and at the end, even the feedback was taken from the patient, because this was a pilot study run for a larger study.
No, but then you never said that it is a pilot study.
Okay.
But you accepted that the sample size was less. So it
Yes,
is
ma'am.
contradictory, no? Then it is
Yeah.
contradictory. So in the beginning only, you should have said that it's a pilot study.
Okay.
Okay. My second question to you is that, are you trained to use this IASTM method?
Yes, ma'am. I have done the workshop for the same, and I have been practicing it.
Okay. Okay. Now, a very small two questions. Which language of the SPADI questionnaire did you use? English, Hindi, or Marathi?
Ma'am, while communicating with the patients, I have mostly used the Hindi language while communicating, but I have tried to kept my instructions similar while asking most of the questions.
No, but there are Hindi, Marathi versions available very freely from the author. So you should have taken a permission from the parent author to give that, because then patient would have read it himself or herself and marked the answers, no? Instead of you taking the interview. Okay?
Okay.
Yeah. And you said the frozen shoulder cases were diagnosed by the physician. Don't you, as a physiotherapist, have a capacity to do a clinical decision making to diagnose the frozen shoulder?
Ma'am, actually, it was like you have to take a diagnosed cases, or means how will you prove for us one single diagnostic test which has a good validity also to prove that it is a diagnosed case for that it is a frozen shoulder only. So
But
for that,
knowing the stages of the adhesive capsulitis, okay, there are 3 stages of adhesive capsulitis, and frozen shoulder is one of it. As a clinical decision-making capacity of physiotherapist, definitely gives you authority to diagnose it as a frozen shoulder.
okay, ma'am.
Patient can be referred to you by the physician as a pain in shoulder.
Okay.
But you are going to diagnose it, no, with your capacity to do a clinical examination.
Yes.
Okay. Okay. I'm done with the questions, Dr. Seema. You can
Yes.
please.
So what I understand is, in one group you gave myofascial release mobilization with the edge mobility tool, but in other group you have not given any release or MFR, anything. Nothing has been given, that sort of, right?
No, ma'am.
So okay, so that is one thing. And do you have any dropouts in your study?
Ma'am, it was a pilot study done. So for this much pilot study, there was no dropout.
There was no dropout.
No.
Okay. And have you considered diabetic and non-diabetic patients here?
Uh,
Because both will respond differently to the treatment.
yes, ma'am, as most of the population was diabetic only, but there were some 3, 4 people who were not diabetic.
Uh, okay, I think when you will go for the further study, consider that point in your study, that how many were the diabetic and non-diabetic.
Okay, okay. Thank you so much.
Thank you. We can go ahead with the next presentation, please.
Yes, ma'am. Ma'am, there is little connection problem from our side. We'll take 5 minutes to start for the next.
Okay.
Okay, participant number 03, please start your presentation. Am I audible? 03.
Number 03, please unmute yourself.
Zero three. 03, are you there?
Is it senior or juniors, ma'am,
It's a
right now?
senior category is only there.
I cannot
Senior
see
category.
I cannot see a senior 03 in the list.
Maybe they haven't edited their name, I think.
Yeah. Is it Kiran
And
Jeswani?
yes, correct you are. She's there, I think.
Yeah, that's her name.
Hello.
Yes, yes, yes. Please
Hello.
start.
Am I audible?
Yes, yes, you're audible.
Shall I start?
Yes, please start your presentation.
Good morning, everyone. The topic is the Tampa scale of kinesophobia and pain, disability, and grip strength in patients with lateral epicondylgia, a narrative review of the literature. So, lateral epicondylgia is a chronic pain at the lateral epicondyle of the humerus. Signs and symptoms are pain, tenderness, limited extension at the elbow joint, and weak grip strength. So in the fear avoidance model, it is a psychiatric model that shows how individuals develop chronic musculoskeletal pain because of avoidant behavior based on fear. So if there's injury, there is pain. But if there is no fear, then the patient recovers. But if there is fear, then the patient experiences pain and movement re-injury, behavior and cognitive avoidance. The patient will view a situation worse than what actually it is, which will cause disuse, depression, and disability. So related to the fear avoidance model, Miller, Colley, and Todd introduced the word kinesophobia, which is fear of physical movement and activity. This is a Tampa scale of kinesophobia, which is a 17-item questionnaire used to assess the subjective rating of kinesophobia. The range of from 17 to 68, where high score indicates an increase in the degree of kinesophobia. Next slide, please. Next slide, please. Need of study. Tampa scale of kinesophobia was originally for chronic low back pain, but recently it has been used in other musculoskeletal conditions. So it is necessary to explore both the physiological and the psychological factors in order to identify patients at higher risk of developing chronic symptoms and kinesophobia and provide effective rehabilitation for lateral epicondylgia. Numerous studies were identified regarding the Tampa scale of kinesophobia and musculoskeletal pain. Far fewer were found regarding the in relation specific to lateral epicondylgia. Method: a review was performed of all the published studies which use the fear avoidance model and assess Tampa scale. Databases used were PubMed, Pedro, Cochrane, and Google Scholar, which was searched on March 17, 2020, and again on April 19, 2020 for new articles. Keywords were Tampa scale of kinesophobia and lateral epicondylgia. Only studies which assess Tampa scale in adult lateral epicondylgia were available in English were included, and the studies which were combined with other musculoskeletal conditions were excluded. Next slide, please. Next slide, please. So, results and discussion. Numerous studies were identified regarding lateral epicondylgia and pain, function, and grip strength. Very few studies were found regarding Tampa scale in relation specific to lateral epicondylgia. A total of 6 articles were reviewed according to the inclusion criteria, which included study from 2012 to 2017. So these were the articles which were reviewed. The first study in this section was published in 2017. The study studied the efficacy of scaphoid mobilization on pain, physical function, and kinesophobia in lateral epicondylitis patient. So the study supported that kinesophobia is a commonly seen factor among the patients with musculoskeletal pain, which should be considered while planning an intervention. In 2017, Francisco et al. Used measures of elbow pain, grip strength, and Tampa scale to evaluate the influence of expectation plus mobilization with movement in patients with lateral epicondylgia. This was the only study in this review in which grip strength was assessed. Although the study did not find any difference between groups on kinesophobia, clinically relevant differences were observed. The study also supported the fear avoidance model and assumed that patients with more kinesophobia could perceive more disability and vice versa. In 2018, Bina Kritika et al. Published a study on prevalence of kinesophobia among tennis elbow patients in India. The study concluded the importance of Tampa scale in determining kinesophobia, and the prevalence could have a negative effect during the process of rehabilitation. In 2016, Ganesh B.R. et al. Used visual analog scale, Oxford scale, and Tampa scale to evaluate the effect of mobilization with movement on pain, kinesophobia, and activities of daily living. This was the first study of its kind to support that kinesophobia is one of the most extreme form of fear-related movement. Fear of movement is an important factor which results in disability, disuse, and depression. In 2016, Kumbas et al. Assessed the acute effect of isometric exercises of different intensities on pain sensitivity in lateral epicondylitis patients. So relation analysis between pain rating and clinical variables, including pain and disability and kinesophobia was performed. The author concluded that there was a significant correlation between pain, disability, and kinesophobia. The last study to be reviewed was published in 2012 by Kumbas et al. To assess if sensory, motor, and psychological factors are unlike in severe lateral epicondylgia compared to less severe cases and control. The authors did not find any difference in fear of movement between different levels of severity of lateral epicondylgia. Conclusion. Next slide, please. So according to the inclusion criteria that were found during the research period for this review, there have been only 6 studies conducted about lateral epicondylgia and the Tampa scale in general. 5 studies supported that the fear avoidance model can be applied to lateral epicondylgia patients. To measure the kinesophobia and lateral epicondylgia connected to perceived disability, the Tampa scale has been used. Patients with lower Tampa scales have better elbow function. However, this relationship did not always persist in all the studies. Next slide, please. Future scope. There is scarcity of research on the relation between kinesophobia and lateral epicondylgia. Future research is required to find out if and to what extent pain, function, and grip strength correlate with kinesophobia in patients with lateral epicondylgia. No studies focused on the treatment of kinesophobia. It was an adjunct with other primary measures to be assessed. In order to provide effective rehabilitation protocol, avoid re-injury, it is imperious to assess kinesophobia along with pain, function, and grip strength in patients with lateral epicondylgia. Next slide. Next slide, please. References. Next slide.
Okay, your time is up.
Thank you.
Chaya Verma ma'am and Seema ma'am.
Yeah. I have few questions for the participant.
Yes, ma'am.
You are giving emphasis on the Tampa scale of kinesophobia.
Yes,
But according to my knowledge, you are using a fear avoidance model, which is a psychosomatic model or psychosomatic behavioral model.
Okay, ma'am.
There are scales available which are synonymous with the Tampa scale of kinesophobia, which are fear avoidance belief scale, as well as pain catastrophizing scale also.
Okay.
So why did you give importance to this Tampa scale rather than other 2 scales? Because those are the recent ones compared to Tampa scale of kinesophobia, which has come in 91, and I think fever avoidance has come in 97.
Okay. Ma'am, actually, in mostly lateral epicondylgia patient studies, Tampa scale of kinesophobia only has been used. The other, which I when I reviewed, I couldn't find any other scales mostly used. It was mostly Tampa scale of kinesophobia which was used.
Because basically, all these scales are pertaining to low back pain.
Yes, ma'am.
Then they have been generalized to the other conditions.
Yes, ma'am. Yes, ma'am.
Okay, that is the one thing. Second thing, I would have been very happy if you would have shown us the exact flow chart of whatever the review of literature you have done. That is how in the review of literature presentation it is done.
Okay, ma'am.
So what keywords had been used?
Ma'am, Tampa scale of kinesophobia and lateral epicondylgia.
But then your title says that you have taken grip strain, disability, and pain along with the Tampa scale of kinesophobia.
Yes,
so
ma'am.
those keywords also should have been used in your search.
Okay, ma'am. Okay, ma'am. Yes.
And what are the Boolean word did you use in the search engine?
Ma'am, Tampa scale of kinesophobia only I used.
No, what are the Boolean words did you use for your PubMed search? Boolean
Grip
words are
strength.
or.
Grip
No,
strength.
Boolean words are or, but.
Okay.
Okay, because that will
Okay.
decrease your number of articles which you get, and that shows the clarity of your search engine,
Okay, ma'am.
which
Okay,
has not been shown in your PPT presentation over here.
Okay, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
Thank you. I'm
Thank you,
done
ma'am.
with the questions. Yes.
I have a few points to add here. First, you
Yes,
have
ma'am.
given psychometric property of your scale, which is very important when you write a review of literature. And
Okay, ma'am.
mainly your review is like, as ma'am has said, you have in your title, there are many things to be explained, but the review is only about the Tampa scale. So
Okay, ma'am.
maybe you need to use a better search engine. There are search engine only for cognitive articles, so you can use that. Plus, you have given the view of what literature you have got. But after, when you write a review, you have to give the strength limitation of your review and the main
Okay.
findings that you have got from the review. So
Yes, ma'am.
I
Yes, ma'am.
think those part was missing in your review. So if you can
Okay, ma'am.
improvise and make it better, that would be.
Yes, ma'am. Sure, ma'am. Yes, ma'am. Thank you, ma'am.
Yes, we will move towards participant 04.
Hello. Hello.
Yes, 04. Go ahead.
This is not my presentation.
Okay. Your code is 04?
Yes.
Okay, fine. Wait for a second. Give us 2 minutes.
Participant senior category 04, right?
Yeah. Actually, I wanted my topic is related to MSK. I guess it is put up in neuro.
No, no, no.
No.
Because it's a MSK only.
MSK comparison of fib extensor strength, and this is a
No,
04.
that is not my PPT, ma'am.
But the 04 code is given to this topic only.
Yeah, but I think REC/SR/NR04 is given to me.
NR is neuro. NR is neuro.
Yeah, that's why I think there is some confusion. My topic is related to MSK.
Yes. No, but your topic is same.
Comparison of fib extensor.
Comparison
Is it
of.
No, that is not my topic, ma'am.
That
Okay,
is.
then your
Okay,
presentation
we will wait for a few minutes and we will start with MSK 05. We will.
Yeah, sure, ma'am. Sure.
Okay,
Yeah.
fine.
Yeah, no problem. No problem.
05, please unmute. Hello.
Yeah, we are starting. Just give it 2 minutes.
Zero five.
05, please raise your hand.
05, you can start.
Can you start?
05 is there?
There's no code number. Probably they have their own name.
Yeah, but
So
I think
I don't know.
everyone,
Please change your names as your code numbers, please.
What is the name of this person?
just a minute, give me 1 minute. I'm contacting her.
Is it fine? Please start talking. We'll check it.
05, please start. Now you are unmuted.
No, she is not. I can't find her in the list.
She is there. Her name is Mrudula.
That's not what she's kept in the group.
Okay. Because she is not able to edit also her name.
All paper presenters are requested to rename themselves on Zoom.
Rename
You have an option to rename.
as your presentation codes, please.
Without that, we cannot unmute you.
Senior category MSK 05, are you there? Okay, we'll start with the presentation of senior category MSK 04.
Hello.
Yes.
Ma'am, should I start? I think there was some confusion. Is it clear?
You are 04?
04, yeah.
So just check it out, whatever PPT we are sharing.
Just a minute. 04, that means your topic was not comparison of hip extension.
No, ma'am. No.
We'll come to you later. Just
Sure.
start with the MSK 04 code, which is given to the member right now. Okay?
Okay, ma'am. Okay.
Just wait for 2 minutes. We'll come.
Yes, sure.
MSK 04, are you there? MSK 04, senior category 04. MSK senior category 04, are you there?
04, please unmute yourself.
Okay, I think there is a problem with senior category. Both the papers 04 and 05, they are not able to unmute themselves. So I request both the judges that shall we start with the junior category?
Yes, you can start,
Yeah.
Doctor.
Hello. Hello.
Yes.
I'm
Yeah.
MSK 4. I've got
Uh,
unmuted right now. Can you please
okay.
play my presentation
Okay.
comparison?
Fine.
Yeah.
So is it visible? Screen is visible?
The screen is visible, but I can't see my PPT right now.
Just a minute. Wait.
Yeah.
Is it fine now?
Yes.
You can start the presentation.
Please do the slideshow.
Yes.
Good morning, everyone. The title of my presentation is Comparison of Hip Extensor Strength and Lumbopelvic Stability in Persons with Non-Specific Low Back Pain and Normal Healthy Persons. Next slide. As the recent evidence says that core is a box with 29 pair of muscles with diaphragm at the roof, paraspinals and gluteals at the back, pelvic floor and hip girdle musculature at bottom. Function of the core is that it serves as a muscular corset and center of functional kinetic chain. Next slide. Deficit in core muscles can lead to back pain, with one of the potential contributors being the hip joint. Also, literature has found that patients who suffer from low back pain have changes in hip extensor recruitment pattern and disturb lumbopelvic rhythm. Gluteus maximus has also found to fatigue faster in subjects with low back pain. Next slide. Persons with low back pain thus avoid the painful truck movements that leads to disuse of muscles and disturbs the lumbopelvic rhythm. Also, the hip-spine interaction gets disturbed. The conventional treatment has emphasized more on transversus abdominis and multifidus, but hip extensors have received very little attention. Also, hip extensor deficits in athletes have been studied, but the non-athletic population has not been addressed. Thus, the need arises. Next slide. The aim of the study being to compare hip extensor strength and lumbopelvic stability in persons with non-specific low back pain and normal healthy persons. Objectives being to assess the lumbopelvic stability and hip extensor strength in persons with non-specific low back pain. Second objective, to assess these outcome measures in normal healthy persons. And third objective is to compare lumbopelvic stability and hip extensor strength in the low back group versus the normal healthy individuals. The secondary objective was to assess the hip extensor strength of dominant and non-dominant leg in both the groups. Next slide. The inclusion criteria was age 20 to 40 years, BMI within normal limits, subacute non-specific low back pain with VAS less than 3 and centralized pain. Exclusion criteria, past, present urological, musculoskeletal or cardiopulmonary disease, hip flexion contracture, scoliosis, previous back surgery, peripheralized pain, gait deviations, SI and hip joint pathology, positive slump test and red flag signs. Next slide. It was a cross-sectional observational study with 110 subjects, 55 in each group, with a convenient sampling method, and study setting was physiotherapy department of tertiary healthcare center. Institutional ethical clearance was taken before conducting the study. Next slide. 55 persons of non-specific low back pain and normal healthy persons were selected as per the inclusion and exclusion criteria. Informed consent was taken for those who wished to participate in the study. All the participants were divided into two groups, Group A of normal healthy persons and Group B of the non-specific low back pain. Demographic data of both the groups was collected and low back pain assessment was done. Training of abdominal draw-in maneuver was given using pressure biofeedback unit for 3 days. Assessment of lumbopelvic stability was done and graded using Simon's test. In Group A, there were 4 dropouts, and in Group B, please come to the previous slide. And in Group B, there were 6 dropouts. Please come to the previous slide. Okay, the outcome measures that were there was the abdominal bracing maneuver and the isometric testing of the hip extensors. Coming to the results, next slide, please. With respect to the demographics regards to the age and BMI, there was no significant difference. It indicates that both the groups were same to start with. Next slide, please. Now, when the core strength was compared between group A and group B, core strength of low back pain group was lesser than that of the control group. The likely reason could be that transversus abdominis pre-activates before the peripheral movements of upper or lower extremity due to the feed-forward mechanism. And in low back pain, transversus abdominis does not activate in advance due to delayed onset timing, due to which sensory motor integration is disturbed, thus hampering the corrective responses. Next slide. Now, when hip extensor was compared between dominant and non-dominant, it was found that hip extensor strength was more in the dominant limb as compared in both the groups. Next slide. This can be hypothesized by the Previk's neurodevelopmental theory, which states that no limb is clearly dominant as one foot acts as a postural support and other for the voluntary action. Also, the anti-gravity extension on left side emerges before the voluntary motor control on the right side. This suggests that dominant foot for either unilateral or bilateral task behaviors is left for most of the individuals. Also, the cross-sectional studies shows that left leg tends to be longer and heavier. So this could be the likely reason why strength of non-dominant was more than dominant. When, please come to the previous slide. Okay, previous slide, the results. Please come to the previous slide. Yeah, when the dominant was compared with the non-dominant in hip extensor and in the group A and group B, it showed that there was no significant difference. That is dominant of dominant of low back versus dominant of control versus non-dominant of low back and non-dominant of the low back pain group did not show any significant difference. Next slide. The likely reason could be that back pain was in a subacute stage, maybe not a sufficient duration to weaken hip extensors. Also, VAS was less than 3, so it may have not affected the strength of hip extensors. SI joint pathology was excluded. Muscle was tested at 60 degrees, that is at optimum length tension relationship, but literature has found that level of gluteus maximus is highest during a full squat exercise, that is the outer range. Next slide. The conclusion of the study was core strength was significantly lesser in persons with subacute non-specific low back pain as compared to normal healthy persons. Hip extensor strength of non-dominant lower extremity was more than the dominant lower extremity in both the groups. A cross-group comparison between group A and group B, hip extensors did not show any significant difference in dominant as well as the non-dominant lower limb. Next slide. Limitations, only the core strength was addressed, endurance of the muscles was not considered, and the muscle was checked only isometrically. I would further like to add the clinical implication that the hip extensors, though it did not show any difference between the groups in the subacute non-specific low back pain, they still form a part of core. And as the core muscles were found to be weak in the subacute stage of the low back pain, so we should start the core training in as early stage as that of the subacute low back pain. These are my references, and thank you.
Judges.
Yes, I think I will ask my questions after Dr. Seema Saini goes ahead with.
Okay. So you have decided to take age group between 20 to 40 years.
Yes, ma'am.
Any specific reason for taking that age group?
Ma'am, I had to specifically assess the subacute low back pain. After 40, there are degenerative changes also that can take place. So again, ruling out the degenerative changes or any other problems like the stenosis, which I didn't want it to be a part of the study, as I wanted to work specifically on non-specific low back pain. That
Exactly.
is
Can
why
you
I
please,
chose the age group.
can you
Sorry,
please
ma'am.
define non-specific low back pain for me?
Non-specific low back pain actually means like when the patient does not have any specific red flag signs
What is
and
the red flag sign? Yeah, exactly. My question, you are just correlating it. So in exclusion criteria, you have mentioned red flag sign. So what do
yes,
you exactly mean by red flag signs?
the red flag signs would be in the case of rest pain, unexplained weight loss. So, or having a pain that is undiagnosed, or not able to find out the cause, what is the cause of the back pain. So, all these things are the red flag signs. So, ruling out the red flag signs, when we understand that the back pain is coming due to a certain mechanics, like suppose it can be due to some postural reason. So, that I would define like a non-specific low back pain without any uh, actual pathology, or I can say any anatomical structure may or may not be involved. It can be the mechanics that is more involved.
Okay, correct. So you are correctly saying that we should include the cause of the non-specific low back pain should be the main thing that we need to consider, right?
Yes, ma'am. Yes, ma'am.
Yeah, but in your study, you were only concentrating about the hip extensor strength, right?
Yes, ma'am.
And
Yes, ma'am.
but you use the core strength for so my I'm not able to understand why we are talking about the hip extensor strength in the title, and in the conclusion we are talking about the core strength. So how these two things are correlated?
Okay. Ma'am, there are both
Nothing
the
is
things
in your
that
title
are
is
involved.
talking strength.
Like suppose like we have the core. So core muscles, we all are focusing on transversus abdominis and multifidus, but as hip extensors, they also form a part of core. So if hip extensors are not recruited and if they are not strengthened, then it puts 3 times more load on the erector spinae. This has been found in the kinesiological studies. So if the hip extensors are recruited, then we can have a perfect balance of what we called as the low cross syndrome that is given by Janda. So it will help in that particular way. So I've assessed both, that is the core strength, and one outcome measure that is lumbopelvic stability that was assessed using pressure biofeedback unit. And second outcome measure I have taken as the hip extensors.
If we talk about the hip extensor recruitment, then I think uh, the isometric testing that you have done is not an appropriate tool to, as an outcome measure.
Yes, ma'am.
We
The
have to
hip
go for
isometric testing, right, ma'am, I've done, but I've done it on Biodex. So where we get the torque of the muscle. So the actual torque of the muscle in the mid range, that is around 60 degrees. So we can get the actual torque of the muscle in that particular position. That's why I have done the isometric testing of the hip extensors.
okay. Thank you. I'm done with the
Thank you,
question.
ma'am.
Yeah,
Have a
yeah.
line.
Yes. I have 3 questions for you.
Yes, ma'am.
You have tested the gluteus maximus strength with the isometric method,
Yes,
but
ma'am.
you yourself has said that gluteus maximus muscle fatigues faster.
Yes, ma'am.
So how do you justify yourself?
Yes, ma'am. Ma'am, gluteus maximus, it tends to fatigue faster. In the reasons why, because one thing, the hip, many a times
No,
the hip
I'm not
extends.
asking you the reason. I'm
Okay.
asking you that you have used a method of isometric contraction of the
Yes, ma'am.
gluteus maximus strength.
Yes, ma'am.
But
Yes,
you
ma'am.
yourself are saying that a gluteus maximus fatigues faster.
Okay. Ma'am, during the isometric testing, what I have done at that particular position, so it was just that the patient had to press on the rest that was given on the thigh and hold it till the torque was calculated and then release it. So it was not a sustained contraction that was given. It was only a 10-second
And
contraction
how
that
many
was
times did you
given.
give the
Uh,
contraction?
I
How many?
did. I did 3 trials with breaks, and then the best of the 3 was done, and then the torque was calculated, and it was divided by the body weight for the normalization.
My next question is, your secondary objective was to find out the difference between the dominant and the non-dominant side.
Yes, ma'am. Yes, ma'am.
What was the criteria to decide the dominant side? Did you use
Um,
any
yes, ma'am.
specific method
Yes,
to
ma'am.
decide?
The dominant side, it was done by using the leg which first kicks the ball. So suppose I give a ball to the person and ask the person to kick. So maximum 90% of the population use their right leg to kick the ball. But
But
when I assessed the strength, I
no, but if
found that
I'm a
non-dominant
ambidextrous,
lower limb.
I'll just cutting you over here. If I'm a
Yes, ma'am.
ambidextrous, I can use any side.
Yes, ma'am.
So
Yes, ma'am.
there is a
Ma'am,
criteria to
absolutely.
find out the dominant side.
Excuse me, ma'am,
Yeah,
and
yeah.
participant.
Yes.
Actually, the time is up for the
Okay.
So I
Please go
request
ahead.
now participant number 05 to
Thank
start
you,
with
ma'am.
the presentation.
Yes, please. Please go ahead. Please go ahead.
Can you hear me, ma'am?
Senior category 05 is there?
Yes, ma'am.
Yeah, you can start with the presentation. Time is start.
Okay. Good morning, everyone. My topic for the presentation is effect of matrix rhythm therapy in pectoralis minor muscle tightness. Next slide, please. Pectoralis minor muscle is the only scapulothoracic muscles which is originated anteriorly, which is on the anterior aspect, originating from the scapula, from the ribs to the scapula. So the muscle lengthens during the arm elevation along the scapula to rotate it upwardly, externally rotate and tip posteriorly. So the orientation of these pectoralis minor muscle is such that it favors the scapular internal rotation, downward rotation and anterior tipping, and this is considered as an antagonist to the necessary scapular motions during the arm elevation. Thus, during arm elevation in healthy subjects with pectoralis minor tightness has increased internal rotation. So the today's that I'm presenting on the therapy is the matrix rhythm therapy, which works on the principle of micro extension to macro mobilization. Now it is nothing but it is a vibratory rhythm that synchronizes with the cells to improve the quality of extracellular matrix. So the purpose of this study was to see the painless approach during the therapy. As we can see with the traditional therapies, it can include the inflammation when we are trying to overcome the difficulties. Next slide, please. Hello. Please change the slide. Yeah, therefore the matrix therapy, how it works with the physiotherapy. It delivers the rhythmic oscillations between 8 to 12 hertz. Now according to the random Dr. Randall, which he had a experiment, every cell has its own rhythm, which is
Ma'am, there is some network issue from your side. I think your voice is not audible.
Some network issue is there.
From participant side. MSK 05, are you there?
I think there is some issue with participant side network. We'll start with the next presentation. Sorry, judges. Maybe she is having some problem with the network. We'll call her and we'll go for the next presentation.
Yes.
Senior 06 hasn't renamed themselves.
Sorry, Piyush, what happened?
Who's next? Senior 06, right?
Yeah, 06, right.
I'm here. Actually, I couldn't get the time to rename it. There was some confusion before.
Okay, so
I'll be MSK 06.
Yeah.
Okay.
I request
Just wait for a minute.
Yes, sure.
Both the judges, Dr. Chaya ma'am and Dr. Seema ma'am, to make entry in your paper, that is MSK 06 code. Because ma'am, in your print, this code is not written. MSK 06. Chaya ma'am?
Yes, yes, yes. I have already done it.
Seema ma'am?
Yes, yes.
Okay.
Thank you, ma'am. Are you able to see the screen?
Yes. Yeah, this is MSK 06 and not NR 04.
Just a second.
Yeah, you can start the presentation.
Yeah, thank you. Good morning, all. My title for presentation is Impact of Stretching on Limit of Stability of the Young Adults, a comparison between static stretching and PNS stretching techniques. Introduction, next slide. The ability of the body to move the center of gravity voluntarily and maintain balance is fundamental for performing mobility tasks such as body leaning, transition from a seated to standing position, or walking. Limit of stability is defined as the maximum distance an individual is able to or willing to lean in any direction without the loss of balance or changing the base of support. It is known that reduced limit of stability is related to risk of fall or instability during postural activities. Next, muscular control and dynamic maintenance of balance involves the coordination of muscular kinetic chains. Next slide, please. Musculoskeletal responses are selected by the central processing control system and executed by the effector systems to adjust the COG or the base of support. And ankles and hip strategies play a very important role in maintaining this postural stability and preventing stepping and hence reducing the risk of fall. So for small external perturbation that cause a loss of balance in a forward direction, ankle strategy is recruited and the muscle activation usually proceeds in a distal to proximal sequence where calf muscles, specifically gastrocnemius activity, is from 90 to 100 milliseconds after the perturbation onset, followed by the hamstrings. Flexibility of hamstrings and calf muscles thus are a major contributor in exerting the ankle strategies and maintain the postural stability. Proprioceptors in the muscle detect body position and maintain balance, and any change in the activity or length of the muscle will cause reduction in the proprioception activity and hence might affect the balance and the postural stability. Hence, physiotherapy also focuses on improving the postural stability along with the flexibility exercises to the muscles. Although there has been a mixed review on if stretching improves the stability, and if it does, then which technique is better. So the need of study is, next slide. The proprioceptive system is one of the key contributors in maintaining balance, and they exert their influence through ligaments, joints, and muscles specifically via the stretch reflex. Thus, interventions are required to improve the flexibility, and of these interventions, static stretching and PNF are the most commonly used, and both have shown their effectiveness in lengthening or improving the flexibility. But there is a debatable literature which has shown that there might be an improvement in the balance as well as postural stability by giving these two techniques. Hence, the need arises of comparing these two techniques and if there is any effect on of static stretching and PNF on improving the stretching and thereby improving the flexibility and thereby postural stability. Next, the aims and objectives are aim is to compare the effectiveness of static stretching and PNF on limit of stability in the younger adults. To determine the effects of static stretching of objective is to determine the effect of static stretching of hamstrings and calf muscles on the limit of stability in young adults. Next will be the effect of PNF stretching of hams and calf on the limit of stability, and third will be to compare these two effects. Methodology. Study design was to methodology. Study design was a comparative study. Target population is young adults between 18 to 23 years of age with bilateral hamstrings and calf muscle tightness. Simple random sampling was done and the sample size was 30. Inclusion criteria of age group is 18 to 23 years of age with bilateral hamstring tightness measured on active knee extension test, while bilateral calf muscle tightness measured on weight bearing lunge test. Subjects with balance or coordination problem, impaired vision that is not corrected by eyeglasses, recent lower limb injury that could affect balance, and any other diseases which can affect balance were excluded. So the next institutional ethical clearance was obtained and screening of the subjects was done based on the inclusion and exclusion criteria. Those selected were given the written informed consent and were selected into the study. Selected participants were assessed for hamstring tightness on active knee extension test and the calf muscles on weight bearing lunge test. The limit of stability was measured on Neurocom balance master for all the selected participants and recorded as a pre-outcome measure. Participants were then randomly divided into Group A with N is equal to 15 samples treated with static stretching and Group B PNF stretching. So assessment of limit of stability basically consists of a force platform where the subject stands and a target is displayed on the screen where the subject has to reach. So for the present study, readings of the maximum excursion, directional control, endpoint excursion, reaction time and movement velocity of the anterior directions were taken. The static stretching was given to group A, consisting of 4 repetitions of static stretches for the hamstrings and calf muscles, holding at the point of discomfort for 30 seconds each and 20 seconds of rest. And this was given for 6 days per week for 2 weeks. Hold relax was given for the group B. Patient isometrically contracted the affected muscle against the therapist resistance for 10 seconds, followed by relaxation for 5 seconds. The muscle was then lengthened to the new range, and the entire procedure was repeated for 3 times. This was also given for 6 days per week for 2 weeks. Post 2 weeks, each participant was again assessed for limit of stability on the balance master and recorded as post-treatment measure, post-outcome measure. The data was collected and analyzed statistically. So results, the mean age of group A was 22.15 years, while group B was 23.05 years. The graph shows within group analysis for reaction time and movement velocity for group A, where there was a reduction in reaction time and increased movement velocity. Graph 2 shows the within group analysis of, next slide, yeah. This shows the differences within the group A for endpoint excursion, maximum excursion and directional control, which also showed improvement in the group A. Next, showed the results for group B for changes in reaction time and movement velocity, where again there was a reduction in reaction time as well as movement velocity. Next slide, please. Next graph. Next. This shows the within group analysis of group B, where endpoint excursion, maximum excursion and directional control for group B also showed an improvement. Next. Between group comparison when done showed that the group B showed a better reduction in reaction time, and group A showed a decreased movement velocity. Next, between group of endpoint excursion, maximum excursion and directional control comparison showed that group B showed a better endpoint excursion, maximum excursion and directional control after the intervention. Discussion. The purpose of this study was to examine the effects of static stretching and TNF on the limit of stability. As compared to group A, group B showed a better improvement in all the components of LOS for the anterior stability as measured on the balance master. So postural stability or balance relies heavily on the contribution of information from proprioceptive receptors located within the muscles and connective tissue. Since the stretching changes the length of the muscle and tendons, it is possible that either dynamic stretching or static stretching may have an influence on proprioception and therefore balance.
Your time is up.
Yeah.
We should go for the question answer session.
Yeah, thank you so much.
Can I go ahead with the question?
Yes, ma'am. Yes, ma'am.
Yeah. What statistical method did you use for this study?
Ma'am, for within group analysis, we used the Wilcoxon test, and for between group, it was man-Whitney test.
So did you do a normality test?
Yes, ma'am. We found that it was a non-parametric distribution, hence we had to use these.
So why was it non-parametric distribution?
Ma'am,
Data was absolutely in the numbers, no? So why
sorry,
it was
ma'am.
non-parametric? Your data was
Yes,
in absolutely in the numbers, in the discrete numbers. But still you went ahead with the non-parametric test. Why?
ma'am, yes, ma'am. We found that the data was normal, not distributed normally.
So why your data was not distributed normally? Because your age group is between 18 to 23.
23, yeah.
So that means you had a skewed data.
Yes, ma'am, a little bit, yes.
How much? Where was the skewing? It was skewing towards 23 years or towards?
It was skewing towards 22 years, ma'am. 22 to 23 years.
Okay, so what was your sample size?
30. Total sample size was 30 divided into 15 and 15.
Yeah, so that means your study has a limitation.
Limitation, yes, ma'am. I had
right
put
from
it
the
actually.
beginning, in the planning.
Okay. Okay.
Okay.
Yes.
Okay. Okay. I'm done with it.
Thank
Dr.
you.
Seema,
You are saying limit of stability. I think you should give a operational definition for limit of stability, stating the center of mass, center of gravity, and the base of support. This is one thing. And
Yes, ma'am.
other, if we come on to your statistical analysis,
Yes, ma'am.
for your EP, MXC, and DCL, I think you have used Wilcoxon only, right? Again, that parametric and non-parametric is a issue.
Yes,
And
ma'am.
you could have done, if you're taking like more than two variables, I think the better statistical analysis would be the ANOVA test, one-way ANOVA, or
Okay.
depending upon the your parametric and non-parametric.
Non-parametric. Okay.
So,
Okay, ma'am.
I'm done with the question.
Thank you so much, ma'am.
Okay.
Thank you,
Okay,
Preeti.
judges. Actually, we are this senior code number 05. We are going to take presentation after junior category as she is having some technical problem. So we are going to start with MSK 01 junior category. 01,
Yes, ma'am.
please start.
Yes, ma'am. Ma'am, will you just play the
Yeah, yeah.
PPT? Yeah. Okay. Good morning, everyone. My research topic is effect of induced muscular fatigue on balance and core strength in male volleyball players. Next slide. Next slide, please, ma'am. Hello. Hello.
Yes,
No,
yes.
ma'am. The previous one. Previous slide, ma'am.
Is it
Okay. Yes, ma'am. Volleyball is a sport that is relatively played in the small field by performing repetitive fast movements and the high vertical jumping. According to the survey conducted, 58% of the players were in the age group of 22 to 25 years. The most common injuries that was susceptible during the match were while performing spiking, blocking, diving, and the setting. Next slide, please. So the question arises, what is fatigue and how does it affect one's performance? So fatigue is during the maximum contraction of many mixed muscles, it is common to see 50% reduction of the force over a period of a few seconds, which is known as fatigue. It also refers to both physical and the mental exhaustion during a prolonged stimulation or exertion. Fatigue can also alter the proprioceptive kinesthetic properties of joint by increasing joint laxity and causing the sensorimotor biomechanical deficit such as decreased muscle strength and decreasing the neuromuscular contraction and which leads to the increase for the injuries. The next question arises, what is a dynamic balance and it's important during the match. So dynamic balance is important when demonstrating a skill in the complex movement for high sporting performance. So what is the importance of core muscles in the match? That is, the core refers to the lumbopelvic hip complex where the center of the gravity is located. Deficiency in the core strength lead to the predisposing athletes for the injury. Next slide. So the need for study, various studies has been shown that there is a close relationship between the unbalance and the lower body injuries in volleyball players. The relationship between the fatigue and the balance in athlete is poorly understood. Therefore, the purpose of this study is to assess if the fatigue has an immediate effect on balance, core strength in volleyball players by checking its static and dynamic stability and core muscle strength for spinal stability. Next slide. So research question arises, will immediate induced fatigue will have an effect on static balance, dynamic balance, and also on lumbar core strength in male volleyball players? Next slide, please. The aim of the the aim and the objectives are: aim to find out the effect of induced muscular fatigue on balance and core strength in male volleyball players. There were three objectives: to evaluate the effect of induced muscular fatigue on static balance in male volleyball players, and to evaluate the effect of induced muscular fatigue on dynamic balance in male volleyball players. The third was to evaluate the effect of induced muscular fatigue on core strength in male volleyball players. Next. The methodology was: the study design was experimental. Study samples were 20 males. Type of sampling was convenient sampling. Inclusion criteria: only male were included in the study. Age group between 18 to 25 years. District level volleyball players were included. Players with a minimum of 3 years of experience were included in the study. Also, the player who has not performed high intensity exercise before 2 days were included in the study. Players with the any pathological condition were excluded from the study. Musculoskeletal injuries were excluded from the study. Next slide. So the moving on to the procedure. The study was carried out on the district level volleyball players. Study approval was obtained from the institutional ethical board and informed consent was obtained from all the players. 20 male volleyball players were included in the study. They were tested twice during the same session. And for single leg stance, and the subjects were asked to perform single leg stance barefoot with the dominant leg on a firm surface. The dominant leg was found by using the ball kick test. The instruction was given to keep both the knees apart, not to touch hands to the body, and to look straight and focus on the object at a distance of 1 meter. The balance was recorded until the subject could not maintain the above mentioned position. For functional reach test, the subjects were asked to reach as far as possible from the comfortable standing posture without taking a step, losing a balance, or lifting a heel. The first point of the tip of middle finger on the wall was marked. The subject has to maintain the position for 3 seconds. And again, we have to measure the tip of the middle finger. The distance between first and the second point was recorded. And for the core strength, it was measured by using the pressure biofeedback method using aneroid sphygmomanometer. The subject was in the crook lying with the cuff placed under the lumbar spine area, and it was inflamed to 40 mm of Sg. The subject were asked to activate core or to tuck in
Your
and
time
maintain
is going to get over in a minute.
To maintain it between, okay ma'am, to maintain it between 40 to 50 mm of Sg for 10 seconds. If the subjects were not able to maintain it for 10 seconds, the rest was given for 3 minutes and asked to hold again at the lower value for 10 seconds. The muscular fatigue was induced by performing the squatting. The rate of perceived existence scale was used, that is a modified box scale with the 10 by 10, which is extremely strong. The subjects were instructed to squat as if sitting on the chair in which the tibia remains relatively vertical. After this, the immediate single leg stance, functional reach and core muscle testing was repeated.
01, your
Okay,
time.
ma'am.
Go for questions.
Okay, ma'am.
Dr. Seema, ma'am.
Yes. Chaya ma'am, can I ask first?
Yes, please go ahead.
See, your title states induced muscular fatigue, which
Yes,
I
ma'am.
did not understand from the study. What do you understand by induced muscular fatigue? Because that part was, I could not see in your study.
Ma'am, we have to induce fatigue. The fatigue was induced using the subject's its own body weight by performing the squatting, repetitive squatting. So the for that we have to we have used the perception rate of perception scale uh, by 10 on 10, that is modified rate of perception, modified box scale. uh, After performing the squatting, as the patient as the subjects were exhausted, the post reading were taken. like single leg stance, functional reach, and lumbar core strength.
Okay, the second question
Yeah.
is you have used what functional reach test for dynamic balance, right?
Yes, ma'am.
Why
Yeah.
not use the star excursion test, which is more specific for dynamic balance?
Yes, ma'am. Uh, the star exclusion test was the study was done earlier, so that the this which I have used, the functional range test, was not used in the volleyball players, so I have included in this study.
No, I think for outcome measures, you have to go with the psychometric property, then what is being used and what is not being used.
Oh, okay, ma'am.
Yeah, thank you. Ma'am, you can please proceed.
Yes, I think my question is also the same. What is the immediate induced fatigue, which I think Seema ma'am has already asked you. My
Yes,
other
ma'am.
question is why only male volleyball players were taken? Why females were not taken?
Ma'am, male, because the area which I was doing the study were mostly the male, where I was able to found the male players, so it was
That
available,
means
means
your
they were
research,
easily available.
yeah,
Yeah.
your research is research specific. That means you
Yeah.
have taken only males, and that too also from your area with limitations of only sample, because it's a convenient sampling. So that means the study is
Yes.
planned according to the convenience of the researcher. That is what the take-home message is from this study. And second question is,
Yes,
high
ma'am.
intensity exercises were not given to this patient prior to your study.
Yes, ma'am.
Knowing them as they are district level players, how can you
Yeah.
tell them not to do these exercises 2 days prior to your study?
Ma'am, actually, the informed consent was taken prior uh, to while before the testing. So I have asked. I was taken the. I took the informed consent prior the testing. So I asked them to not to, means, practice or to perform high intensity before 2 days.
Actually, it is unethical, no? You are telling the
Okay.
district level champions and district level players not to do high intensity exercises, which is a part and parcel of their training program. Okay?
Okay, ma'am. Okay, ma'am.
I'm done with the
Yes.
queries.
Okay. Thank you.
Thank you.
Yes.
Yes,
MSP 02, now please start your presentation.
Yes. Good morning, ma'am and sir. My topic for presentation is correlation of scapular position in sitting and standing in healthy males aged between 19 to 35 years. Next slide, please. Introduction. The position of the scapula is the key contributor to normal and abnormal scapular motion and control. Normally, the scapula rests at a position on posterior thorax, approximately 2 inches from the midline between the second and seventh ribs. The scapula function as a bridge between the shoulder complex and cervical spine and plays a very important role in providing both mobility as well as the stability of neck and shoulder region. There is a significant relationship present in the muscle contraction abilities in shoulder region and the position of the scapula. Next slide, please. Standing is known to induce greater lumbar lordosis compared with sitting in a healthy population. Sitting can slightly increases the thoracic kyphosis compared with standing. For the muscle balance, scapular position is very most important. Scapular protraction is defined as the abnormal position, which defined as the increased distance between the inferior angle of scapula to the adjacent spinous process of the vertebra. Standing is known to increase greater lumbar lordosis compared with sitting in healthy population. Sitting can slightly increase the thoracic kyphosis compared with standing. Next slide. Methodology. Descriptive observational cross-sectional study is the study design. Target population was where the healthy males aged between 90 to 35 years. Sample size is 107 and study duration is 1 year for synopsis and 6 months for data collection. Next slide. Inclusion criteria. Healthy male asymptomatic individuals are selected for the studies. Age between 90 to 35 years. Person who are willing to participate. Exclusion criteria are any recent shoulder spinal injuries and surgeries, fracture around the proximity of the shoulder, congenital deformity of the scapula, pharyngeal deformity, cervical radiculopathy, any neuromuscular disease disorder of the scapula, brachial plexus injury, and a mentally disabled person. Next slide. Next slide, please. This is the flowchart of the procedure. Study protocol is prepared. Informed written consent will be taken from the order participant subjects. Procedure is explained. Subject will be assessed for the outcome measure, that is scapular position in sitting as well as standing position. Data will be collected statistically and analyzed, and final result will be obtained. Next slide. The procedure, the scapula position is measured with the help of vernier caliper from the inferior angle of scapula to the adjacent spinous vertebra in three different hand positions. The three different hand positions are hand in rest, hand on hip, and hand in 90 degree of abduction and internal rotation. The scapular position will be measured in sitting as well as in standing position in all three positions of the hand. Next slide, please. The hand in rest. For this position, the participants are instructed to keep the hand relaxed at their side. Similarly, and hand on hip, the position, this participant are instructed to place both hand on ipsilateral, that is same side of the hip, and consequently the humerus were positioned in medial rotation at 45 degree in abduction coronal plane. Next slide. Third is the hand in 90 degree of abduction with internal rotation. For this position, the participant is instructed to actively elbow extension and to elevate the arm and internally rotate both the upper extremity in 90 degrees in coronal plane. Next slide. The result, table number 1 shows that the comparison scapular position and in right and left side in standing position. That is the in standing position, arm on rest on left and right side, there was no significant difference are observed, and hand on hip similarly left and right side, no significant difference is observed, and similarly on hand in 90 degree of abduction and internal rotation on left and right side, no significant difference is observed. Table number 2 showing that the comparison scapular position in right and left side in sitting position. In table 2, we are talking about the sitting position. Sitting position, arm on rest position, right and left side, there is no significant relationship. Hand on hip, right and left side, similarly, there is no significant relationship. And similarly, on hand in 90 degree of abduction and internal rotation, no significant difference is observed. Next slide. Table number 3 showing that the comparison and correlation of scapular position in sitting and standing for right side. Right side, arm on rest in standing and sitting position, both were measured, and the p-value is not significant. And hand on hip for standing and sitting on right side is measured, and there is no significant difference is observed. And similarly on hand in 90 degree abduction and internal rotation, no significant difference is observed. Table number 4 showing that the comparison and correlation of scapular position in sitting and standing for left side. Table number 3 showing the right side, and table number 4 shows the left side of the positions. Left side, arm on rest position, there is no significant difference. Arm on hip and arm in 90 degree of abduction and internal rotation, no significant difference is observed. Next slide. Scapula actually has a no backbone.
1 minute left for your presentation.
Yes, bony articulation with the thorax, which allows the tremendous mobility of the scapula. Spine is also not attached to the scapula, therefore providing scapula to function independently to perform variety of movements. Standing is known to induce greater lumbar lordosis compared with sitting in healthy population. Sitting can increase thoracic hypothesis compared with standing population. But present study, ideal sitting was taken as an assessment of scapular position. Previous study by Linda McKenna and Xavier Conwell concludes that the body posture had no effect on scapular orientation at 120 degree, indicating the body posture may be more important at rest but not in neutral sitting position. Next, conclusion, the present study concludes that the measurement of the scapula can be done in either ideal sitting or standing position, 90 to 35 years of males. Limitation, all the males individuals are studied, selected for the study. Age considered as 1935 years, small sample size. Future scope, the scapular position can be correlated to individual with rounded shoulder. Scapular position can also be correlated to individual with forward head posture. Study can be done with different age group. Future study can be done including both genders. Future studies can be done with larger sample sizes. These were my references. Thank you.
Okay.
Yes, Dr. Seema, you can go ahead with the question.
Yes. Can you please tell me the clinical significance of your study?
Yes, ma'am. Ma'am, the present study concludes that the measurement of the scapula can be done in either sitting as well as standing position. In healthy males, 19 to 35 years of male, Normally the scapular position measured in standing position, but in my studies, I have found that there is no difference in scapular position in sitting and standing position in three different arm position. That is arm on wrist, arm on hip, and arm on 90-degree abduction, internal rotation.
Yeah,
So,
I understand you have done a lateral slide test, which has a very weak inter and intra reliability.
okay.
So, I think the study could be better, but
Okay,
I am done.
I have 2-3 questions for you, sir.
Yes, ma'am.
You have said that this is a descriptive observational cross-sectional study.
Yes, ma'am.
Why so many adjectives to this study? You could have said only cross-sectional study.
Yes, ma'am.
No?
Ma'am, yes, ma'am. Cross-sectional study is used for that.
It's a usually cross-sectional
Yes, ma'am.
studies
Yes,
can
ma'am.
be observational, no? Why
Yes,
descriptive
ma'am.
observational cross-sectional study? Okay,
Ma'am,
that
because
was the
this is in this was we have to describe the different positions and all that.
So descriptive study is not the describing the positions. Descriptive study relates to your statistics.
Okay, ma'am. Yes,
It's a descriptive analysis.
okay, ma'am.
Okay, and you have included the people between the age group of 19 to
19 to
35.
35.
Why between 18 to 19 were excluded?
Ma'am, due to the fact that they are pediatric population can be added because of this.
No. 18 to 19 is not a pediatric population. 18 above
Yes,
is
ma'am. Yes,
adult
ma'am. Yes, ma'am.
population. Okay, and your flowchart says will be taken. That means you are not taken any pains in correcting your slides. Your study has already been done.
Yes, ma'am.
Yeah, so how can you use the word as a will be taken for the future study? Your flowchart says it's in the future tense.
Okay, ma'am.
No?
Yes.
Yeah, I'm done with the question.
Okay, 03. Start your presentation. 03. Participant number 03, are you there? Please unmute yourself.
Hello.
Yes, 03.
Good morning. My title for today's presentation is Effectiveness of Anthropometry and Kinovia in Measuring Cervical Range of Motion. Introduction. The study was carried out to investigate the accuracy of Kinovia computer program using the anthropometry in calculating the extent of cervical motion relative to cervical range of motion. Due to pain or a neck spasm, cervical movement may be restricted. Aims and objective of study. The purpose of study is to determine the simultaneous validity and reliability of Kinovia method for measuring the dominant cervical joint range of motion in healthy population compared to anthropometry. Methodology, study type, comparative study, simple random sampling size, 30 healthy individual, both male and female, age group from 18 to 25 years. Material required consent from Kinovia computer program and anthropometry. Procedure, measurement procedure. Each subject was sitting and standing on a stool close to the wall while maintaining good upright balance posture with both feet on floor with normal lumbar lordosis, hands on thigh and 90-degree in hip and knee joint. Each subject was required to assume a natural head position with purpose of positioning and the head centers of mass in a vertical plane through the atlanto-occipital joint, while the nose pointing forward in a line with a sternum and belly button. Each subject was given full explanation, verbal instruction concerning the purpose and procedure of the study. The digital camera was steady to record the movement before the start of the measurement. Measuring cervical side bending range of motion using Kinovia computer program. Sternal notch is the axis of the angle between two lines. The first is line segment between the sternal notch marker and the forehead marker. The second is the vertical line on the sternal notch marker. Cervical side bending movement were done on left and right side. The position of each marker was indicated with a washable ink pen for accurate replacement Then the marker was glued on the ink pen. The examiner was sitting behind the camera taking the video. The examiner asked the patient to do lateral flexion on the right side, then hold it for 5 seconds at the end of the range. An examiner asked the participant to return it to the neutral position. From neutral, then participant will do lateral flexion to the left side and hold it for again 5 seconds at the end of the range. The procedure was repeated 3 times to get the mean average. Cervical active range of motion was calculated as angular displacement from neutral to right side and from neutral to left side in frontal plane for side bending. The examiner recorded the measured angle after doing the Kinovia computer program measurement analysis of each video for each participant using Kinovia computer program. Measuring cervical side bending range of motion using the anthropometry device, each participant was seated in the standard 4-leg chair and a back should be supported. The examiner stood in front of the participant and offered instructions. The measuring tape was placed on the mastoid process on the lateral tip of the acromial process. The examiner asked the participant to start from the neutral position. The neutral position, the examiner asked the participant to do lateral flexion on the right side and hold it for 5 seconds at the end range and return to the neutral position. Then examiner asked the participant to do lateral flexion on the left side and hold it for 5 seconds at the end range of motion. The examiner manually adjusts the participant's neck after assuming the neutral position. Each participant bent his or her head right and left without elevating his or her shoulder. The examiner asked the participant to return to the neutral position. Analysis the range of motion using kind of a computer program as follows. The examiner connect the camera with the laptop in which the kind of a computer program was installed. The examiner apply the analysis for the each cervical active range of movement measurement in frontal plane. The procedure was repeated 3 times. Then the mean average of the measured angle using kind of a computer program were recorded. The analysis of each participant were saved on computer in a separate file. Here is the image. First image is showing use of computer kind of a program. First image is neutral head position and ask the participant to do lateral bending and hold it for 5 seconds and again back to the neutral position and then do right side bending. And in second image, anthropometry is used. Then result the correlation analysis between the cervical right and left side bending measured angle using kind of a computer program and cervical range of motion showed that the two measurement had a strong positive correlations. Conclusion, the software program Kinovia has been a valid method for measuring active cervical range of motion in clinical setting and can be used as one of a diagnostic tool. Thank you.
Dr. Seema, ma'am?
Yes. What was your sample size? I think it's 30, right?
Yeah, it's 30.
Yeah. So for a validation study, can you please tell me what is the minimum sample size requirement?
Sorry, ma'am.
For a validation study, reliability and validity, you were trying to find out, right?
Yep.
So what is the minimum sample size requirement?
Ma'am, it's 30 and both are male, female, and age group is from 18 to
No,
25.
that is your study, but that is not the minimum requirement for the validation study. Yours was a healthy subjects, right?
Yeah, it's a healthy subject.
So why you have taken only 30 sample size? My next question is, have you checked the test, retest, reliability, inter-intra-rater reliability?
Yes, ma'am, I checked that test pre and post.
You have checked test, retest, reliability?
Yes, ma'am.
Yeah. Dr. Seema, can I go ahead with
Yes,
the
yes,
question?
yes.
Yeah.
Sure.
As Dr. Seema has rightly pointed out, madam, you have checked validity and reliability of this Kinovia computer program. So there has to be an inter-tester and intra-tester reliability, which is not predicted in your statistical analysis. Secondly, the validity is also not been checked with the gold standard. What is the gold standard have you used to correlate your validity of this new instrument, which is not obviously seen in your statistics and methodology? Are you there, participant number 3?
Yes, ma'am, I'm there.
Yeah. Secondly, your methodology is very deep and intent. The pictures have to be absolutely good to explain us exactly what methodology have you used, which were not predicted in your PPT presentation.
Okay.
Okay. And the third query of mine is this Kinovia computer program very easily available and without any freely available, or do you
Yes,
have to
ma'am,
pay
it's
for it?
free. No, ma'am, it's free of cost. We don't have to pay for that.
So
We can
do you,
install it in our laptop.
did you take any permission to use this program?
No, ma'am, we don't need to take any permission to use this app. It's
Okay. Okay. I'm done with the questions.
Okay, thank you, ma'am. Actually, code 04, participant 04 PPT is not getting opened because of some technical issue. So I request code number 05, please start your presentation.
Good morning, respected dignitaries. I am presenting my paper on physiotherapy rehabilitation for a post-operative case of distal femur fracture. So, as we know, fractures are defined as break in the continuity of the bone. Here we are going to discuss about distal femur fractures. So, distal femur fractures are the fractures of the thigh bone that occur just above the knee joint. Distal femur fractures vary. The bone can break straight across, that is a transverse fracture, or it can break into multiple pieces, which is a comminuted fracture. This is a case of comminuted fracture. Next slide, please. Femoral shaft fractures are serious injuries. Next slide. Femoral shaft fractures are serious injuries which can cause disabilities requiring critical examination and appropriate treatment methods. As most of these injuries are caused due to trauma, these require intensive surgical care. As a result, soft tissue pathology is normal. Both the hamstrings and quadriceps muscles begin to contract and shorten when distal femur breaks. Impairments and functional limitations, however, frequently persist following the injury and a surgical procedure long after adequate bone healing is demonstrated radiographically. Patient information. Patient was a 19-year-old medical student that presented to physiotherapy department with a complaint of pain in left knee joint while stair climbing, along with restricted range of motion during knee extension. He had a history of road traffic accident 1 year back and was operated for distal one-third femur fracture. Fracture was classified as high velocity comminuted fracture. It was surgically reduced by side plating and nailing. 10 days after the surgery, patient started receiving physiotherapy and performed knee range of motion using continuous passive movements. Then, after 3 months, the plate which was surgically placed broke and the patient had to undergo another surgery in which intramedullary plating with supporting nails was done. After this surgery, patient started physiotherapy in 6 days at a private clinic. When patient came to us, his clinical findings were: first, pain. Pain was assessed using numerical pain rating scale. Patient rated the pain as a 6 on a scale of 1 to 10, where 1 was the least and 10 was the highest pain. It was pinprick type in sensation and it was felt over the center of patella while walking and stair climbing. The pain was caused due to tightness of rectus femoris muscle. Active range of motion. Here we can observe that active range of the affected knee joint is reduced in both flexion and extension. Next slide. Manual muscle testing, strength of muscles were checked and there was significant reduced strength in knee joint extensors and flexors were grade 4. Tightness and weakness. Severe tightness of quadriceps muscles and hamstrings were found in left leg. In quadriceps, the most tightened muscle was rectus femoris and weakness was found in vastus medialis, which resulted in extension lag in left knee joint as well as the pain the patient complained of. Radiological findings. This is the X-ray image which was taken at the time of the accident. And next slide. This is the X-ray after the surgical reduction of fracture by intramedullary plating and supporting nails. intervention, patient visited the physiotherapy department since 10 days, and each day consisted of one session for 45 minutes. The goals of treatment were to provide effective quadricep mechanism, to release the tightness in quadriceps and hamstring, to increase the strength of vastus medialis muscle, to reduce pain over the center of patella while stair climbing, to regain maximum possible range of motion in flexion and extension of knee joint. Mobilization. Manual mobilization was given. Anterior tibial glide for increasing knee extension. Posterior tibial glide for increasing knee flexion. Mulligan was also given for increasing knee range of motion. Anterior glide using a Mulligan belt. Stretching. Stretching exercise for quadriceps and hamstrings were given for releasing the tightened muscle along with myofascial release. Patient was also advised to perform self-stretching of quadriceps at home. Strengthening exercises included resisted exercises using a weight cuff of 1 kg. Patient was asked to perform knee range of motion using weight cuff, that is against the resistance of the cuff to increase the muscle strength. Active knee joint exercises. Patient was taught how to perform supported squatting and was advised to perform the same at home for at least 15 repetitions. Outcomes. Following are the clinical findings on the 10th day of the treatment. Active range of motion. There is we can notice that the knee range, flexion and extension were increased. Manual muscle testing. There was not much difference in muscle testing as the treatment was given only for 10 days. Tightness in hamstrings was released by myofascial release. Quadriceps tightness was released using stretching techniques, and stretching was done manually by the therapist in physiotherapy sessions, and patient performed self-stretching at home as well. After 10 days of physiotherapy, patient had no complaints of pain. The range of motion in flexion and extension was increased, and tightness of the muscle was released. It was observed that the patient experienced major relief in hamstring tightness after the application of myofascial release techniques. Mobilization techniques used for increasing the knee range was observed to be effective in increasing the range as well as reducing the pain. Discussion. In younger patients, distal femur fractures are typically caused by high energy injuries such as fall from great heights or due to road traffic accidents. The procedure used to treat femur fractures can differ, and after initial rehabilitation, it is often important to regain full range of motion and mobility to help patient to return to all the normal activities. Complications including chronic pain, inflammation, and weakness can create difficulty in walking, stair climbing, or doing activities without any appropriate rehabilitation. These are my references. Thank you.
Dr. Chaya ma'am.
Yes. I have two questions for you.
Yes, ma'am.
You said that the intramedullary nailing was done, but actually it is a plating which has been seen over here. Because there is a difference between the intramedullary nail and the pin and plate. Because there is something called as a load sharing mechanism and load bearing mechanism in the internal fixation of fractures of the lower limb.
Okay.
Am I right? Am I right?
Yes, ma'am.
Yeah. So there the pictures what you showed in PPT had a plating with the screws.
He underwent 2 surgeries, and that one was the photo I showed was of the first surgery. He did not have the X-rays of second when we were doing.
And when did he come to you after surgery, second surgery?
After second surgery, he came to us after 6 months. His surgery was done in June, and he came to us in January.
That means the tissue healing had already taken place by the secondary fibrosis.
Yes.
And you got results within 10 days of post physiotherapy?
We did not get increase in muscle strength, but his tightness was released. He was a young student and he was active, so it was easy for us to get the result, and he was very cooperative. He came daily for the therapy sessions, and as well as he practiced it at home also.
Okay, my third question is strengthening was given with a 1 kg weight. Did you calculate his 1 repetition maximum being a young guy?
No, we did not calculate it at first because he was in pain while doing the action. Therefore, we started basic 1 kg weight.
That is not a limitation to calculate the 1 RM because he was a young guy and he came to you after 6 months post surgery.
Yes.
Okay, I'm done with my questions.
Thank
Dr. Seema? Yeah.
Yes. What all types of mobilization you have used other than Mulligan mobilization?
No, we just gave him normal manual mobilization and Mulligan.
Which manual mobilization Manual mobilization means what?
Mobilizing the joints to increase the range.
Yeah, so which type? Like Maitland, Carlton bone, celiacs, which
Maitland.
and which grade you have given?
Uh, for second grade. First.
So grade 2 you have given.
Yeah.
For 10 days.
Yeah, 10 days.
And grade 2 will not improve the range, right?
End range के लिए we have given him for end range. Now he had extension lacked, so for that we gave him the mobilization.
Thank you.
Okay, 06.
Yes, ma'am.
Please start.
Okay. Good morning, everyone. My topic for the presentation is efficacy of cryotherapy versus conventional tests in reducing pain levels in exercise-induced delayed onset muscle soreness in normal individuals. Next, please. Next, please. Introduction. Following an extended layoff from exercise, most people experience soreness in exercised muscle. Temporary soreness may persist for several hours immediately after unaccustomed exercise, whereas residual delayed onset muscle soreness appear late and can last for 7 days. Definition. Delayed onset muscle soreness is a muscular pain or discomfort that follows physical activity, usually eccentric to which an individual is not accustomed. That means the activity greater than the normal individual activity. Clinical features seen in DOMS are pain, tenderness, residual swelling, stiffness, inflammation, and soreness. Other symptoms include decreased range of motion and muscle strength. Next, please. Pain gate mechanism. Pain perception is regulated by a gate which can be open and closed by other input from central and peripheral nervous system. The nociceptive infrastructure is then carried by small diameter C fibers and A delta fibers to substantia gelatinosa and nucleus pulchris, from where it is carried to cortex via midbrain. A delta fibers have collateral to periaqueductal gray matter in midbrain, which activates the descending pain suppression pathway, which releases enkephalin to suppress pain in substantia gelatinosa. Need for study. DOMS is a common problem seen in athletes and even normal people following unaccustomed work. Pain and reduction in performance may interfere with day-to-day activities, so treatment is required, which will reduce pain in minimum time limit. DOMS is widely recognized and yet controversial injury phenomena, both in terms of origin, cause of injury, and treatment. The purpose of the study is to know the difference of outcome of cryotherapy versus TENS in reducing pain. Aims and objective. First aim is to evaluate reduction of pain after giving cryotherapy. Second is to evaluate reduction of pain after giving TENS. And third is to find whether cryotherapy or conventional TENS is more effective in reducing the pain level in DOMS. Methodology and material. Study setting. Physiotherapy department of our college. Study design, experimental and comparative study. Participant, non-symptomatic individual. Sampling technique, simple randomized technique. Sampling method, envelope method, sampling size 60, study duration 1 year, materials, visual analog scale, ice pack, conventional TENS machine, and weights of 2 kg. Methodology, study method, 60 subjects were selected based on inclusion and exclusion criteria. 30 subjects were assigned in group A and 30 to group B. Inclusion criteria, normal subjects with no biceps pain previously. Subjects between the age group of 16 to 20 years of age. Exclusion criteria, bicipital tendinitis, any previous pain in bicep muscle, any sensory loss, myofascial syndrome, and fibromyalgia. Procedure. Ethical clearance was obtained from Institutional Ethical Committee. Participants were explained about the procedure and informed consent was taken. They were randomly allocated in group A and B. Experimental and comparative study was conducted. DOMS was experimentally induced in biceps brachii muscle unilaterally by flexing and extending elbow for 20 times, lifting 2 kg weight. Visual analog scale was used to record the level of pain. Readings on bar scale was taken 4 times, that is before exercise, immediately after exercise, after 24 to 48 hours of exercise, and after treatment. Next, please. Ma'am, next. Treatment was given according to
following protocol for each group after 48 hours after experimentally induced DOMS. Technique. Group A. Patient seated on chair with elbow in complete extension. Ice cube massage given for 15 minutes each treatment session for bicep brachii muscle. Group B. Patient lying or sitting with elbow in complete extension. Apply conventional TENS for 15 minutes over biceps brachii muscle. Duration of treatment. Both were given for 15 minutes, one session per day. Results. Statistical analysis was done by using descriptive and inferential statistical using student paired and unpaired t-test. Software used in analysis was SPSS 22.0 version and P less than 0.05 is considered as a level of significance. Results. This study showed statistically significant reduction in pain level is in both experimental groups. This graph depicts comparison of pain on VAS in cryotherapy group with baseline using student paired t-test. Next. Table 2 showed comparison of pain on VAS in TENS group with baseline. By using student paired t-test, statistically significant difference was found in pain on VAS score after exercise, after 24 to 48 hours of exercise, and after treatment. Table 3 shows comparison of pain on VAS in cryotherapy and TENS group using student unpaired t-test. So statistically difference was found in pain in both the groups. Discussion. Next. After a prolonged layoff from exercise, most people experience soreness in exercise muscle. DOMS occur 24 to 48 hours after exercise is very common problem among affecting the daily functional activity. Therefore, it is essential to relieve pain effectively and quickly. In this study, 60 normal healthy students were randomly selected and they were divided into group A and B. DOMS was experimentally induced in them and treatment was given. Data was collected using VAS scale.
The time is going to get over within a minute.
Yes, ma'am. Statistical analysis was done and t-test showed 90% of significance. Both groups showed significant statistical difference in reduction of pain. Hence, TENS is more effective than cryotherapy in reduction of pain. Possible mechanism of pain relief. TENS can directly block C fibers carrying the tissue damage pain, thus closing the pain gate in DOMS, whereas ice fails to block C fibers as they can continue to conduct at very low temperature. Cryotherapy can reduce pain effectively in initial hours of injury, reducing metabolic rate and hence secondary cell necrosis. Thus, it will not be much effective in reducing pain level in DOMS, which usually occurs after 24 to 48 hours of exercise. Conclusion. This study showed that both modalities reduce pain effectively, but TENS is more effective than cryotherapy in reducing pain. These are my references. Thank you.
Can I go ahead with the questions?
Yes, ma'am.
Yes. What was the clinical application of your study?
Clinical application, ma'am, cryotherapy and TENS was used for treatment.
So don't you know that this is the age-old proven thing that the cryotherapy and TNS, both of them are used for the DOMS?
Ma'am, they are used, but we from the study will be comparing both the modalities, that which is more effective.
There is so much of literature available to compare these two methods. This is a one thing. So there was nothing new in giving the clinical application of this study. That is what I think. And second, my query was, ethically, is it right to induce the muscle soreness or fatigue in the healthy individuals when they don't have any other complaint?
Ma'am, prior consent and was taken from those individuals.
No, agreed. Consent has to be taken. But is it ethically right to induce the muscle soreness or the fatigue in the people who are already healthy? You could have taken the patients with the pain, no?
Yes, ma'am.
This is what I think. Ethically, it was not right to induce fatigue in the healthy individuals.
Yes, ma'am.
Okay? Yeah. I'm done with my questions, Dr. Seema.
Yes, I totally agree with what ma'am said, that it's ethically not right to induce a pain in the population. Secondly, if you have given the cryo and TENS after 48 hours, what if your sample is complain of pain after 24 hours? So did you give anything to them?
Ma'am, in initial hour, no, ma'am, we didn't give anything.
You did not give?
No.
So that is again an ethical issue. Secondly, in your study, you have mentioned that for pain outcome measure you have used VAS, but
Yes, ma'am.
the scale that you have shown is NPRS. So the VAS is different and NPRS is different. I think you need to correct whether you have used a VAS or you have used a NPRS. I'm done. Thank you.
Okay, ma'am. Thank you.
MSK 07 junior category presentation is scheduled. MSK 07, are you there? Junior category MSK, can you please unmute? Piyush, can you please unmute 07?
07 has not renamed. I'm trying to look for him. Or
Piyush, I will message you the name.
yeah, please.
Yeah. Piyush, I have messaged you. WhatsApp
Okay, I
you.
got it. In one moment. Okay. 07, please unmute. Yeah.
07, are you there?
Yes, am I audible?
Yeah, you can start the presentation.
Okay, thank you. My presentation is a physiotherapy approach to post-sequestrectomy rehabilitation in an adolescent female, a case report. When a pyogenic infection of the bone causes avascular necrosis, it can result in osteomyelitis. The infection can be due to bacteria such as Staphylococcus aureus, etc. Body infections that include the bones and joints are generally very irritable to the patients and doctors treating them. In this case, the right tibia was affected, and sequestrectomy was carried out with an application of an Elizarov fixator. After this, physiotherapy was initiated as multidisciplinary approaches are generally required from before the operation to the end of the rehabilitation program. The physiotherapy sessions are designed based on the individuality of each patient. Next slide. The patient was a 13-year-old female who had undergone the sequestrectomy for chronic myelitis on her right tibia. Her chief complaints included pain over the right leg due to the surgery, a decreased strength in her lower limbs and the whole body, quickly getting fatigued, and being dependent on others to do any activity at all. Next slide. On the 5th of May 2019, the patient was playing when she fell and got injured. Her wound was painful and swollen, and there was pus formation. She then went to a government hospital where drainage and antibiotic beading application was done. This was done on the 11th, and its removal was done on the 28th of May 2019. For further management, she was brought to our hospital on the 22nd of June, and the x-rays were done and showed a fractured tibia with chronic osteomyelitis. The sequestrectomy was done on the 27th of June, and the physiotherapy sessions were begun the next day and continued until the day of the discharge, which was the 21st of July. Next slide, please. Upon evaluation, there was a reduced range of motion in the right limb. The patient reported a pain grade of 7 on the numerical pain rating scale. There was no swelling upon observation and palpation, and there was the presence of tenderness grade 2. Previous slide, please. Upon limb length measurements, the right limb was 2 inches longer. Next slide. These are the x-rays that were taken before and after the surgery. The one on the left shows the affected area, and the one on the right shows the placement of the Elizarov fixator. We can clearly see the fractured bone in the image on the left. Next, please. The treatment protocol began in the first week itself. Muscle setting exercises were prescribed that included static isometric exercises along with ankle pumps and toe curls, toe stretches, and when at rest, the ankle was kept in a neutral position. The exercise sessions were conducted twice a day. By the second week, more energy requiring activities were begun, and that included active assisted heel slides, hip flexion, and abduction movements. Dynamic quadriceps and previous slide, please. And VMO strengthening was also done along with passive and active stretches. These were also done twice in a day. Next slide, please. By the middle of the second week, the patient felt stronger and resistant exercises were prescribed, specifically for the lower limb. Care was given to ensure that the patient did not overwork herself. In the fourth week, ambulatory training was begun using a walker. Appropriate footwear was prescribed to level out the limbs to ease the walking and independent activities. Next slide, please. In the table, we see that overall, the patient showed an impressive improvement in the muscle strength, specifically hip flexion, progressing from grade 1 to 4 out of 5 as seen in the red. The blue showed an improvement in the knee flexion from grade 0 to grade 4 out of 5 after the sessions. Green shows the improvement in the strength of the plantar and dorsiflexors on the right side from grade 3 to grade 4. Overall, there were muscle strength improvements by the end of the physiotherapy sessions. Next slide, please. The active ranges of motion of the lower limb is seen in this table. The right side showing an improvement significantly the hip flexion from 39 degrees to an astounding 118 degrees as seen in the red color. As seen in green, the ankle dorsiflexion was also significantly improved from 7 degrees to 12 degrees. Next slide, please. The passive ranges of motions were obviously also improved. Specifically, the hip flexion seen in red improved from 40 degrees to 119 degrees, and ankle dorsiflexion seen in green from 7 degrees to 15 degrees. Next slide, please. The numerical pain rating scale also showed an improvement before and after the physiotherapy sessions, progressing from grade 7 to grade 2. The lower extremity functional scale also showed an improvement from 15% to 63.75%. Coming to the discussion of the case. The difference in the limb length is due to the increased growth in the right tibia due to the osteomyelitis. This is due to the increased vascularization. After the surgery, muscle setting exercises were the first choice of exercise to provide relaxation, decrease in pain and spasm, and an improvement in the circulation. Active stretches aided by maintaining and increasing the fiber length, and passive stretches reduce the muscle stiffness. Walking aids help in assisting ambulation, provides motivation, provides confidence in the independent activity.
You have only 1 minute now.
Next slide, please. Resistance training exercises. Next slide, please. Resistance training exercises improve the muscle strength and power and endurance. Tissue modeling, healing, and repair are also all aided. Next slide. In conclusion, we see that the physiotherapy sessions resulted in an improvement in the patient. She was eventually able to independently carry out activities of daily living with decreased pain and increased confidence. Eventually, both the patient and doctors were satisfied, but it would have been better if the patient and her family were aware of the importance of pre-operative physiotherapy. Next slide, please. These are references that I have used in my article.
The time is up. Dr. Seema, ma'am.
Should I ask?
Yes, please go ahead.
Okay, so you are saying a contemporary physiotherapy, and you have also spoken about a multidisciplinary approach. Okay, but so I just want to ask you whether you have considered the psychological aspect like depression, anxiety, as your patient is adolescent female in your case.
It should have been considered, ma'am, but I did not consider it in my case. It's kind of a disadvantage for my case, yes.
And that's why it cannot be a contemporary physiotherapy. It's a normal physiotherapy that you have given, I believe.
I agree.
Thank you.
Yeah. I have 2-3 questions for you.
Yes, ma'am.
You said the patient had a 2 inches lengthening, which was observed.
Yes, ma'am.
Yes, but it was measured in the supine line. I suppose so.
Yes, ma'am.
So was it a apparent limb length lengthening, or it was a true one?
It was apparent, ma'am.
Okay. Then was the bone grafting done along with the sequestrectomy? Because there is a lot of gaps seen over there.
There was no bone grafting that I saw in the files, so I don't think so, ma'am.
Okay. You don't think so? That means you were not aware of it.
No, ma'am.
And why there was a delay in ambulation of the patient? You can always start the non-weight bearing walking with the crutches with the Elizarov.
Ma'am, the thing is, the patient was quite, scared. She was quite scared.
But it
And-
was your duty to increase the confidence in the patient. And that is the reason the external fixators are used for the early ambulation, no?
Yes, ma'am.
Okay. And very last suggestion to you,
Yes,
you have
ma'am.
not hidden the identity of the patient in the
Okay.
picture. Okay, which is again unethical when especially in the case report presentation.
Yes, ma'am.
Okay. Oh, thank you. Thank you.
Thank you.
Yeah.
08. Participant number
Yes, ma'am.
08. Yeah, please start your
I'm here.
presentation.
Yeah, good afternoon, everyone. I'm here. My title for the presentation is to evaluate musculoskeletal pain symptoms in undergraduate physiotherapy students. Next slide, please. Introduction. Physical stress imposed on the body during college lecture hours includes poor study posture and sitting on chairs in overcrowded classes. This produces muscle strain, joint imbalance, and soft tissue stress. Muscle must hold the body in a single position for a long time, leading to prolonged immobility. A study shows prevalence of MSK pain symptoms by 43% in lower back, 36% in ankle and foot, 32% in upper back, and 28% in shoulder. After obtaining informed consent, we carried out a cross-sectional study among undergraduate students of physiotherapy with a sample size 45. The participants were given 30 minutes to complete questionnaire. Musculoskeletal health questionnaire was used for the study. Excuse me. The questionnaire includes 14 simple questions with an additional physical activity level. Analysis was done using Microsoft Excel. Next slide, please. Aim of the study was to assess the musculoskeletal pain symptoms among the undergraduate physiotherapy students. Objective of the study was to determine the prevalence of MSK pain symptoms in physiotherapy students and to evaluate the quality of life in undergraduate physiotherapy students. Next slide. Thank you. Material and methodology. Materials. Type of study was cross-sectional pilot study. Sampling method used was simple randomized using lottery method. Sample size was 45 subjects. Materials used were musculoskeletal health questionnaire. Methodology. The participants were provided with a detailed explanation of the content and purpose of the study. Results. Age-wise distribution of the students. In present study, there were 7 subjects of 18-year-old, 18 subjects of 19-year-old, 15 subjects of 20-year-old, 14 subjects of 21-year-old, and 1 subject of 22-year-old. Next slide, please. Age-wise distribution against the MSK scale. Most of the population experiences musculoskeletal symptoms, but their physical activity is not hampered and can cope up with quality health. Next slide, please. In present study, we observed that there is musculoskeletal pain symptoms. It has been seen that most symptomatic population was of 19 to 20-year-old age group. In a study conducted by John Ashutosh Santoshi et al. 2019 March, on students going to coaching classes concluded that the long time improper body posture, neglect to exercise, stress and long hour studying makes the students prone to musculoskeletal pain with 87.1% prevalence. Conclusion. The present study concluded that there is 22.3% subject prone to develop musculoskeletal health issue in future if neglected with considering score less than 40. There is 51.1% population experiencing some symptoms and need to improvise their quality of life to prevent musculoskeletal symptoms in future. Next slide. Thank you.
Dr. Seema ma'am.
Ma'am,
Yes, ma'am.
should I start?
Yes, please, Dr. Seema, please go ahead.
So this questionnaire that you have used is the self-made questionnaire, or you have used a reliable tool for assessing your subjects?
Ma'am, it is a reliable tool. Uh,
Which questionnaire
Ma'am, musculoskeletal health
you have
questionnaire.
used musculoskeletal health? Can you please name it?
Musculoskeletal
This
health
is the
questionnaire
available
is the name
questionnaire.
of the questionnaire. It is reliable
Okay.
and valid.
Okay. So you have used musculoskeletal pain as a broad term. So in your
Yes,
subjects,
ma'am.
just any musculoskeletal pain you have considered as a percentage. You have not seen which pain is more, and because what is the cause of that pain? Why in this population that pain is there? You did not interpret that. Only you have checked the okay musculoskeletal pain is there. So what is the again the clinical relevance of your study?
The clinical relevance, that is there any presence of, like you said, broad term I have considered. I haven't specified the area or the region where they were experiencing more. So in general, the students experiencing it or not, the musculoskeletal pain symptoms, I have just focused
How
on it.
exactly how we are going to do anything for those students or that group of age group of population when we don't know which pain is there and why it is there? Okay. Ma'am, you can please.
Sorry, ma'am, I didn't get your question.
So I'm asking you, see, you are saying musculoskeletal pain is there. Okay, musculoskeletal pain is there.
Yes,
What is
ma'am.
the clinical relevance of understanding musculoskeletal pain? Because it's a broad term. What we are going to do further with that pain? Any ergonomic advice we will do, but on what basis? Because we don't know
Yeah,
structure is painful, basically.
yeah, correct, ma'am. Yeah.
Yeah. Okay. Can I go ahead with my question?
Yes, ma'am.
Yeah. See, you have said the title says to evaluate MSK pain symptoms in undergraduate physiotherapy students. The title predicts that this is a population study. Okay, but your sample size is only 40.
Yes.
So you cannot generalize it to the
Yes.
population of undergraduate physiotherapy students. No, this is the first flaw in your study. Second one is you have said the methodology of taking the patient population sample is a simple randomized lottery method. Why did you need to do this? Why there was a simple randomization with the lottery method needed for your study? What was the rationale of using this sampling method over here? Are you? Did you get my question?
Yes, ma'am. Yes, ma'am.
And third one is that you're pertaining this to the posture during the classes, but then they must be using their mobiles also, no? Because this is the era of total social savvy population or media savvy population. So they must be using the
Yes, ma'am.
mobiles and the laptops of their lecture time or the classroom time. That also can give rise to the musculoskeletal pain. No?
Yes, ma'am.
Okay,
Yes,
I'm done
correct,
with
ma'am.
my questions.
Okay. Participant number 09. Are you there?
Yes, ma'am. Yes, ma'am.
Please start.
Work-related musculoskeletal pain, that is WRMSP, interferes individuals' well-being. A cross-sectional study. Introduction. Work-related musculoskeletal disorders are common at workplace due to chronically exposure to sustained posture for longer period of time. Most of the MSD are caused by poor ergonomics, poor fitness, and extensive load, and this will contribute to cause work-related musculoskeletal pain and influence the person's psychological status. Need for studies. Various studies are being conducted on different professionals, including healthcare workers, nurses, physiotherapists, bank workers, IT workers, but there are less studies conducted on clerical workers, computer workers, clinical and non-clinical staff. Also, there are less articles in Indian population. Aim and objective. Aim, the purpose of the study is to investigate work-related musculoskeletal pain is interfering individuals' well-being, and objective is to determine the prevalence of musculoskeletal pain in different job professionals to evaluate the interference of work-related musculoskeletal pain in an individual. Methodology and material, study design. Type of study is a cross-sectional study. Sampling method was convenient sampling. Sample size was 44 subjects, and the material used was brief pain inventory questionnaire. Inclusion criteria includes age 30 to 60 years, individual having working experience of more or than equal to 5 years. Both male and females were included, and the exclusion criteria was recent injury, recent fracture or surgery, pregnancy, neurological condition, CVS, RS disorders, and GIT infections. Participants have willingly participated after reading the consent form, and the data was calculated according to the pain severity and pain interference, ADL and psychological status, that is the pain interference, using the brief pain inventory. The data was collected over 2 months. Results. In the results, the females were more prone to musculoskeletal disorder than the males, and the table is the age-wise distribution of the samples. Like 11 samples were in 30 to 40 age group, 21 samples were in 41 to 50 age group, and 12 samples were in 51 to 60 age group. Now, in the study, individuals were more prone to low back pain, that is 61.36%, and then the upper back pain, that is 59.9%, then neck pain, that is 59.09%, and then shoulder pain, that is 52.27%, and the knee pain, that is 52.27%, and the least was the ankle and foot pain, that is 11.36%. Next slide. The pain severity is less than the pain interference. That is, pain severity is about 12.9%, and the pain severity as a whole is 15.50%. Here, the ADL activity, the percentage is of 8.61%, and the psychological status is interfering of 6.87% of the total population. Here, the graph shows us about the age-wise distribution of the pain severity and the ADLs. The first graph is showing that 41 to 50 age group has the highest pain severity of about 11.85%, and the next was the 51 to 60 age group, that is 11.19%, and the least was the 30 to 40 age group, 9.62%. And the ADL, here the 41 to 50 age group is mostly affected, that is 8.99%. Then the 51 to 60 age group, 8.63%, 30 to 40 age group was the least, that is 7.73. Here the psychological status has been shown in the graph, that is the mostly affected is the 51 to 60 age group of about 8.73%, and the least was the 30 to 40 age group, that is 5.13%, and the 41 to 50 age group was also affected of about 6.96%. Now the discussion. In the present study, more than 60% individuals were reported as low back pain, and the upper back pain and the neck pain were the next frequent type of musculoskeletal disorder. Pain severity and ADL were mostly affected in 41 to 50 age group, and the psychological status is mostly affected in 51 to 60 age group. Next slide. LBP is most observed as because of poor ergonomics, same awkward posture for longer hours, and not changing for hours may be the reason for the low pain severity and ADL were mostly observed in 41 to 50 age group due to their working environment. And the psychological status is mostly affected in 51 to 60 age group as they are heading towards the process of aging and has more experience than other two groups. Next.
Only 1 minute.
Conclusion in the study, yes, in the study we concluded that low back pain is the major work-related musculoskeletal disorder among the professional, irrespective of their age, gender, and job status. When the demographic data was analyzed, females were more prone to the MSD than male, and the psychological status is mostly affected in 51 to 60 age group. Next slide. Next slide. Clinical implications, work-related musculoskeletal pain if ignored, then it will lead to chronic MSD and will hinder the person's well-being. And the present study shows that employees should follow a proper back ergonomic and should keep changing their position at workplace to avoid excessive load on one joint.
Your time is up. We'll go for question answer session. Dr. Chaya ma'am.
Yes. Your title of the study doesn't include the population and it doesn't fit into the PICO format. Okay. So what was your population over here? Because the title doesn't include any population, the description of the population. Do you agree with me?
Yes, ma'am. It was work-related musculoskeletal pain.
No, but what is the population of the individuals? Interferes with the individual's well-being. Who are the individuals?
Clerical and computer workers.
That has to come in your title.
Okay, ma'am.
Okay, because it doesn't fit into the criteria of the PICO format.
Okay.
Of the research question. Okay. My second query is pain severity and pain interference. How did you check? How did you analyze this?
I analyzed it with the help of Microsoft Excel.
So what is pain severity and what is pain interference?
With the help of brief pain inventory questionnaire, I just calculated the data.
No, what is pain interference according to you?
Pain interference in the, was subdivided into two. That is the ADL activity, which includes in the questionnaire, it was included like general activity, walking ability, or the normal household activities, and the psychological status.
How do you explain? How do you explain as a pain interference? According to your knowledge, what is pain interference?
Pain interfering because of pain, the person is not able to do his ADL activity or like psychological status is getting interfered because of pain.
Okay. I'm done with the questions. Dr. Seema can go ahead, please.
You have used BPI for pain interference, correct?
Yes, ma'am.
This is a scale which is basically used for chronic pain. And maybe the reason why you have found that the psychological or pain interference is more in 50 to 60 age group can be that. So it must have misled you that the other population, they don't have more of an interference, because this particular scale is used only for chronic pain, and we are assessing a work related musculoskeletal disorders.
Yes, ma'am.
Okay, so this is the major thing why you have got, and the explanation that you have given for getting more psychological involvement in 50 to 60 years, that they are having more experience than the other group. I don't think that goes with the results that you have got.
Okay.
So,
yes, ma'am.
Thank you.
Like they are working since 25 to like they are having more experience than other two groups.
Experience and psychological or pain interference cannot be related and cannot be justified. Okay, because you are giving the reasoning for pain interference at 50 to 60 years. Why you have got more score at that level, but because they maybe have more chronic in their pain, and they are where the chronic pain is, there the psychological or the pain interference will be more. So your results corresponds to that rather than the experience or whatever you are saying.
Sorry to interrupt you, ma'am. Actually, time is up.
Okay, yeah.
Now we should move towards MSK Junior category 10.
Yes, please go ahead.
Am I audible? Ma'am, am I audible?
Yes, you are audible.
Ma'am, my paper is on perceived stress, so I have to do paper in musculoskeletal. Is that okay?
Yes, it is okay. No problem.
Okay, thank you.
Yes, please start.
So first of all, good afternoon to everyone. My title of paper presentation is Comparison of Perceived Stress in Undergraduate versus Postgraduate Physiotherapy Students. Next slide. Introduction, next slide. Next slide. Perceived stress in the students of health profession is a growing problem worldwide. Perceived stress is the feeling or thoughts that an individual has about how much stress they are under at a given point of time or a given time period. Perceived stress incorporates feeling about uncontrollability and unpredictability of one's life. How often one has to deal with irritating hassles, how much change is occurring in one's life, and confidence in one's ability to deal with problems and difficulties. Studies of healthcare students reported increased level of stress, with academic pressure being the greatest source. Attending college can be a stressful time for many students. In addition to the academic pressure, some has to deal with the individuation from their family of origin, while some may have to attend numerous work and family responsibilities. Faisala et al., in her study on undergraduate physiotherapy students, reported that 88% of the students feeling stressed. There are a number of studies which evaluates perceived stress of physiotherapy students, but no study which compares perceived stress of undergraduates and postgraduate physiotherapy students. Aims and objectives. To compare the level of perceived stress in undergraduate versus postgraduate physiotherapy students. Hypothesis. Next, null hypothesis. There is no significant difference in the level of perceived stress in the undergraduate and postgraduate physiotherapy students. Alternative hypothesis. There is a significant difference in the level of perceived stress in the undergraduate and postgraduate physiotherapy students. Methodology. Study design is cross-sectional. In cross-sectional study, researchers studies stratified group of subject at one point in time and draws conclusion about population by comparing characteristics of those strata. Sample size is 30 in each group. Sampling technique is convenient sampling. In convenient sampling, researcher selects item for the sample and his choice remains supreme for selection. Group A, undergraduate, Group B, postgraduate. In this study, the subjects were briefly outlined about the study and the consent was taken. 33 subjects filled the hard copy of the questionnaire, whereas 27 subjects filled the questionnaire via Google form. Inclusion criteria includes age 18 to 30 years of age, both genders, pursuing VPT or MPT course. Rest, all the subjects were excluded. Group A, undergraduate students. There were 22 female participants and 8 male participants. Mean age of the subjects were 20.26 years. Group B, postgraduate students. There were 28 female participants and 2 male participants, and mean age of the subjects were 24.4 years. Perceived stress scale questionnaire. Cohen perceived stress scale 10 was used for measuring the degree and the prevalence of stress. It is a 10-item questionnaire with a reliability of 0.82. Its scoring is 0, never, 1, almost never, 2, sometimes, 3 is fairly often, 4 is very often. It has 2 subscales. And direct stress, measuring them where the score is done by perceiving the stress created by the scenario. Question number 1, 2, 3, 6, 9, and 10. And indirect stress, where the score is reversed by measuring the level of happiness and confidence of individuals. Question number 4, 5, 7, and 8. Here we have to reverse the scoring. That means 4 is 0, 3 means 1, 2 is 2, 1 is 3, and 0 is 4. Minimum score on the scale is 0, and the maximum score is 40. More the score, more is the stress. Previous slide. The results. No, next. Unpaired t-test was used to analyze mean of 2 samples as data was normally distributed. Mean perceived stress scale score for undergraduate was 80.27. Whereas for postgraduate, it was 18.81. P-value was 0.351. There was no significant difference in both groups at 0.05 level of significance. Therefore, null hypothesis accepted. Discussion. There was no significant difference in the level of perceived stress between two groups. The result of the present study can be explained by the following research. Sitritskaya in their study concluded that high emotional stability can prevent or delay the effect of perceived stress on psychological well-being, and perceived stress can reduce emotional stability. Rani Verghese et al. In her study on college students showed that high perceived stress can result in lower academic performances. Shah Tarpan et al. In their study on undergraduate physiotherapy students concluded that maximum number of students are in normal category, whereas some students having raised level of anxiety. Nivita Ahmed and Prashanta in their study on medical students concluded that 20% have mild anxiety, 74% have moderate anxiety, and 6% have severe anxiety. Narayan Mutak et al. In his study on college students concluded that there is high grade of depression, anxiety, and stress in undergraduate students. Limitation of this study was sample is not homogeneous. Future recommendation, I recommend the same study in different population and different age groups. Conclusion of the studies. The result of this study concludes that there is no difference in the level of perceived stress in the undergraduates and postgraduate physiotherapy students. References of this study. Next.
Dr. Chaya, ma'am?
Yes. You have said that the perceived stress in the
Yes.
undergraduate and postgraduate students, but you have used a convenient sampling, but you
Yes.
said in between there's a stratified sampling.
No, ma'am, I've said, I have explained what is cross-sectional study. In that, I've said that researchers studies the group of stratified subjects. I've explained cross-sectional study.
So what do you mean by stratified subjects?
Ma'am, group of subjects.
What do you mean by the word stratified?
It's like selective something.
Selective something.
Cross-sectional means researcher studies the subject at one point of time.
This word has a meaning in the sampling population. Anyway, I'm done with the questions. Dr. Seema can go ahead.
Yes. So, according to your study, you have used the perceived scale. So,
Yes, ma'am.
according to that scale, what is like how you will grade the population in mild, moderate, or severe stress?
Ma'am, there is no interpretation. They have just said that higher the score, more is the stress. And the mean stress score was 18 point something. So we can say that it is below the medium level of stress, somewhat below.
Okay, so basically, can you like analyze or can you justify why you got this scoring?
Ma'am, in discussion, I have written that point that in one study they have said that the emotional stability can delay or prevent the harmful effects of perceived stress. So it is necessary. It is possible that the people with high emotional stability can have low stress, and with low emotional stability they have more stress, irrespective of the study, irrespective of their academic pressure. Some students may have more pressure, but they have high stability, so they display less stress. And some students have low academic pressure, still high stress because their emotional stability is less. So there was no significant difference in the level of stress in the undergraduates and postgraduate physiotherapy students.
Okay, so you think that most of the population have a good emotional stability?
No, I'm saying that emotional stability and perceived stress scales, perceived stress are related to each other. Means they are inversely proportional to each other. I'm saying that.
Thank you.
Thank you, ma'am.
Okay, junior category 11 number.
Yes, ma'am.
Please start.
Good morning, respected dignitaries. Today my presentation is on physiotherapy rehabilitation accelerating recovery of older patient with anterior cruciate ligament reconstruction, a case report. Introduction: anterior cruciate ligament originates from posterior medial column of the right femoral condyle and inserted into the middle of the intercondylar area. Its action is to resist the anterior translation and medial rotation of tibia in relation to femur. ACL injury can occur by rapidly changing the direction, landing from a jump incorrectly, twisting of the fixed foot, blow to the knee, etc. ACL reconstruction is a surgical tissue graft replacement of the ACL to restore its function after an injury. The torn ligament can either be removed from the knee or preserved before reconstruction of it is an arthroscopic procedure. Physiotherapy is prescribed for ACL reconstruction regardless of the type of the graft used in the surgery. One of the primary physiotherapy goals is to recovery of the quadricep muscle strength. Many researchers have documented the presence of persistent quadricep weakness in patients with after ACL reconstruction. Patients who engage in quadricep strengthening exercises as a part of their rehabilitation after ACL reconstruction demonstrate improvement in quadricep strength. Rehabilitation programs are therefore designed with the following goals post-knee injury: to increase the muscle strength, restore joint mobility and neuromuscular control, and help patient to return to normal activity levels. Patient information. Patient was 58-year-old male. He suddenly met in an accident on 15 November 2019 where he experienced fall from the motorbike on the road. The hip was in external rotation, knee extension, ankle dorsiflexion and foot was everted. He was conscious at that time and was experiencing pain over the right knee and instability over right knee at that time. Then his colleagues took him to nearby hospital where several investigations were done. X-ray was done, crepe bandage medications were given, but there was no relief. Then he came to the hospital where again MRI and X-ray was done. The patient was placed in the position of full extension and was advised to use axillary crutch for while walking. The patient was prescribed 15 days of physiotherapy to focus on increase in knee movement as well as decrease swelling. The patient underwent surgery for ACL reconstruction using semitendinosus as well as gracilis graft. Patient visited to physiotherapy department after 3 weeks, and at that time he was having difficulty in bending knee, difficulty in walking, and was unable to sit with knee flexed. Following are the clinical findings. After taking informed consent, the physical examination was performed on first day of the physiotherapy session. Patient rated 7 on NPRS scale. Pain was gradually progressive in nature, dull aching type at anterior aspect of knee, which was aggravated by walking and relieved at rest and was associated with swelling. Attitude of limb in supine position was hip was externally rotated, knee was in 5 degree of flexion, ankle was plantar flex and foot was inverted. On palpation, the temperature of affected knee was raised. On observation, there were 3 scars present. Gait assessment shows decreased flexion while walking. Range of motion assessment, there was a significant decrease in range of motion of the affected knee in both hip flexion and extension. There was a notable weakness of the hip quadriceps and hamstring muscles. There was a limb length discrepancy present. Next slide. Next slide. Therapeutic intervention. Each physiotherapy session lasted for 45 minutes. The main goals of physiotherapy treatment were restoration of optimum range of motion, improve strength of quadriceps, improve strength of hamstring, improve pattern of walking. Following is a physiotherapy treatment protocol. We give treatment protocol in 5 phases. Phase 1, which lasted for 3 to 4 weeks. Goal was to increase the range of motion. CPM was given up to the limit of pain and heel slice. To increase the strength of the quadriceps and hamstring muscle, isometric contraction to the hamstring and quadriceps was given. Cryotherapy to decrease the swelling. Application of ice pack over the right knee for 8 to 10 minutes. Phase 2 lasted for 4 to 6 weeks. Next slide. To increase the range of motion, as the range was increased above 90 degrees, the CPM application was stopped. Heel slides, active assisted flexion was given. Wall slides were given to increase strength. Active co-contraction of knee extensors and flexors, hip flexors and abductors was given. Phase 3 to increase the range of motion. Heel slides, assisted heel slides with towel, active assisted flexion, stretching of hamstrings and quadriceps, sideline abduction, adduction, patellar mobilization to prevent stiffness and regain full range of motion. To increase strength, single leg squat, static quadriceps, dynamic quadriceps, static hamstring and gluteal squeezes were given. And gait training, unstable surfaces, walking around obstacles for 10 minutes, or for proprioceptive feedback, single leg stance 30 to 60 seconds for gait training. Basic emphasis was given on swing phase to increase knee flexion, weight shifting side to side, forward and backward. Ice application for 15 minutes. Phase 4 to increase strength, continuous stretches and strength exercises were continued. Agility training was given by T-test. Ice application for 15 minutes, aerobic training, treadmill training was given, and running for short, smaller distance was given. Phase 5, a patient was instructed and written exercise regimen was given, which he has to be followed at home regularly. Following out the outcome, there were increase in range of motion of the affected limb, and there were no weakness in the hamstring and quadriceps muscle. Conclusion. Next slide. Next slide. Conclusion. This
stop because your time is over actually. Dr. Chaya ma'am.
Yes. I want to ask you a very simple question. Is what makes you think that your case report, whatever you have presented over here, is different than what other physiotherapy managements are done?
Ma'am, there are many case reports on adult patient with ACL reconstruction. This is the case report on the older adult, which accelerates the recovery.
So, but what different methodology has been used, or what different method is been given to this patient than what we physiotherapists give, so that this case report becomes exclusively different? There is nothing new, no? This is all the usually practiced by all of us.
Yes, ma'am.
Yeah. Okay. Yes. Dr. Seema, you can go ahead with the question.
I actually wanted to ask the same thing, that what is new in this case report, like what extra or anything innovative we are doing with our physiotherapy management in this particular case.
Absolutely. Absolutely.
We can go with the next presentation.
Yes.
Thank you, ma'am.
Participant number 12,
Yes, ma'am.
please.
Yes, ma'am. So, prevalence of ankle ligament injuries and balance impairment in football players. Next slide. So, football is one of the most popular sports worldwide. Football is known to associated with relatively high injury rate. Overall, level of injury to professional footballers recently being shown to be around 1,000 higher than for industrial occupations, generally regarded as high risk. So, injuries are more common in football compared to most other types of the sports, and numerous studies have been carried out to investigate the type, location, and the severity of the injuries in the football. So, studies have shown that the intrinsic risk factors such as increased age, career duration, and previous injury seem to increase the risk of injuries. Some studies also indicate that the mechanical instability in the ankle or the knee, in general, a joint laxity or the functional instability predispose players for new injuries. So, need for study. There is a lack of literature which is available about effect of ankle ligament injuries on the dynamic balance in local club football players, and hence the study is aimed to evaluate the incidence of ankle ligament injuries and impairment of balance and functional performance of the football players by using modified star excursion test. Now, aim is to evaluate the incidence of ankle ligament injury and associated balance impairment in football players. Objectives: to evaluate the incidence of ankle ligament injury and by using anterior drawer test of ankle, talar tilt test, external rotation stress test, to evaluate the balance with modified star excursion balance test, to evaluate associated balance impairment with ankle ligament injury in football players. Hypothesis: null hypothesis, there is no association of balance impairment and ankle ligament injuries in football players. Alternative hypothesis is there is no association of balance impairment, ankle ligament, material and methodology. Material: demographic data sheet, consent forms, tape, measuring tape, pencil. Methodology: study design was survey based. Study duration was 6 months. Sampling method: purposive. Total number of samples 50, and in football players were taken. Inclusion criteria: the club football players age 18 to 29, players who are playing from at least 3 years under the supervision of coach willing to participate. Exclusion criteria: players who are not willing to participate, occasional football players, and players with bilateral ankles instability. Outcome measures: anterior drawer test of ankle, talar tilt test, external rotation stress test, and modified star excursion balance test. The ethical clearance was taken, consent was taken. Procedure of test was demonstrated to participants. Anterior drawer test of ankle, external rotation stress test, talar tilt test was and modified star excursion test was performed, and data analysis was performed. So this was the anterior drawer, then external rotation stress test, and this is the modified star excursion test. Next. So these are the results according to age-wise distribution. So total there were 50 participants, out of which 18 to 23, that is 78% were the in this criteria. Then 24 to 29 in this total 11 participants were there. Next. Next. So this is the graph according to the dominance. So 76% in total were having the right dominance and 24 are having the left dominance. Next. Next. So in total, out of 50, there were 36% of participants who were injured and 64% participants who were non-injured. So this is about reach distance. So as shown in this graph, the star excursion balance test readings were taken and reach distance in the anterior, posteromedial and posterolateral directions were noted, and participants with injuries showed like there was a deficit in the reach distance comparing to the uninjured participants. Next. Next. So this is a composite score. So as like in injured participants, the composite score were less as comparing to uninjured participants. So the study was aimed to check the association of ankle ligament injuries on the balance of local club football players. So initially, synopsis was approved by ethical committee. By permission for data collection was received from the coaches of different football clubs in Pune. In study, 50 football players were selected according to inclusion and exclusion criteria. History of injury was taken and special test of ankle instability was performed to find association with the ankle ligament injury on balance by using the modified star excursion balance test which was performed. The result of the study reported that out of 50 participants, 18 participants had ankle instability and 32 were normal. So participants with positive instability test showed a reach distance deficit in modified star excursion balance test, and that it indicated that the previous history of injury and ankle instability may have association with the balance impairment and reduces the functional performance of the players, and also suggests high risk of injury in those players with reach distance deficit.
Your
Next.
time is up.
Okay, ma'am.
We'll move towards judges. Dr. Chaya, ma'am.
Yes. Your title says it's a prevalence of ankle ligament injuries and balance.
Yes,
ma'am. Then you are using the word incidence. So are you using these two words synonymously with each other, but they are absolutely different?
Yes, ma'am. Yes.
So that is the major thing, because incidence is at that time, no? And prevalence is over a period of time.
Yes, ma'am.
Second one is, you have said that outcome measures were your anterior drawer test for the ankle joint along with the star excursion test. So what was the measurement for the drawer's test? Present or absent? Or because your outcome measure talks about only a star excursion test.
Yes, ma'am. Actually, if that sulcus sign is present, then only I consider those patients like the test is positive for anterior ankle instability. If there is a hypermobility,
that means you
then
use
only.
this test for the screening of the patients.
Yes, yes, ma'am.
Not as an outcome measure.
Yes, ma'am.
Okay, so this has to be included in your methodology.
Okay, ma'am. Okay.
Okay, yeah.
Yes, ma'am.
Okay, I'm done with the questions.
Let me get to the title first. You have used the word prevalence and then incidence also, and then also you were talking about the association also. So these three terminologies are totally different from each other, because in discussion we are talking about the association of ankle injuries and the balance impairment. Okay.
Yes, ma'am.
And also, first thing that needs to be clarified. And again, when you are saying anterior draw test positive, so how much displacement you have taken as a positive?
Like, ma'am, I have compared it to opposite side. There was not a particular measurement. Like, so that may be my disadvantage of this study.
Okay. Thank you. You can proceed.
Thank you.
To the next presentation.
Yes, ma'am. Thank you.
Yeah, Dr. Shweta, we have a number 12 as a relationship of forearm girth and length with strength and endurance.
Yes, ma'am.
And the 13 was actually the one which has been presented now.
Okay, ma'am.
Okay, so I have corrected it to 12. So is a number that relationship of forearm girth with the hand grip is going to be presented?
Yes, ma'am. It is number 13.
It is number 13. And
yes.
No, number 13 over here is the incidence of scapular dyskinesia, which we have as a number 14.
Okay, fine. Got it.
12 has not presented only, I believe.
Yes, correct.
Yes,
Thank you, ma'am.
Yeah.
So now I request participant to present the study. Actually, it is her code is 14 number code actually.
Ma'am, actually, she's not unmuted.
She's not unmuted. Okay, just a minute.
What is her name?
Namrata.
So, Dr. Shweta, should I name her as a 14 only or 13?
Ma'am, 14 number. You keep her number as a 14 now.
14. Okay.
Okay, you can share now.
Yeah.
Hello.
Namrata, are you there?
Yes, ma'am. I'm there. Am I audible, ma'am?
Yeah, you can see the screen, right?
Yes, ma'am. I can see it.
Start the presentation.
Yes, ma'am. So good afternoon, everyone. My topic today is incidence of scapular dyskinesia among chronic smartphone users with shoulder pain in young healthy adults. So coming to the introduction, globally the number of mobile device subscriptions are approaching 6.8 billion. It is expected that worldwide text messaging frequency will increase to 9.4 trillion annually by 2016, up from 5.9 trillion in 2011. Most people are use their phones and tablets on a daily basis, and while doing so tend to stoop their heads, roll shoulders ahead, and slouch at the same time. The age group of smartphone users varies, ranging from students to workers to elderly people. Furthermore, since smartphone users in their 20s commonly use their smartphone more than the elderly, they are vulnerable to having a severe musculoskeletal disorders. Non-neutral and static postures and forceful exertions have been identified as the risk factors for neck, shoulder, and hand and wrist injury. A typical mobile user's posture include a flex neck, flex trunk, protracted, and elevated shoulders. The most widely observed pain after neck is a shoulder pain. In China, reported neck and shoulder pain incidence is 40% among 2575 young mobile phone users. A study in Canada indicates rates of 46 to 52% shoulder symptoms among 140 individuals. Now, the shoulder complex is made up of clavicle, scapula, and humerus. So, impairment in either joint directly influences the other joints. Scapula. The scapula provides a stable base for all functions of shoulder region. So, while dealing with shoulder region, pathologies related to scapula should be taken into account. Coming to the need of the study, the incidence of shoulder pain is 46 to 52% among 140 individuals in the study. The cause of this shoulder pain is still unknown. Scapular dyskinesia may be a cause of this shoulder pain. So this study will be useful in finding incidence of scapular dyskinesia in chronic smartphone users in young healthy individuals. Aim and objectives. Aim to find the incidence of scapular dyskinesia among smartphone users with shoulder pain. Objectives was to assess the scapular dyskinesia in chronic smartphone users with shoulder pain. Material and methodology. Study design is an observational descriptive study. Target population was a young, healthy adults, which are a chronic smartphone users with shoulder pain. Sample size is 70. Materials. KS scale questionnaire. It is a Korean internet smartphone addiction self-assessment tool used. Pain, measuring tape, book, and a mobile camera. Selection criteria in inclusion, subjects between the age of 18 to 30 years, both male and female, chronic users of smartphone, subjects having a shoulder pain. In exclusion, old age and children, known case of neurological, cardiovascular, and systemic diseases, subjects with congenital and traumatic shoulder conditions, subjects not willing to participate. Coming to the procedure, after ethical committee approval, screening as per the inclusion and exclusion criteria were done. Consent were taken from all participants. Pro forma and the questionnaires was filled. Lateral scapular slide test was performed in a 0-degree abduction position, in a 45-degree abduction position, and in a 90-degree shoulder abduction position. Measurements were taken. Like it is the distance from the base of the spine of the scapula to the spinal process of the T2 and T3, and from the inferior angle of the scapula to T7 and T9. Data were analyzed and recorded. These are the pictures showing the 0-degree abduction, 45-degree abduction, and a 90-degree abduction position. Measurements were taken. Now coming to the data analysis and the interpretation. According to demographic data, the mean age of the participants were 22.6, SD was 2.477. According to the gender, female were 70% and the male were 30%. Right-handed were 98.57 and left-handed were 1.42. From the occupations, 77.34 were the students and the remaining 22.85 were the employees. Coming to the graph, so this graph is showing like in total 70 was the sample size. About that, in total 34 were having a scapular dyskinesia. In percentage out of 100, it is 48.57% having a scapular dyskinesia, and people 51.43% are not having a scapular dyskinesia. Graph 2 are showing according to the persons in a 0-degree abduction, 45-degree abduction, and 90-degree abduction. So accordingly, 28 it is in a 0-degree abduction, in a 45-degree abduction 32, and in 90-degree abduction it is 25. Third graph is showing that the people using mobile phone more than 4 hours with scapular dyskinesia is 29 in numbers, that is 85.29 in percentage, and people not using it more than 4, using it more than 4 is 20, not using it is 5, in percentage basis it is 14.70%. Next slides, please. Graph shows the average K score. So the people having a scapular dyskinesia were having a 39 average K score, and the person without scapular dyskinesia were having 35 K score. Coming to the discussion, the chronic use of mobile phone has a direct effect on health of the person. Repetitive movements and a sustained poor posture causes stress on muscles and joints. In our study, the incidence of scapular dyskinesia in chronic smartphone users with shoulder pain is 48.57%. During a sustained position, there is
presentation.
Sorry, ma'am.
Only 1 minute left for your presentation.
Yes, ma'am. During a sustained position, there is a fatigueness of the muscles which alters the glenohumeral function, coordinated activity of the muscle, which results in impaired scapular movement and the timing. The main reason behind this is the impaired muscle inhibition. In this, when the muscle is activated, it uses a stretch reflex connections to stimulate the agonist and to inhibit the antagonist to movement using an inhibitor in interneurons. So when the muscle is recruited for so much time, it inhibits the function of antagonist muscle and weakens it. So mainly weakened muscles are the serratus anterior, lower and middle trapezius, and the tight muscle will be upper trapezius. Next slide. So the conclusion is there is a moderate correlation between a scapular dyskinesia with shoulder pain in chronic smartphone users. Thank you so much.
Dr. Chaya, ma'am.
I have two questions for you.
Yes, ma'am.
One is what is the definition of the chronic smartphone users?
Ma'am, I have used a scale. In that scale, it shows that and some articles also shows that the persons who are using the like more than 4 hours, they can be say as a chronic smartphone users. So according to that reference, I have taken it like
Is
a
this
chronic.
Scale validated? Is this scale
yes, ma'am.
validated?
Yes, ma'am. It is a validated scale.
Okay. And what is scapular dyskinesia according to you?
Ma'am, like in scapular dyskinesia, mainly we see kinematics alterations in the kinematics of the scapula. So according to that, there are 3 types of the scapular dyskinesia: the medial, the inferior angle, or the medial border, or the upper border comes in the prominent way. And mainly the muscles which goes into weakness are the serratus anterior, rhomboids, or we can say the rotator cuffs are also mainly responsible for it. And the major muscles which goes into the rightness are the upper trapezius muscle, because it is an antagonist, and when the upper rotation of the scapula has been hampered, because of that the serratus anterior goes into the weakness and the upper trapezius goes into the tightness. So this is the main reason of the scapular dyskinesia here.
Okay.
Yes, ma'am.
Yeah, Dr. Seema, you
Yes,
can
please.
go ahead. Yeah.
So you have found
Yes,
the
ma'am.
incidence of scapular dyskinesia. Did you find it out which type of scapular dyskinesia was common in
Yeah. Yes, ma'am. Actually, mainly what I was found was the medial border prominence was more in the patients.
So you should have
In the
mentioned
participants.
also your
Sorry.
question. And plus, the incidence of shoulder pain is quite less than the incidence of neck pain in smartphone users. So you have not taken craniovertebral angle as one of your outcome measures. So can you?
Oh, yes, yes, ma'am. Huh. Hello.
Yeah. So why you have not taken? Because the incidence of neck pain in literature, if you see, is more than the shoulder pain. So my thing is, you are seeing scapular dyskinesia, but did you try to locate at the craniovertebral angle also?
Yes, ma'am. That has not taken. Actually, I saw the studies. The studies on neck pain was done, but not on the shoulder pain. So my focus on was on more on the shoulder pain. So that got skipped by me, the neck pain area.
And
So the studies can be done
all
on both.
subjects have shoulder pain, which you have included.
Sorry, ma'am.
All the subjects that you have included.
Yes, ma'am. The inclusion criteria was that only. So I have screened the subjects, and who were having the shoulder pain were taken only.
Okay, fine.
Yes, ma'am.
Both the judges, please make a note. She is 14 number. just now who has presented, and the previous one was 13 number. Is it fine, ma'am?
Yeah, previous number was the
13.
13. Yes,
That is
yes.
prevalence of ankle ligament injuries and balance impairment. It was 13 number.
Yes.
And this one was 14 number, and then we are moving towards 15 number now.
Yes, yes, noted.
15 number participant, please start.
Yes, ma'am. Yes, ma'am. Am I audible?
Yes.
Good morning to one and all. My paper presentation topic is comparison between effects of yoga postures and foam rolling exercises for improving hamstring flexibility in among young population. So next slide, please. Introduction. Yoga is an ancient physical and spiritual discipline and branch of philosophy that originated in India. Yoga practices enhances muscular strength and body flexibility to promote and improve respiratory and cardiovascular functions. Yoga helps the muscles, tendons, and ligaments to move through a full range of motion, thus cultivating balance and core strength. Self-myofascial release (SMR) is a population intervention used by both rehabilitation and fitness professionals to enhance myofascial mobility. Common SMR tools include foam rollers and various types of roller massagers. Evidence exists that suggested these tools can enhance range of motion and recovery processes in decreasing the effect of acute muscle soreness, delayed onset muscle soreness, or post-exercise muscle performance. One such device that has been shown to increase flexibility prior to physical activity is a foam roller. Next slide. Need of study. Both the techniques are individually proved for improving flexibility, but few researchers has done on comparison between these two studies. Hence, need of study is to see which is more effective for improving flexibility with less use of assistive devices. Aim to compare the effect of yoga postures and foam rolling on hamstring flexibility in young population. Next slide. Objectives. To study the effect of yoga on flexibility in hamstring muscles by using 1990 straight leg raising test. To study to compare the effect of both techniques by using 1990 straight leg raising test. Research question is which method between yoga and foam rolling exercises is more effective in improving hamstring flexibility in young population. Next slide. Material used is goniometer, then foam roller and yoga mat. Methodology is type of study is interventional study. Sampling method is purposive sampling. Study population is young students 18 to 25 age, and sample size is 100. Outcome measure is range of motion by goniometry by using 1990 straight leg raising test. Next slide. Inclusion criteria. Inclusion criteria is young population, people having hamstring tightness, then age within 18 to 25 years age, then both male and female. Exclusion criteria is recent injuries to knees, hypermobility, recent injuries to hip, and any hip knee musculoskeletal disorders. Hypothesis. Null hypothesis, there is no difference between the effect of foam rolling and yoga on flexibility in hamstrings. Alternative hypothesis, yoga is more effective in improving flexibility of hamstring and as compared to foam roller. Foam roller is more effective in improving flexibility of hamstring compared to yoga. Next slide. Procedure. Ethical approval was taken and written consent was taken from the ethical committee. Subjects were selected by purposive sampling. Total 100 students were screened for hamstring muscle tightness. Hamstring muscle tightness was assessed by using 1990 straight leg raising test, dividing them into group A and group B 50-50 using simple random sampling. Pre-assessment test was done to check flexibility. Group A was given 4 yoga postures for improving hamstring flexibility. That was standing forward bend, uttasana, then downward facing dog pose, then triangle pose, and then side lunges. And group B was given foam rolling exercises for hamstring stretching. The first step begin in a seated position with your hand on the floors. Place your foam roller under your knees and slowly begin moving roller up towards the hip. Be sure to rock your weight back and forth. The protocol was given for 30 to 60 seconds, 2 to 5 repetitions for 3 days, continuously every week for 4 weeks. And relaxation time was given 5 to 10 seconds in between the sessions. Readings were taken after 4th session and data was analyzed and results were obtained. These are the postures, yoga postures, and for improving hamstring flexibility and foam roller exercises. Next slide, result and interpretation. Data was analyzed by using paired t-test and unpaired t-test. Within the groups, paired t-test was used, and in between the groups, yoga and foam roller unpaired t-test was used. There was no dropout of the patients from the study. Conclusion, after comparing both groups, group A and group B, it was concluded that there was improvement in hamstring flexibility in both groups. But the yoga and foam roller, which made it clinically significant and statistically, it is also significant. We concluded that yoga postures may be more effective as compared to foam roller and can be given without any assisted devices. So, but under the observation by a professional yoga instructor after proper evaluation of patient by a physiotherapist. Limitations of study, only specific age group was included in this study. Next slide. Recommendation and future scope. Different outcome measure can be used. The study can be done in different populations such as athletes. Further study can be done with inclusion of equal number of male and females, and then the study can be done on bilateral leg also. Clinical implication, as per the study, for improving hamstring tightness, yoga posture can be given without any assistive devices anywhere. Thank you.
Dr. Seema, ma'am.
Yes, so the first thing is in your inclusion criteria, you have mentioned people having hamstring tightness. So
yes, ma'am.
You have taken severe tightness also in your inclusion.
Yes, ma'am. Yes, ma'am. People, all the groups of tightness, people who is having hamstring tightness are included.
So there was no baseline for including in your group for hamstring tightness.
Yes, ma'am.
So in your foam roller group, how many were into severe tightness, and in your yoga group, how many were into severe tightness?
Ma'am, actually, tightness. I have measured the tightness by using 99
because it's an
straight
objective
leg lifting
method.
test. Yes, ma'am.
Because it's an objective method for measuring the tightness, I'm asking you this question.
So, ma'am, I have used goniometer to measure the hamstring tightness.
Yeah, that I understood that you have used that as an outcome measure, but I'm asking you how many, whether the distribution was homogeneous or not, that I want to understand. Whether in both the groups the tightness taken was like same, or in one group you have taken severe, or in other group you have taken mild to moderate.
No, ma'am. No, ma'am. Both group I have taken moderate, mild, and severe tightness.
Yeah, but you have not categorized that tightness.
Yes, ma'am.
Thank you. Chaya, ma'am, please.
Yeah. Can you justify why have you used a purposive sampling?
Ma'am, I have taken I have taken only people who is having hamstring muscle tightness, and ma'am, particular age group of people.
Okay. Then your objectives have come before your research question. In your research methodology, the research question is always the first one to come. No, if you go to your slide, you will understand it that objectives are written first, and then the research question has come. The order is reversed. And in results section, you have not shown any table or graph. It is only the 2-line results.
Okay, ma'am.
Okay, this is a paper presentation competition. We need to have to look at your tables and the graphs.
Okay, ma'am.
Okay, done. You can go ahead with the next one.
Yes, ma'am. Okay, ma'am. We'll start with now number 12. Junior category number 12. Are you there? Are you there?
What is the name of this person?
Just a minute. Her name is Sanjana.
I couldn't find her. Deshpande, yeah?
Is she there?
No, I can't find her.
She's
Probably she is on some other name.
okay. She's having some connectivity problem actually.
Achha.
Okay,
Number 12, can you please raise your hand if you're here?
Anjana, can you please raise your hand?
Okay, I can see you now.
She's there. Okay.
Is this you?
Number 12.
Yes, hello.
Yes, please start.
Yes, ma'am. Sorry for the delay. So my paper presentation topic is the relationship of forearm girth length with hand grip strength and endurance, and it is a correlational study. Next, yeah. Introduction. The hand is one of the most complex joint in the human body. The major function of the human hand is to manipulate objects and to accomplish goals such as grip, grasp, and to form precise movements also. Hand grip strength plays a very crucial role for human body while performing the prehensile and precision hand functions also in order to hold objects in our day-to-day life and to maintain it. So to perform daily living skills and work-related functions, recreation activities, one requires considerable amount of hand grip strength. It has been reported that certain hand characteristics such as long fingers, larger hand surfaces, forearm length and its circumference plays a very important role in having a stronger grip and strength. Stronger hand grip strength has found to be associated with lower heart risk, heart attacks, and stroke. Better hand grip strength was associated with heart cardiac structure and function in a pattern that is indicative of less cardiac hypertrophy and remodeling. Also, hand grip strength is a predator of muscular endurance as well. Endurance is ability of muscle group to perform repeated contractions over a period of time until fatigue. Therefore, it is important to consider hand grip endurance as an important component for assessment of static hand grip strength. Individuals in everyday life requires a constant muscular contraction in order to perform ADLs, holding objects, lifting weights for ample amount of time, which requires stronger hand grip strength. Henceforth, it is important to consider hand grip endurance as an important component for assessment of static hand grip strength. So the materials and methodology is, this includes information of the subjects, procedure, data collection. So the study design is correlational study. Target population were young adults with normal BMI. The sample size of the study was 150. The method used for this was purposive sampling. Materials required is stationary handle dynamometer, weighing machine, stadiometer, measuring tape, consent form. So our inclusion criteria consists of young adults with normal BMI, age between 18 to 33, both males and females, people with right and left hand dominance, individuals with complete hand and forearm range of motion, individuals should be healthy while performing hand activity. Our exclusion criteria is history of any recent fractures or any hand pathology, deformity, or any neurological pathology. Outcome measures is hand grip strength and hand grip endurance. So the procedure, both male and female subjects were considered for the study. Weight of the objects was documented using weighing machine, whereas height was recorded by using a stadiometer. So on the basis of the measurements, BMI was calculated, and according to our inclusion and exclusion criteria, 150 subjects were selected for the study. So forearm length and girth of dominant hand was measured using measuring tape in centimeters. Forearm length was measured using from olecranon process to the midpoint, joining the radial and ulnar tuberosity using a standard measuring girth. For forearm girth, the part with maximum muscle bulk was measured. Hand grip strength and hand grip endurance was measured by using dynamometer. Each subject was made to sit on a chair with the dominant hand shoulder adducted, elbow flexed to 90 degree, and forearm wrist in neutral, with forearm resting in armrest of the chair and wrist at the edge of the armrest. For hand grip strength, handle dynamometer was given to the subject in his or her dominant hand. Subject was instructed to grip the dynamometer as hard as possible for 3 seconds. So 3 trials were taken of the hand grip strength was done, and average of these recordings was calculated. And for the hand grip endurance, 60% of hand grip strength was measure the hand grip endurance. So subjects were instructed to squeeze the handle dynamometer till 60% of his or her strength and were told to maintain it. So the time till which the subject was able to hold that was recorded. 2 trials were done for the endurance within 5 minutes of rest in between both the trials. The recording with maximum time was selected as hand grip endurance of that individual. All 4 readings were taken and then analyzed by statistical procedure. So the data analysis was done by using Spearman's coefficient of rank correlation, which revealed a positive correlation of forearm length and girth with hand grip strength, whereas it shows a weak correlation of forearm length and girth with hand grip endurance. So the first graph shows the correlation of forearm length with hand grip strength, which is a positive correlation, whereas the second one shows the inverse correlation, which is between forearm length and hand grip endurance. So when the forearm this length increases, the endurance decreases. Whereas third graph shows positive correlation between forearm girth and hand grip strength, and last one shows inverse and weak correlation.
1 minute left.
Yes, ma'am. So this is the reading which we got by using the statistics. Ma'am, next discussion. Yes, from the results of the study, so which we get, it is the most fundamental concepts in the muscle physiology, which show the direct relationship between the isometric tension development in muscle fiber and length of sarcomere in muscle fiber. There is an optimal sarcomere length at which the muscle fiber is capable of developing an isometric tension. So muscle fiber develop maximum isometric tension at optimal sarcomere length because of the thick and thin filaments. If the muscle fibers is lengthened or shortened beyond the optimal length, so the amount of active tension that the muscle fiber is able to generate, it decreases. When the muscle fiber is lengthened beyond the optimal length, so the cross bridge formation will be more, maximum in number. Henceforth, the grip
Your
strength
time
will be
is up.
more. Yes, ma'am.
Your time is up.
Yes, ma'am.
So, Seema, ma'am.
Yes, the first is why you have used the Spearman correlation coefficient.
Yes, ma'am. Ma'am, we have using this because our study is correlational.
Yeah, you
So due to
use a Pearson.
yes, ma'am.
Why you have not used the Pearson correlation coefficient? Why you have used the Spearman's?
Ma'am, we have not using Pearman's because in Pearman's what we have some data, like they have some, so we have to go according to that. Whereas we are doing in general and we are comparing. So henceforth we are using this.
You know when to use Spearman and when to use Pearson coefficient correlation.
Yes, ma'am. Yes, ma'am.
Okay. Next thing is you are saying the weak inverse correlation. What do you mean by that? Weak
Yes, ma'am.
positive or weak negative?
Ma'am, weak inverse, I have said because of the values of the row value. Because length and endurance, the value is 0.228, and the negative this had come in our statistics. Henceforth, it is inverse and but it is weak.
Means it's weak negative correlation.
Yes, ma'am.
Thank you. Ma'am, please.
Yes, yes. Now, why have you calculated BMI to include the subjects in your study?
Yes,
What
ma'am.
was the
Because
correlation of the BMI and your outcome measures?
yes, ma'am. Ma'am, because we have taken BMI because we want normal BMI people. Because in overweight and underweight, there are chances of they must be having a weak grip strength and endurance. So henceforth, they are excluding that. So to take normal BMI, we have taken this.
So you already had a bias in your mind that the
No,
obese
ma'am.
people will have a weak.
We have the articles which concluded that in uh, underweight and overweight obese people, they have their weak strength and power. Henceforth, we have taken normal BMI.
Okay. Which make of the company you had used for the handheld dynamometer?
Sorry, ma'am. Repeat.
Which handheld dynamometer was used over here?
Ma'am, stationary.
What was the make? What was the company's name?
Okay. Jamar handheld dynamometer.
What is the type of Jamar handheld dynamometer?
Ma'am, this was stationary type. We have two types in this.
Stationary type. It's a hydraulic handheld dynamometer.
Hydraulic, yeah, ma'am.
Okay. Take it. Yes, I'm done with the questions.
Okay, ma'am.
Okay, participant number 04. Are you there?
Yes, ma'am.
Please start.
Am I audible?
This is from senior category. No, this is from
No,
junior
ma'am.
category.
It's
Junior category, ma'am.
junior category, ma'am. 04.
4. Okay, got it.
Should I start now?
Yes, please start.
Good afternoon, everyone.
My topic for today's presentation is carrying angle and its correlation with different parameters, height, length of forearm, and age. Introduction, the definition of carrying angle. The carrying angle is defined as the acute angle made by the arm's median axis to that of the forearm, which is fully extended, supinated, and thus measures the forearm's lateral obliquity. This angle is best found when the elbow is in full extension, forearm in supination, and the shoulder in external rotation. Next slide. The carrying angle allows the forearm to clear the hips while swinging during walking and is also important when carrying objects. It is observed that the normal carrying angle in males is 5 to 10 degrees. In females, it is slightly greater, being 10 to 15 degrees. When the carrying angle is more than 15 degrees, the condition is known as cubitus valgus. When the carrying angle is less than 5 degrees, the condition is cubitus varus. The carrying angle varies between individuals and is found to be higher in females compared to males. As in study, it was shown that as females have smaller shoulders and wider hips than male counterparts, thus the females have a greater carrying angle. The carrying angle in the non-dominant extremity is less than in the dominant extremity of both the gender, as force of nature altered the carrying angle. Next slide. Need for study. Most of the studies, previous slide now. Need for study, as most of the studies done on carrying angle include comparison of carrying angles of right and left side, comparison in males and females with dominant and non-dominant side, and correlation with circumference of waist. Thus, there was an attempt made to study correlation of carrying angle with height of the person, length of forearm, and age. Aims and objectives, to study correlation of carrying angle with height, to study correlation of carrying angle with length of forearm, and to study correlation of carrying angle with age. Procedure. In procedure, first permission from the ethical committee was done. Then selection of target population was there according to inclusion and exclusion criteria. First explanation of the current study was done to all the patient, and informed consent was taken. Then the total procedure was explained to the patient as what is to be done. Then evaluation of carrying angle was done in degrees, evaluation of height in centimeters, and evaluation of length of forearm in centimeters. Then the data collection was done and statistical analysis was done. The inclusion criteria was physiotherapy students. The exclusion criteria was any musculoskeletal injuries of upper extremity, fractures of upper extremity, or any neurological involvement of upper arm. The materials used for this study were universal goniometer and a measuring tape. The measurement of carrying angle was done using a goniometer. The fixed axis of the goniometer was positioned on the upper arm's median axis. The mobile arm of the goniometer was adjusted to forearm median axis, and the angle was noted on the goniometer. The angle was taken on both the sides to assess the difference on both the sides, if any. It was measured in degrees. The height of the person was measured using a tape. The landmarks used where the height was measured in standing in an erect position, in anatomical position with bare foot from the vertex to the heel. The forearm length was measured using a tape. Medial epicondyle and ulnar styloid process were used at the landmarks. The distance is recorded as forearm length between these 2 points. All the parameters were measured in centimeters except the carrying angle, which was measured in degrees. 3 consecutive readings were taken and the mean was recorded along with age. The result shows that there is inverse relation between the height and the carrying angle. If the height of the person is more, the carrying angle is less. There was also inverse relation with the forearm length and carrying angle, as forearm length and height of the person are directly proportional to each other. In conclusion, height of the individual is, according to the report, inversely related to the carrying angle. It is evident from the present study that the height and length of forearm is directly related to each other. Therefore, the length of forearm is also inversely related to the carrying angle. No significant variation was found in carrying angle with age of the subject, as the age were in the limited range. Limitation of the study is that the correlation with age couldn't be found, as their age was limited 18 to 22 years. Thank you.
Yeah, can I ask question?
Yes, ma'am.
Yeah. Your study population says that it was done only in the physiotherapy students.
Yes, ma'am.
What was the rationale for this? Why did you choose only the physiotherapy students?
Ma'am, they were easy to access.
One sec. Let me finish my question.
Yes, ma'am.
So, do you think that whatever the outcome measures or whatever the study you are going to do will be different in the other population than in the physiotherapy students?
No, ma'am. The population was easy to access. That's why the physiotherapy students were used as a population.
That was the investigator's bias. It was your
Yes,
convenience.
yes, ma'am.
Yeah, you
Yes,
agree
ma'am.
with that?
Yes, ma'am.
Okay. And age definitely has a change in the carrying angle, and that study has been done. But you should not have kept that as a objective because you had only a limited population. No?
Yes, ma'am. Actually, the population was decided later, and then we realized that the age component will be a limitation in our study.
It is not a
But
limitation. It's a wrong objective which you have chosen because your age is only from the specific time. The very
population,
young
yes,
people.
ma'am.
So you cannot have a age criteria is in your study. That is a wrong selection of the objective.
Yes, ma'am.
Okay? Yeah. Yes, I'm done. Dr. Seema, you can go ahead.
The one thing is, I
Hello?
should remove the age from your title because you actually have not
Hello?
addressed that. Hello,
Yes.
am I audible? Hello.
Yes, ma'am. You are audible, ma'am.
Yeah. So age cannot be a part of your title as you have not actually taken in your study the age criteria. Second, what statistical test you have done to find the correlation?
Yes, participant 04.
Are you here?
Are you there?
I think let it be. We'll start with the next presentation.
Yes, correct. Okay, ma'am, we have finished with our all 15 junior category papers, and now we are moving towards the last paper, senior category 05. 05 senior category. Piyush, please unmute her. Piyush, are you there? Piyush, can you hear me?
Yes.
Please unmute her. I have
Um,
given her name. Zero 05.
yes. She's there. Please unmute.
05, are you there?
05, please unmute. She's here. I allowed her to talk, but
Okay, but
yeah.
I don't know, maybe some technical issues. She must be having some network
She just
issue.
left.
05, are you there? Actually, she was having technical issue at that time also.
Mm-hmm. She has to unmute from her own side now.
Please unmute from your side, 05.
Yep.
Is she?
She has unmuted.
Please start.
Ma'am, this is my neuro presentation actually, not MSK.
No, but it is now under the category of MSK only.
Okay.
So please start it.
Ma'am, my topic is not matrix rhythm therapy. It's about Bell's palsy.
No. It's a senior category MSK. It's not, we are
Yeah, that's what I'm telling. Mine is neuro category.
No, it's not for neuro. We are calling senior category MSK 05.
No, I'm not me, ma'am.
Judges, please give us 2 minutes. We'll call her. Hello, Mridula. काय करू?
एका तासात 6 होतात.
Excuse me, ma'am. Hello.
Yes.
Ma'am, I'm participant number 04 from junior category.
No, we don't
Lost.
want you. We want senior category MSK 05. Piyush, her name is Mrudula. Please unmute her. Is it? Mrudula, no, Mrudula. We are not able to hear you actually. Actually, he has unmuted you. Piyush has unmuted you.
Zero five, no?
Piyush,
Yes.
are you able to see the name Mrudula?
No, I can't.
05 senior category SRMSK 05. Are you able to see? No.
No, there's SR Neuro.
SR 0, no, SR MSK 05 I'm saying. Are you
No, I
able
can't
to
see her online.
just check it out? We'll give her a minute and otherwise we'll end the session. No, she's not there, no?
No.
I'm so sorry, Mridula, you are not there in the list, so I'll have to stop it now. So actually our one participant, that is MSK senior category 05, because of some technical issue, she is not able to join it. Please judges make this known. Senior category 05 is not presenting the paper because of the technical issue.
Okay.
Is it fine, ma'am?
Okay, okay.
Yes.
Okay, ma'am.
Dr. Shweta will give us some 15-20 minutes to submit our results. Is it okay?
Yes, ma'am. We are just finishing it. Before that, actually, I want to give you thanks a lot, a big thanks a lot to both of you. So on behalf of Rehab-e-Con team and musculoskeletal physiotherapy department, I extend my deep gratitude to our eminent judges, Dr. Chaya Verma ma'am and Dr. Seema Senvi ma'am. Thank you so much, ma'am, for giving your valuable time and evaluated five senior and 15 junior papers. Actually, it was a rapid fire round for you, and it must be tiring for both the judges. And thank you so much for your all valuable suggestions which you have given to our senior category and junior category. Thank you so much, ma'am. So now I request both the judges to give their feedback for this musculoskeletal physiotherapy research paper presentation under Rehab-e-Con 2021. Dr. Chaya, ma'am.
Yeah, most welcome. And I'll give my results within 20 minutes. Okay. I'll just send you on the WhatsApp.
Okay, ma'am. Okay, ma'am.
Yeah?
No.
Okay. Most welcome. Thank you so much for giving us the opportunity to judge the papers.
Ma'am, it's our pleasure and honor both. Thank you so much, ma'am.
Actually, I'm glad that I could share the platform with Dr. Chaya Verma, ma'am. She's always my favorite. And
Thank you for kind words, Seema.
I would like to thank Dr. Varsha Kulkarni, ma'am, Principal, LMF College, and Dr. Shweta Pajpute for the invitation. And I think it was a well-organized conference.
Is it, ma'am?
It is. This thing, little bit, it happens. So
yes, ma'am. Actually, I accept our apology. Both the judges.
we cannot, the technical faults are always there. So we have to ignore that part.
Yeah, ma'am. And unfortunately, our senior code, this is 05. She hasn't also presented because of this technical delay.
I can understand.
No problem. Okay. God bless you all. Okay. I'll quit the meeting. Okay.
Yes, ma'am. Thanks a lot, ma'am. Thank you, ma'am. Thanks a lot.
There is one announcement for the participants that validatory function and results will be declared around 4 to 4:30 p.m. So kindly join on the same link which was there on the yesterday. We'll again circulate it in the WhatsApp group for the validatory function. Thank you.
Neurophysiotherapy presenters. We are just done with the musculoskeletal prepared presentations. Can you hear me, all of you?
Yes, ma'am, we can hear you.
So within 5 minutes, we are going to start.
A reminder to all the student presenters, please rename yourself with your code ID only. If you're raising your hand, I will assume that you have to be presenting.
We are starting with our neuro presentations. So I kindly request neuro 01 and 02 to be ready. There is an instruction for presenters. Please change your login name. And instead of that, put your code, which we have given you.
Put the complete code. If not, it will not be unmuted from our side. Please notify, put the complete code. Am I audible?
Yes, ma'am, you are.
Okay. We shall start. A very good afternoon. I extend my warm welcome once more to all the delegates and the participants online. Day 1 of Rehab-E-Con 2021 commenced with all its grand success. We are here to accomplish day 2 of the conference. I, the conference organizing chairman, Dr. Varsha A. Kulkarni, the principal, LSFPF College of Physiotherapy, along with the conference program head, Dr. Gargi Bhalekar, the HOD of Neurophysiotherapy of our college, welcome you all for this session. We are honored to have with us the two dynamic personalities, Dr. Swarna Ganveer ma'am and Dr. Saili Paldekar, as the judge for neuro paper presentation. I am fortunate to introduce Dr. Suvarna Ganveer ma'am. Hello ma'am. Madam is Professor and Head of Department of Neurophysiotherapy, Dr. Vittal Rao College of Physiotherapy, Ahmednagar. She requires no formal introduction though. I take the privilege, ma'am, to introduce you. She is crowned with 23 years of teaching experience with UG, PG recognition and also the PhD guide in MUHS Nashik. She is also the FAMER member and has procured PG diploma in epidemiology. Ma'am is also the member of Board of Studies, Allied Health Sciences. She is also the recognized faculty of for Health Sciences Education workshops and research methodology workshops at MUHS Nashik. Ma'am also is the coordinator of Maharashtra State Indian Association Physiotherapy Women's Cell and the EC member IIP Maharashtra State Branch. I welcome you, ma'am.
Good afternoon, everyone. Our today's judge is Dr. Saili Paldekar, ma'am. With us. She is having 14 years of experience in neurophysiotherapy. Ma'am is a NDT certified and currently ma'am is the head of Department of Neurophysiotherapy in Mymel College of Physiotherapy. So there are instructions for presenters that they do not have to reveal their ID. They have to unmute themselves and they have to keep their cell phones on silent mode. They have to abide the timings and we will give you a timing call. And the time, if after the time is up and you will continue with your presentation, then the question answer session will not be held. So please follow these instructions. So, and keep your videos off. Presenters, please keep your videos off. So I request code number Neuro01. I'm going to senior category. Are you there? Senior category Neuro01. Are you there?
Yes, she's here. Please unmute yourself.
01, are you there?
Your time starts
They
now.
are here. They are here, but they are not unmuting.
Senior Neuro paper presentation 01, please unmute yourself. Your time starts now. Okay, shall we start? She is not able to unmute. Can we please start with the second senior paper presenter? Senior category Neuro 02, are you available? Are you there?
Hello, am I audible?
Yes. What is your, this is virtual hall 2, that's how you have named yourself?
I am 02.
But you need to rename yourself as your code.
Yeah, I am RAC SR Neuro 02.
Okay, please code it the same.
No, but this is not my tab.
Okay, wait. The first one is there. She's there. Okay, your time starts now.
Okay. Good afternoon, Vanan. Hello, may I start?
Just please note this.
That the code is 02.
Yeah, 02. May I start, ma'am?
Yes.
Am I audible?
Yes.
Yeah. Good afternoon, Vanan. All over here. My topic of presentation is effect of mental practice on balance confidence in patient with essential tremor. It's a case report. Next slide.
It is changed.
Essential tremor is a progressive neurological disease and is considered the most common movement disorder. Depression, anxiety, and age are associated with increased functional disability in essential tremor regardless of tremor severity. Essential tremor also associated with a wide range of impairments such as ataxia, postural instability, impaired tandem walking, and decreased gait speed, which hampers the confidence. There is a paucity of research investigating in rehabilitation for individuals with essential tremor. Next slide. Typically, individuals with essential tremor will seek medical management to reduce tremor, such as pharmacological remedies or the deep brain stimulation. Although the deep brain stimulation can diminish tremor, but the prolonged bilateral deep brain stimulation is linked with postural instability and impairments in gait and balance in individuals with essential tremor. Also, the deep brain stimulation not routinely preferred by patients. Next slide. Considering the current pandemic crisis, when actual patient visit not possible, daily rehabilitation is a boon. So, I treated this patient on telerehabilitation only. So I used mental practice, which involves repetitive cognitive rehearsal of physical movements in the absence of physical and voluntary attempts. Mental practice alone is not as efficacious as the mental practice coupled with physical practice, but it does elicit the cortical and neuromuscular activations. Next. It's a case report. So I have taken once a 70-year-old male patient diagnosed with epilepsy having essential tremor on regular medication since 55 years. So he was diagnosed with epilepsy at the age of 16, and he is on regular medication since then. For that, I have given him 15 sessions of mental practice at home on teleconsultation. Scoring of essential tremor rating scale, TETRS. I have taken first the initial day. I have taken the scoring of tremor on that scale, and it was first on the TETRS. The first session it was 21, and after the last session, after giving the mental practice session, the last score for TETRS was 12. And the 6 item activity specific balance confidence scale I have taken on first, it was 70% showing, and on the 15th session of mental practice, the last session, the score was 160%. It shows there is an improvement in activities on balance confidence, and reduction in essential tremor were noted. And so this is the scale for activity specific balance confidence scale, in which there is some questionnaire. I just want to ask the patient regarding the questionnaire, and there is a confidence, like the confidence is rating from 0 to 100%. 0% is no confidence, and 100% is the complete confidence. So the activities are like the total. I have taken the small short version of it, so I have taken only 7 questions. The questions are like walk around the house. I just want to check the confidence. Like this way, I have checked the confidence. Next is, and this is the essential tremor rating assessment scale, in which there is activities. There are some activities like head tremor. In sitting only, I have to check head tremor. Face, in face there is a jaw tremor, smile, close eyes, open your mouth, purse lips, tremor of protruded tongue, voice tremor, and all that. Archimedes spiral, handwriting I have to check, and dot approximation task. Standing tremors only I have to check. So I have to check in that the knees are 10 to 10 to 20 centimeter apart and are flexed 10 to 20 degree, and the arms are down at the subject side. So these are the few tasks which I have to check in that scale, and according to that I have to scale. I have to rate this thing. Though item are like head, so head, face, tongue, voice, upper limb, lower limb, spirals, handwriting, dot approximation, and standing. And I just want to check is there is tremor or not. The ratings from 0 to 4. Okay. The next one is, so this report describes a mental practice is a novel physiotherapeutic approach that offers a promising means for improving balance confidence with reduction in tremor. Also, from a practical perspective, mental practice constitutes an attractive alternative to other rehabilitative approaches because it does not require physical rehearsal, can be performed without direct supervision, and requires minimal expense and equipment, facilitating ease of use. The further studies are needed. And these are some references I have used. Thank you.
Judges, time for question answer.
Serial number 2, senior number 2. May I just know what exactly mental practice was given, and how could you do it through tele-rehabilitation, and how many sessions of tele-rehabilitation per week, and for how long each session lasted?
Yeah, ma'am, I have taken 15 sessions. On day first, I have checked. It is like the scale, the active essential.
Don't tell me the scale. I do not want to hear about the scale, which you have explained very rightly and very in depth in the slide presentation. What I want to know more about is the intervention. How was it given?
Okay. So for mental practice, whatever I have checked in scale, head tremor, face, and all that only I have told them just mentally imagine like the stand on tip and reach something above your head, stand on chair and reach something, to take out of it are bumped into by people. And when you are walking in a mall, someone is striking you, and how you will prevent from striking with others and all. Step on and off the accelerator while holding the railing and all. So these are some activities the patient has just imagined.
No, no.
And
So everything was So everything was only through verbal feedback. So nothing
only
was
no
visual.
no
Nothing
no
was given
only
to
on
them.
no only mental practice I have given on
Yeah, for
tele-rehabilitation
mental
only.
practice only, dear. No, for mental practice only. Only verbal input was given to the
only
patient.
verbal yeah ma'am, only verbal input I have given to him.
There was no physical practice given at all. It was only mental practice.
Yeah, it's only mental practice.
Okay. The patient did not perform any exercise or any
No,
activity on his own.
no,
Other than
no.
what your activity was given.
No, only mental activities. That what activity I have told, I told you, na, that only he was just imagining, and he was not. He is 71 year old epileptic. The male patient is.
Yes.
So
Did you check his cognition before giving mental practice?
yeah. He is cognitively well. He is well oriented to time, place, and person.
No, the cognition is a different thing. Did you check his using any scale for his cognition?
No.
Epileptic since ages, right?
Yeah. I have not checked, ma'am. For cognition, I have not taken any scale or something like that. But he is what I am comprehending to him, what I am communicating to him. He is very well understood what I am telling to him, because he is taking physiotherapy since 2017, and he is my patient.
Okay,
So
yeah, just one thing. The essential tremors which you said, where were the tremors more? Was it hand, legs, trunk?
Yeah, very good question, ma'am. Thank you for your question. The tremors is in like upper limb only. Like
only
it
upper
is
limb, right?
only upper limb, and there is and while writing or reaching any object, the activity specific tremors are there specifically.
So do you think there is a correlation in between upper limb tremors and ABC?
Yeah. There is I need to study more, ma'am. In that, I will do a detailed study of it. Maybe I will take more sample size and will study further for it.
Reminder, 2 minutes have been done for the questionnaire. Thank you.
Yes, ma'am. Thank you, ma'am.
Thank you. Is the senior presenter of neuro paper presentation 01 ready?
Yes, ma'am. I'm ready.
Okay. We'll start with you. Okay, you are ready?
Yes, ma'am.
Your time starts now.
Good afternoon, one and all.
Be loud. You're not audible.
Am I audible now?
Little louder.
Okay, ma'am. Now?
Please move to closer to mic.
Yes, ma'am. Am I audible now?
Yes. Perfect.
Oh, okay. Thank you, ma'am. Okay. Good afternoon, one and all. My code is Rehab-e-Con senior category neurology 01. Topic of my presentation is effect of art-based play therapy on upper extremity functions in young child with unilateral cerebral palsy, a case report. Next slide, please. Next slide, ma'am. What exactly happens in the upper extremity functions affection in hemiplegic cerebral palsy is that hello.
Just a minute, we are trying.
Yes.
Yeah, you can start.
Yes. Okay, ma'am. So children with unilateral cerebral palsy, they have mild to severe involvement of upper extremity based on their affection of the brain. So involvement is in terms of like shoulder adduction, internal rotation, elbow flexion, wrist and forearm in pronation, wrist in mainly in flexion, or sometimes thumbs are into adduction. Next slide, please. So the case study I have taken is here a 2-year-old male child who has been diagnosed with left unilateral cerebral palsy, and he was having difficulty in using his upper extremity for his functional activities. While playing, his shoulder was moving into adduction, internal rotation, and elbow was frequently going into flexion with the too much of pronation in the forearm, and fingers were going into curling. Study procedure, the informed consents were taken for the from the parents to include the child into the study. Then communication skills of the child were assessed. Then sensations for the left upper extremity, then muscle tone, range of motion, strength in pattern, reflexes were recorded for left upper extremity. Then pre-treatment quest score was recorded. Then advanced play therapy was given to the child, and post-treatment quest score was recorded. So, in the assessment, what we have found is that there was a grade 1 tone in the elbow flexors as well as in pronators. Strength in pattern for the left upper extremity was grade 3. Then DTR was slightly exaggerated for the bicep. And left upper extremity was a little bit lazy, and a child was having neglect towards his left upper extremity. He was not paying attention to the left upper extremity while doing activities. So it was basically lazy. So outcome measure here used was the quest score. Quest is basically a quality of upper extremity skill test. It is very much useful for the young child who are less than 3 years of age, and it has good inter-rater reliability and validity. And quest basically assesses the quality of upper extremity functions. It has different components in the quest. The dissociated movements are there. Then grasp component is there, weight bearing, and the protective extension. So all these components are basically assessing the quality of movements of upper extremity, and the components of the quest are arranged in the developmental sequence. So management given to the child was my official release was given prior to the treatment. Then as the major problem in the child was difficulty in opening hand on commands or while performing activities, as well as excessive pronation of the hand was there, and child was not actively participating in the therapy. So what we have given is we have used different types of colors. Paint colors were used, and to put the colors on the hand, the child was asked to completely supinate the hand and open up the whole fingers and the hand, and then only the color was spread on the hand, and then child was asked to give the handprints on the different types of papers, so that so each activity was repeated with different types of color. For supination, we have asked the child, we have made it compulsion to put the color only if the child supinates the hand. Then color was put on the hand, and child was asked to use to hold the different types of objects and to give that print of the hand on those objects. So next slide, please. So for improvement of the grasp, we have used we have asked the child to print different types of different shaped objects, as well as different types of stamping tools were used, which are commercially available in the market, as well as we have used cutout apple as well as cutout potatoes for stamping tools to improve the grasp in the child. Then child was encouraged to dip those tools into the color and then print it on a paper. And each activity was repeated with different types of color and different types of shapes. Next slide, please. Then as we have found that the left upper extremity was basically lazy, so we have used the gel based color and asked the child to spread the gel based color on the left hand with his own right hand, and we have asked the child to get the visual feedback while performing this activity, and we have performed this activity in a quiet room so that the child can pay full attention to the treatment. Next slide, please. So total duration of the therapy was approximately 45 minutes to 1 hour. It depends on the child's participation in the therapy as well as mood of the child. Then treatment was given for 6 days a week, and total duration of the therapy was 2 weeks. Next slide, please. Then we have compared here pre and post treatment quest score. Here we have compared the three components of the quest, and we have calculated the data. So out of that, initially pre-treatment quest score was 23.42. So after treatment, it was 68. Post treatment, it was 68.3. Then different components when we have compared like dissociated movements, initially it was 66 and it has improved to a much a greater number, that is 92.18. Much improvement was seen in the grasp component, which was initially having negative score of minus 3.72, which has improved to 40.74. Weight bearing has improved from 8 to 72. We have not checked the protective extension component.
1 minute is left.
Yes, ma'am. So basically what we have found is here the improved component was dissociated movement as well as grasp. Next slide, please. So it can so we can in the present study we have undertaken this to determine the post-treatment effects of child-friendly art-based play therapy on upper extremity quality of function. So quest score has improved, so it can be concluded. Next slide please. It can be concluded that the art-based play therapy may be beneficial in improving the quality of upper extremity functions in children with unilateral cerebral palsy. So next slide please. Next slide. So we have not done a long-term follow-up study for this. So the drawback is that the sustained improvement cannot be studied. And next slide. So features, we have studied this on the left hemiplegic unilateral cerebral palsy, but the same study can be carried out on the right hemiplegic hand, so that the differences due to perceptual disorders can be studied later on. Thank you.
Over to judges. Over to judges.
I just have one thing that was he a right dominant child classically?
Yes, ma'am. Basically, he was right dominant. He was using, but since childhood, he was using right hand. So that we cannot comment whether it was because of his involvement or whether it was preference was because of a lack of strength in left upper extremity, or whether it was his dominance.
Okay, fine.
Thank you, ma'am.
Are you ready? Code number 3.
Yes, ma'am. Am I audible, ma'am?
Yes, you are. Your time starts now.
Okay. Good afternoon, everyone. My research topic is effect of cognitive sensorimotor training versus repetitive facilitation exercises on quality of movement of upper limb, functional activity, and range of motion of upper limb in hemiparetic patient. This is a comparative study, and my code is 03. Next slide, please. Introduction. As we all know, stroke is a sudden loss of neurological function caused by the interruption to the blood flow to the brain. Large number of people who survive a stroke are left with permanent impairment of an arm and hand even after the completion of conventional rehabilitation program. Need of study, recent review of the randomized clinical. Ma'am, the slide is not clear.
Is it clear now?
Yes. Need of study, recent review of randomized clinical stroke rehabilitation trial on intervention for motor recovery after stroke show that CIMT, robotic arm training, therapist provided exercise program and repetitive task training did not improve affected arm hand function when used in acute stroke. The standard neurophysiological facilitation technique used for hemiplegic upper limb have not been confirmed to promote functional recovery in hemiplegic limb. This promotes that more research needs to be conducted for the same. Cognitive sensorimotor training therapy and repetitive facilitation exercises, both techniques will promote the functional recovery of hemiparetic upper limb and hand function by improving joint perception and realization of the movement. Hence, this study aims to compare the effectiveness of cognitive sensorimotor training versus repetitive facilitation exercise on quality of movement of upper limb, functional activity, and range of motion in hemiparetic patients. Next slide, please. Research question. Will there be any difference between cognitive sensorimotor training and repetitive facilitation exercises on quality of movement, functional activity, and range of motion of upper limb in patients with hemiparesis at the end of 4 weeks of intervention? Next slide. Aims and methodology. My aim of the study was to determine the effect of cognitive sensorimotor training versus repetitive facilitation exercise on quality of movement of upper limb, functional activity, and ROM in upper limb in patients with the hemiparesis at the end of 4 weeks of treatment. Research design was experimental study. Sample size was 38, that is 19 in each group, and sampling method was simple random sampling. I have included the patient both male and female with the age 18 to 79 years. Patient with stroke, confirm on MRI. There should not previous history of the stroke. The MMHC score should be more than 21 out of 30 and Brunstrom recovery stage score should be more than 4. I have excluded the patient with the severe sensory disturbances, pain and contracture, patient with hemi-neglect and any other musculoskeletal condition like frozen shoulder and any fracture of the upper limb. Next slide, please. My outcome measure for the study was first motor evaluation scale of upper extremity in stroke patient, that is MES-UPS scale. This is a scale to check the quality of the movements of upper limb in stroke patient. The psychometric property of this scale was the reliability 0.99 for arm and 0.97 for the hand function, and validity for MES-UPS is 0.87. Barthel index, it is mainly used for to check the functional activity in the patient. Reliability was 0.94 and validity for is 0.59. And for the range of motion measurement, I used universal goniometer. Next slide, please. Now this is the flowchart of the study. I selected 38 subjects with the random selection, and they were divided into two groups, that is group A and group B, 19 patients in each group. And before the starting of the intervention protocol, the pre-intervention MES-UPS, Barthel score and range of motion were recorded. In group A, I have given cognitive sensory motor training treatment for the 5 times in a week for 4 weeks, that is 30 minutes each session. And group B participant to receive repetitive facilitation training for 30 minutes in 30 minute session for 5 weeks, that is for the 4 weeks. And post intervention MES-UPS score, Barthel index and range of motion were recorded, and data was analyzed using Wilcoxon sign test for within the group, and for between the group I used Mann-Whitney U test. Next, please. Now I'll start with my treatment protocol. I'll explain the treatment technique with the images. Next slide, please. So ma'am, next slide, please. Yes. In group A, the patient treated with the cognitive sensory motor training technique. In this technique, you can see the patient is blindfolded while doing the exercise. Okay. And they were asked to concentrate on movement first. Therapist first passively move the joint in different positions, that is from proximal joint to distal joint. Therapist first move the joint in one direction, then wait for few minutes, ask the patient to mimic the same movement, and likewise, the progression is made by changing the plane of the movement, that is forward flexion and backward extension of the shoulder should be the first progression, and the second progression made with the abduction and adduction plane, and then medial and lateral rotation for the third plane. And according to this, the plane of the movement should be changed. So this is about cognitive sensory motor training. Next slide, please. In group B, I have taken repetitive facilitation exercise protocol. In this, even in this, the proximal to distal movement pattern are given to the patient. Ask the patient to move the joint. Ma'am, next slide, please. Okay. In the repetitive facilitation exercises, I have given the movement protocol as the patient to actively move the joint, and I applied the pressure over the muscle belly from proximal to distal manner to facilitate the muscle. As this follow the principle of neuroplasticity, more the repetition, more the motor learning, and as the more motor learning is there, the recovery is better. So repetitive facilitation exercise is all about. Next slide, please. And in conventional therapy, the control activities such as range of motion stretching, active assisted range of exercises, and modified aerials are given to both the groups. Next slide, please. Now I'll start with the statistical analysis. In first diagram, you can see there is a pie diagram showing comparison of mean age difference in group A and B. And in second and third, there is a pie diagram for the gender-wise distribution in group A and B. In group A, 11 male and 8 females were included, and in group B, 7 male and 12 females were included. Next slide, please. Now in this slide, you can see there are three graphs showing pre and post treatment outcome measure score in group A. These all three graphs are showing CSMT, that is cognitive sensory motor training.
Ma'am, your
Okay,
time
ma'am.
is
Thank
up.
you. Yes, thank you, ma'am.
Yes, judges, up to you.
You have said the study design is experimental study and your sampling technique is simple random sampling. So why it cannot be randomized control trial?
Yes, ma'am, it can be, but I choose both the experimental techniques, so I compared both the techniques.
So that is why, but then the sampling technique that you have said is a simple random sampling. And you didn't mention as to how the allocation to the two groups was done.
Yes, ma'am.
The method of allocation to two groups you haven't mentioned.
The random selection was there, ma'am. All odd numbers
there is a
will be.
procedure of allocating to the two groups. So that you
Yes,
could
yes,
have
ma'am.
mentioned, you know, how
Yes,
you
yes, ma'am.
have done
Sorry.
that.
Yes, yes, yes.
So otherwise it was fine. Thank you.
Thank you, ma'am.
Ma'am? Ma'am, can we proceed?
Yes, yes.
Ma'am, 04, code 04 is not participating, ma'am. So we are going to start
Judges,
with
please
05.
note. Judges, please note. Code 04 is
Done.
not participating.
Right.
So code 05 is ready?
Yes, ma'am, I'm ready. Am I
The time
audible?
starts now.
Can you hear me, ma'am?
Yes.
Okay, I'll start. Good afternoon. My topic of presentation is comparison between effects of mirror biofeedback and EMG biofeedback on patients with Bell's palsy. Next. So introduction, basically idiopathic peripheral facial palsy or Bell's palsy is a lower motor neuron or lesion of 7th cranial nerve, which affects both the sexes. And basically it is characterized by Bell's phenomenon. And this is all the introduction about Bell's palsy. Next. Before proceeding to the methodology, I'll tell about the purpose of my study. It is to compare the effects of EMG biofeedback and mirror biofeedback therapy on patients with Bell's palsy. And I have included the objectives to find out the effect of mirror biofeedback on patients with Bell's palsy, to find out the effect of EMG biofeedback on patients with Bell's palsy, and a third one to compare the both. Now we'll proceed to methodology. In this study, we have selected 20 patients aging between 18 to 60 years of age group. And patients with central facial palsy were excluded. And then the patients were divided into two groups by CHIT method, that is randomly it was sampled as group A and group B. Group A was given the treatment of mirror biofeedback, whereas group B was treated with EMG biofeedback. And before starting the first session, pre-assessment was taken by using House-Brackman grading scale and facial grading system. And also after the last session, the same outcome measures were taken. The treatment was mainly focused on these three muscles, that is the frontalis from upper trunk, buccinator from middle trunk, and the orbicularis oris from the lower trunk. Next. So the first group in this group received 22 minutes of treatment, including 2 1/2 minutes of massage and 13 exercises in front of a mirror. It is given, basically the 5 repetitions were given for 2 weeks. So 6 days in a week. So the total sessions were 12. Also, to make it fulfill ethically, we have given IG current stimulation, 30 contractions per muscle. So the 90 contractions were given, 3 sets of 30 contractions. And also we have included these exercises as elevating eyebrows, elevating of corners of the mouth, scrolling. Next slide. Closing alternating eyes, saying A, E, I, O, U, and all the exercises of motor exercises of muscles supplied by facial nerve. So this is the figure in which you can see. Group B was treated by using, that's okay, EMG biofeedback. In this, also 12 sessions were given for 2 weeks, 6 days in a week. And here also we have given IG stimulation to all the motor points, 30 sets of 30 contractions and 3 sets. So totally 90 contractions were received. Next. Here, before starting the treatment, the patient's preparation and the other preparation of the skin was done in order to reduce the impedance. After that, the reference electrode was attached to the right wrist. And after that, the muscle which is to be tested, on that muscle, we have kept the active electrode and we have asked the patient to remain at rest for some time, for 15 seconds, to note down the spontaneous activity of the muscle. After 15 seconds, we have asked the patient to contract the muscle and we have noted the activity. Each muscle is tested for 3 times and we have taken the best score out of which. And for the treatment purpose, we have used that best score and we have asked the patient to contract till that level for gaining more benefit. Next. So this is the diagram which shows about the placement of the electrodes by using EMG, surface EMG. Next. Next. So after finishing sessions, again, outcome measures were carried out to compare pre-post score of the same group. Next. For the statistical analysis, to compare pre-post scores of the House-Brackman scale, we have used Wilcoxon signed rank test. And to compare the values of Sunnybrook scale, pre-post scores, we have used paired t-test to compare in the groups. Then to compare between the groups, we have used Mann-Whitney rank sum test to compare House-Brackman scale scores. And we have used unpaired t-test to compare the values of Sunnybrook scale scores. Next. So here we can see the results. These are the graph which is showing about group A, that is treated with a mirror biofeedback. So the sample size of each group was 10. By using House-Brackman scale score, here we can see the p-value of 0.06, which is not statistically significant. Next. This group shows the comparison between Sunnybrook scale scores by using mirror biofeedback. So here the p-value has come statistically significant, that is 0.00. Next. Now we have done the comparison pre-post scores of group B, that is which was treated by using EMG biofeedback. So the sample size was 10 and here also the p-value is 0.03. So it has shown statistical significance. Then the next was by using the scores of Sunnybrook scale. Here also we have used paired t-test and the value of p is 0.00. So it has shown statistical significance. Next. Now we have compared between the groups as A versus B. So the first score. Hello, can I continue?
One minute is left.
Yeah. So the comparison is done by using pre-post scores. Next. So here, next slide, we have not found any statistical improvement by using this scale. Next. Next slide, please. Next. When we compared the scores of Sunnybrook scale, that time also we have not found anyone is better statistically. But clinically, we have found that the EMG biofeedback is better. So the conclusion of the study is mirror biofeedback and EMG biofeedback has shown statistically significant improvement in overall outcome measures. But when we compared both the groups, there was no statistical significant improvement found. Next. Next. Limitation of the study was small sample size, and the future scope, this same study can be done on the larger sample size by using larger sample size, and the same study can be continued by doing the study on central Bell's palsy or the central facial palsy, we can say. Next.
Over to judges.
Next slide.
Ma'am, your time is up.
This is references, and thank you.
Judges?
Yes, it's done.
Just a quick query. Was there any medical support given, like as in steroids or anything of that sort? Both the groups? Did you have any?
Yes, ma'am. Patients were on medication. Yes, because they were selected in the acute phase of Bell's palsy. Yes, for every patient.
Okay.
Medical support was there.
Yeah.
When the study was conducted, when these patients were treated?
Actually, ma'am, it was before starting the lockdown. So the treatment was done on the patient-to-patient basis. It was
Before
done in
starting
OPD.
So almost a year
Yeah,
back.
before March. Yeah.
And what was the cause of Bell's palsy in these patients? Overall.
Only the idiopathic cause. The patients with idiopathic causes were only selected.
What do you mean by idiopathic cause?
And also we have, like ma'am, the first thing, when the patient were not knowing about the cause, even we have selected the patients by otitis media, which led to the Bell's palsy, and also cold exposure patients. So
it was
we have
before the
excluded
lockdown,
basically
dear. It was before the lockdown, you said. So there was no
Yes, ma'am.
question of COVID exposure.
No, I didn't say cold exposure, ma'am.
Okay, cold exposure. Okay.
Cold exposure, not COVID. Yeah.
Okay. So idiopathic is the patient doesn't know what is the cause.
Yes, the cause is unknown.
Okay. Done. Thank you, dear.
Okay, thank you, ma'am.
06? 06, are you ready? Zero 06? 06? 06, are you there?
Zero 06, please unmute yourself.
Zero 06, are you there? Should we move ahead with 07?
This is junior going on, right?
No. Senior 06. Okay, we'll move ahead with senior 07. Are you there?
Yes, ma'am. Am I audible?
Yes. You are 06 or 7?
07.
06 is also here.
Okay, 06 will continue with you later. Your starts now.
Good afternoon, everyone. The topic
Code is 07.
The topic for my project presentation is comparison between the effects of rhythmic auditory stimulation and conventional therapy, with conventional therapy alone in improving the upper extremity functions in subacute and chronic stroke patients. Please change. Stroke is a leading cause of adult disability with a prevalence rate of around 84 to 262 per 1 lakh patients in rural area and 334 to 424 per 1 lakh in urban areas, and incidence rate being 119 to 145 per 1 lakh. Upper extremity impairment is one of the most important challenge which is experienced by nearly 3/4 of the stroke survivors. Several conventional therapies are available for upper extremity therapy, but in light of these data, alternate strategies to reduce the long-term disability was required. Rhythmic models of motor re-entrainment, such as rhythmic auditory stimulation, thus represents a prominent approach. Rhythmic auditory stimulation is a technique by which a series of auditory stimuli are presented at a fixed rhythm so that the patients have to synchronize their movements to the rhythm generated from a device. Please change. Very few studies have been done on the use of RAS in improving shoulder and hand functions, hence the need of the study. Rhythmic auditory stimulation is a technique by which a series of auditory stimuli are presented at a fixed rhythm so that the patients have to synchronize their movements to the rhythm generated from a device. Please change. Very few studies have been done on the use of RAS in improving shoulder and hand functions, hence the need of the study. The aim of the study is to compare the effects of rhythmic auditory stimulation plus conventional therapy with conventional therapy alone in improving the upper extremity functions in subacute and chronic stroke patients. Objective is to find out the effects of rhythmic auditory stimulation and conventional therapy in improving the functions of upper extremity in subacute and chronic stroke patients using Fugl-Meyer scale. Methodology, the study design is experimental study setup being PCMC area, duration of 7 months. Let me please correct this. Type of sampling is also convenient sampling with a sample size of 30. These are the materials used. This is the digital metronome and the target matrix template, which is a 28 consecutively numbered targets organized in 36 by 18 inches grid, such that the distance between each targets was 6 inches. 30 participants who fulfilled the inclusion criteria were selected after taking the written consent from them. 2 equal groups were formed. The patients were informed about the treatment. Group A was a conventional group and group B was conventional plus RAS group. Conventional treatment included mobilization techniques, mobility exercises, stretching, strengthening, balance exercise, coordination exercise, and fine movement exercise. Please change. Rhythmic auditory stimulation plus conventional therapy group. In this, the patient was seated at a standard height table with the trunk in contact with the front of the table and back supported. Target matrix template was secured on the table. Target arrays were selected such that the movement will take place in all planes. Please go to the previous slide, ma'am. In this, the patients were then asked to move between the arrays at a self-selected space so that the baseline RAS frequency was established by using the metronome. The patients were then asked to move in sync with the auditory frequency determined by the therapist. 5 to 10 seconds trial of 30 seconds with 15 to 20 seconds of rest between trials and 1 to 2 minutes of rest between blocks of trials was done. So the other different arrays were selected, the inter-target distances were increased so as to require larger movement excursion. Target arrays were selected that would encourage different movements at the shoulder. Difficulty of trials was graded by changing the cue frequency. Frequency was changed once the participant completed 5 to 10 trials in a given target array. This intervention was given 5 times a week and the patient and for 4 weeks. Please change. The outcome measure was Fugl-Meyer assessment scale, which was taken pre-intervention and post-intervention. It has a reliability of 0.98 to 0.99 and a high validity of 0.94 to 0.95. Items were scored on 3-point ordinal scale. 0 cannot be performed. 1, they can perform partially. 2 performs completely. So the domains were assessed for only upper extremity. Subscales can be administered without using the full test. So only the upper extremity subscale was used. In it, the domains were upper extremity, wrist, hand, coordination and speed, sensations, passive joint of motion, and joint pain. So the results were in group A on comparing the pre and post data by using the Wilcoxon sign rank test, the P was found to be 0.001, which is significant. In group P, on comparing the pre and post data, P was less than 0.0001, which is extremely significant. When both the groups were compared using Mann-Whitney U-test, P was less than 0.001, which is extremely significant. Rhythmic entrainment models have emerged as an approach that effectively improves quality of movement such as timing, coordination, accuracy, and stability in neurologic population prior to intervention and compared to unaffected side reach, which heavily relied on compensatory trunk flexion during affected side reach. Following RAS, this overall contribution of the trunk was reduced, and so there was an increased shoulder flexion. There was significant improvement in elbow extension due to the changing inter-target distances in the arrays, which required larger movement excursion and thus encouraging movement against the abnormal synergy pattern. Significant gains in task completion, time, upper limb functional capacity, and the patient's own perceived quality of movement was also seen. RAS showed to increase the excitability of spinal motor neurons via the reticulospinal pathway, thereby reducing the amount of time needed for the muscle to respond to a given command. RAS was proved to have an effect on, please kindly change the slide. RAS was proved to have an effect on cerebral activity by inducing synchronization of movement and rhythm through sensory stimulation. By applying RAS, a movement can be synchronized, and as the patient tries to synchronize their movement with the music, concentration and motor control both are promoted.
1 minute is left.
Kindly change the slide. So conclusion is RAS has an appreciable effect on the quality of movement by decreasing the compensatory reaching strategic post-intervention, positive changes in motor control, thus normalizing the movement pattern. Next slide. Thus, the study demonstrated beginning efficacy in incorporating rhythmic cueing as an integral part of rehabilitation. Limitation of study was multiple comparisons with other interventions was not made. The sample size was small. The results of this intervention investigation only speaks to the utility of the RAS intervention with individuals who have mild to moderate motor deficits in the hemiparetic arm. So clinical implication is rhythmic auditory stimulation can be incorporated in the conventional way of treatment so as to improve the movement quality and thus the functions of upper extremity in stroke patients. These are my references. Thank you.
Judges, up to you.
Just a thing again, how many of you had, how many of your patients were right hand dominant and how many were left hand dominant? Did it have any effect?
Ma'am, this could be added in the future scope of study, but I had mixed patients.
Oh,
Yeah, yes, ma'am.
Questions.
Code 06 is ready. Judges, 06 is there. 06 is there. Please unmute yourself.
Senior presenter, senior neuro presenter 06. Are you able to hear us?
Piyush, is it possible for you to unmute her?
I think she cannot be unmuted.
Piyush? Mr. Piyush?
Actually, Dr. Pallavi Tide is trying to unmute, but she is unable to mute herself. Can someone please unmute her?
Mr. Piyush? Mr. Piyush, is it possible to unmute her?
Have you renamed your PPT?
Login name.
Your login name, please rename your login name as the code.
We have renamed. We have renamed it to SRNR06. Please unmute.
We can hear you.
We can hear you.
Can the speaker come up?
Zero 09 is ready. Is 09 is ready?
Hello.
Yes.
Ma'am, this is 09.
Okay. Are you ready?
Yes, ma'am.
Judges? Kind notification, judges. Please note that we are starting with 09. And 08 is not there. 08 is not a participant. Judges, kindly note that because of some technical error, code 06 is not able to join now with us, and code 08 is not a participant. So we are starting with the code 09. Shall we start, ma'am?
Yes, please.
09, are you ready?
Yes, ma'am.
So your time starts now.
Okay. Good afternoon, everyone. The topic of my study is effectiveness of multisensory balance training versus vision-deprived balance training on balance and gait speed in stroke patients, a comparative study. Introduction, stroke, ma'am, you need to click on the screen. Thank you. Stroke is sudden loss of neurological function caused due to interruption to the blood flow to the brain. So stroke causes the following symptoms, that is headache, dizziness, loss of balance, coordination, then there is weakness on the opposite side in arm and legs, then vision issues and hearing issues. Next slide, please. The need of my study is that stroke causes motor and sensory loss, which contributes to the impaired balance, increased fall risk, and gait alterations. Research has shown that balance has an effect on activities of daily living and walking ability in stroke. Hence, balance training helps improve overall function in stroke patients. Balance training utilizes nothing but it's just the integration of appropriate sensory system. The multisensory exercises retrains the sensory pathways, help adapt to the changed capacities and regain function. The vision deprived exercises helps by ruling out the vision overuse and help the brain improve the long-term memory of the balance adjustments with respect to the environment. Many isolated studies on both the exercise protocols have been carried out in various populations like stroke, diabetics, cerebral palsy children, geriatric population, and Parkinson's disease. There is limited evidence on which training program is more effective. Thus, the present study aimed at comparing two exercise protocols to find out which is more effective on balance and gait speed. My research question is that will there be any difference in effect of multisensory training and vision deprived training on balance and gait speed in stroke patients at the end of 6 weeks of intervention? My primary objective was to compare the effects of multisensory training and vision deprived training on balance and gait speed when assessed using Berg's balance scale and 10-meter walk test respectively at the end of 6 weeks of intervention. Hypothesis. My null hypothesis says that both the exercise protocol were equally effective in on balance and gait speed in stroke patients. Alternate hypothesis, H1 says that multisensory is more effective than vision deprived on balance. H2 says that multisensory is more effective than vision on gait speed in stroke patients. H3 says that vision deprived is more effective than multisensory on balance, and H4 says that vision deprived is more effective than multisensory on gait speed in stroke patients. Methodology, it's a comparative study. The data was collected from community dwelling stroke individuals, hospitals, outpatient departments in and around the city. Population was stroke more than 6 months, aged 40 to 60 years. Sample size was 40, 20 in each group. Ma'am, please go on to the previous slide. Yes, thank you. Sampling method was a random chit method and outcome measures were Berg's balance scale for balance and 10-meter walk test for gait speed. My inclusion criteria was age 40 to 60 years, both male and female, presence of stroke more than 6 months, and who were able to walk 10 meters independently with or without assistive device, had a score of minimental score more than 24 and Berg's balance score of less than 40. I have excluded patients with musculoskeletal or surgical problems of lower extremity, which might affect the mobility. Also, cardiovascular and respiratory problems were included, excluded. Other neurological conditions like brain tumor, demyelinating disease, and subjects with auditory and vestibular disorders were excluded. Procedure, ethical clearance was obtained and written consent was taken from all the participants. 40 subjects were selected based on the inclusion and exclusion criteria and were randomly assigned to two groups. Group A consisted of all even as per the arrival and Group B of all odds. Pre-assessment of Berg's balance and gait speed was done for both the groups, and then Group A underwent multisensory exercises and Group B underwent the vision deprived training. Post 6 weeks, both the groups were assessed for balance and gait speed again, and the data was analyzed using paired and unpaired t-tests. Intervention. The group A consisted of multisensory balance training, which consisted of 9 exercises, that is walking on 3 different surfaces, floor, foam mattress and soft mattress. Then there was obstacle clearance, 1 leg stance on 2 surfaces, soft and floor. Then there was double leg stance, tandem walking and rising from the chair without use of arm. Group B underwent vision deprived training, which consisted of exercises in 3 positions, that is supine, sitting, and standing. Supine consisted of bridging and side turning. Sitting consisted of sit to stand and manual perturbations. And standing consisted of the walking exercises. Data analysis. Group A consisted of 40 male, 60 female, 60% female with mean age of 54.75, and group B consisted of 60% male, 40% female with a mean age of 53.25 years. And there was no significant difference found between the age. The comparison between the group A and group B was done using the unpaired t-test. Effect on balance. On balance, it was seen that there was no significant difference found. Gait speed, also there was no significant difference found between group A and group B. And on comparing the mean differences of balance and gait speed, also there was no significant difference found between group A and group B, as you all can see in the following graphs. Within group comparison was done using the paired t-test, and both the groups showed significant difference on balance and gait speed. So there was improvement in balance and gait speed in both the groups within group. Discussion. So how the brain controls the balance is that various systems give input to the brain, which instructs the muscles to control the balance. Following stroke, there is reduced perception of sensations along with the difficulty in integrating the sensory inputs. Group A protocol trained the patients by providing continuous and various sensory inputs, thus improving perception and keeping the sensory system activated all the time, thus improving the motor learning. Group B protocol worked on the basis that in absence of one sensory system, the other system takes the charge to help the brain adjust to the changes. In this, what happened, the visual system was taken out, and thus the vestibular and the proprioceptive system worked more. Conclusion. The present study concluded that, on comparison, both the groups were equally effective in improving balance and gait speed in stroke patients at the end of 6 weeks of intervention. These are my references. Thank you.
Judges, over to you.
Do you have any reference for the multisensory balance exercises that you had given? Was it an established protocol or was
Yes.
it developed by your own self?
No, ma'am. It was an established protocol. I have a reference for the same.
And also the exercises given in multisensory balance training, were they the same or you kept on changing the sequence or something of that sort?
No, ma'am. The sequence was the same. And I have taken it from the same study. Like there was one study which gave the protocol. I have taken it from there.
Okay.
Balance scale, there is a component which is standing on one leg.
Sorry, ma'am. I cannot hear you. I'm sorry.
Now, can you hear me?
Yes, ma'am.
In the work balance scale, there is one component that is standing on one leg.
Yes, ma'am.
So, in your patients, on which leg did you ask them to stand?
Ma'am, the affected leg. Actually, the protocol that I have, it was on both the legs. I made the patient practice on both the legs, starting with the affected leg and then on the non-affected side.
No. While checking on the work balance scale, you need to choose only one side. So,
Yes,
which
ma'am.
side did you choose? You chose
Ma'am, the affected side. While on assessment, it was the affected side that I checked. But during the training program, I made the patient practice on both the legs. So it was it was given in the protocol to be followed on both the legs.
And by vision deprived balance training, I mean routinely in a normal day-to-day activities, we do not need this particular aspect. So I'm not very convinced with the need of the study.
Sorry, ma'am, I cannot hear you.
Why did you choose widget deprived balance training? Because in a day-to-day life, we do not need this. So I am not very convinced with the why of the study or need of the study. So can you explain that?
Ma'am, my basically my need of study was to compare both the protocols that were already established. They had individual effects on both balance and gait. So my study aim was to compare the effects.
Yeah, but then what does clinical implication does it have?
Ma'am,
What ma'am is trying to say is, why did you choose vision deprived? Because multisensory is okay, but why vision deprived, especially in stroke patients? You do not require that in any of your ADL activities, right? So why did you choose the vision deprived protocol?
Never mind.
Yeah.
Okay. All the best.
Are you there?
Yeah, yes, ma'am.
Ma'am, shall we proceed with the next presenter?
Yes.
Code 06, are you there?
Yes, ma'am. I'm there. Am I audible?
Yes. Judges, kindly note, it is SR on screen. It is JSR. The code JR code is there, but it is a SR number 06.
Should I start, ma'am?
06, your time started now.
Yeah. My topic of presentation is effect of proactive and reactive balance training on postural instability in patient with Parkinson disease. Introduction. As Parkinson disease, it is a neuroprogressive disorder characterized by the cardinal features of rigidity, bradykinesia, tremors, and postural instability. Postural instability consists of alterations in postural control strategies during standing tasks when it responds to unexpected perturbations or when performing any voluntary movement. Anticipatory postural adjustment are used in a proactive manner to stabilize the body before doing the voluntary movement. And in terms, this APA, that is compensatory postural adjustment, are uses the feedback. It leads to adjustment to the unexpected perturbation. Literatures have shown that anticipatory postural actions firstly act and it is firstly followed and by the compensatory reaction in terms of muscle activity. Literature also showed that there is a decrease in magnitude of muscle activity in patient with Parkinson disease. My need of the study was the postural instability in Parkinson disease may involve changes in both compensatory, anticipatory and compensatory postural reactions. Studies have shown that dopaminergic medications may produce a limited improvement in postural instability. Early automatic postural responses are only partially corrected, while later occurring postural corrections do not improve at all. Thus, it leads to postural instability, it leads to loss of balance, there is an increasing number of falls, there is a fear of fall, and thus there is a decrease in functional independency. My research question, will there be any effect of proactive and reactive balance training on postural instability in patients with Parkinson disease after 4 weeks? Aim to study the effect of proactive and reactive balance training on postural instability in patients with Parkinson disease. My objectives are to study the effect of conventional balance training on postural instability in patients with Parkinson disease using activity-specific balance confidence scale, Berg balance scale, and motor components of unified Parkinson disease rating scale. My second objective was to study the effect of proactive and reactive balance training on postural instability in patients with Parkinson disease using the same outcome measure. And my third objective was to compare both the effect with conventional and experimental group. Methodology, research design was experimental, study place Parkinson Society, urban city, study duration 1.5 years, sample size 20, sampling type is convenient sampling. Yes, next slide please. Inclusion criteria: patient who did not require any assistance to rise from chair or bed, that is grade 3 on yard scale. Patient who had no any other neurological conditions or mental deterioration. My mini mental state examination score will be greater than 23. Both genders, age 55 to 65 years. Exclusion criteria: patient having severe dyskinesia, patient having unstable cardiovascular diseases, or any other chronic condition that could interfere with their safety during testing procedure. In conventional therapy exercises for group A, the treatment consisted of active joint mobilization, muscle stretching, and motor coordination exercises. During each session, the patient started in lying in carpet, then in sitting, and then in standing position. The week protocol is given in early in 2 weeks. There is a 30-minute duration of exercises is given, and in later on it is progressed to 60-minute duration in next 2 weeks. In group B, the proactive exercises. Coming to the last slide, please. The proactive feedback exercises consisted of stand on the floor and sway between a chair, stand on a stepper and reach out for a ball, throwing a ball and catching a ball, turning the ball sideways, transfer the body weight onto the tips of the toes and into the heels, walking over the obstacles, coordination exercises like arm swing during the walking. My reactive, next slide please. Weight shifts in multiple directions sitting on a Swiss ball, reach out for a ball, stand on a stepper, cross the hands across the chest with eyes closed, perturbations in different directions, stand on a foam mattress of medium consistency and maintain the balance. These are the my results of the study calculated by with the normally distributed data by Wilcoxon sign rank test and pair T test, and with non-normally distributed data it is calculated by Mann-Whitney test and unpaired T test. So table 1 shows the group A, that is epidaris component of motor components. So here all the components that is arising from chair, posture, and the posture instability shows significant effect improvement rather except the gait component. Yes, next slide please. Next slide, please. The group B, same. All the three components show the significant effect except the gait component. When I compare with group A and B, then I found the significant effect in postural instability and except the gait component. So here I found when I compare with group A and B, only the postural instability component shows significant effect, where rest of the component did not show any significant effect. Yes, next slide, please. So in group A and group B of ABC scale, so here there is a significant improvement within group, and even I compared with the both group, then it was found that group B shows more significant effect than the group A. Yes, next slide, please. In work balance scale, both the group show significant effect within the group, and when in between the group B shows more significant effect than group A. So discussion around the study, that is group A showed more significant effect. So likely reason may be the focus on to maintain the physiological elasticity, contractility, and provide sensory feedback from contractile muscle to develop coordination and motor skill for functional activities. My group B shows more significant effect. So possible likely reasons are the feedback and feedback reactions are pre-programmed in the CNS, and in advance it leads to commands to both focal and postural muscle, and then to feedback to initiate and stabilize the posture. Group B shows more significant effect than the group A. So David and Konarasan et al. He stated that highly challenging exercises, which is emphasis on motor and cognitively challenging balance exercises, show more improvement than the control group with visual care. My gait component of epidaris did not show any effect. So Rosin et al. He stated that gait initiation problems in PD were not any result of any discoordinated movement, but it is due to the deficit within the basal ganglia internal cueing for the movement sequences. Yes, next slide, please. Conclusion of this study. Present study concluded that the proactive and reactive balance training was found to be more effective than conventional balance training on posture instability in patients with Parkinson's disease. Limitations of this study. All the tests in this study were clinical tests. Use of appropriate computerized system to evaluate for posture instability was not used. Long-term follow-up was not taken. Yes, next slide, please. The further scope of these studies, the effect of proactive and reactive balance training. Next, previous slide. Yes, coming toward the previous slide. It can be studied the different stages of Parkinson's disease.
1 minute left.
Yes. Yes. Next slide, please. Next slide, please. Next slide, please. Clinical implication of this study is that the feed-forward and feedback exercises should be incorporated in clinical balance training, and this combination of exercises will help to improve the postural stability among the Parkinson's disease patients. Next slide. These are my references. Next slide, please. Yes, next slides. These are my references. Thank you so much.
Judges, over to you. Judges, over to you.
Time the study was conducted, what was the
Yes,
overall
ma'am.
time duration of the study?
1.5 years.
And you have shown the sample size calculation formula.
Yes, ma'am. That is for
In your
formula
slide.
for the prevalence. Yes, 4PQ upon L square. So according to the prevalence of Parkinson disease, I have
So this
calculated.
particular
Yes, ma'am.
So is this a routine neurorehabilitation setup or is it a Parkinsonism?
Ma'am, it is a Parkinson
Center?
society. Parkinson center is there.
So what is the use of taking the prevalence formula? Anyways, all patients are with Parkinsonism.
Ma'am, there is a less prevalence.
So that formula of sample size calculation would not be applicable in this case.
Ma'am, the prevalence as I have taken, that is very less. So I have taken this formula to calculate the sample size. So yes, it can be taken as a purposive sampling that the patient's availability is there. But I go through the formula of the study that the prevalence and then calculate the sample size. So
that's what I'm saying here. Prevalence is out of so many neuro patients, these many patients are of Parkinson.
yes, ma'am.
100%. Won't it be?
Yes, ma'am. Pardon, please. I'm not able to hear you properly.
Or is it? Okay. Fine. Good study.
Thank you, ma'am.
Code number 10 is ready.
Yes, I'm ready. Can you hear me?
Yes,
Hello?
yes, we can.
Yeah.
Please start your
Should I
time.
begin?
Yeah, your time is start.
Yeah. Good afternoon to one and all. My research study is on risk factor and identification of mild cognitive impairment among normal middle-aged adults. Now, as you know that cognition is very crucial for human thinking and experience, as cognition is a process of selecting, storing the information which is required in our daily activity. Any decline in cognition will definitely lead to memory loss or difficulty in attention, difficulty in problem solving, and this, if not treated, will eventually lead to dementia or Alzheimer, which in turn will cause the patient to depend on the others for their caretaking. Now, it has been seen that the age-related changes occurs in the mid-20s. Now, there was a lot of studies done where we have found that in the age group of 45 to 49, the prevalence rate of cognitive decline was 3.6%. Now, in the past few decades, India has experienced a lot of changes. There is a lot of urbanization and lifestyle has been changed along with the environmental changes. Now, this eventually will lead our people to expose to a lot of risk factors for dementia, and maybe there is an increase in prevalence. Now, the risk factor, to name few, are modifiable and non-modifiable, which includes age, gender, diabetes, comorbid conditions, etc., and so on. Mild cognitive impairment, which I'm going to term it as MCI throughout my PPT, is a transient phase between the normal aging and dementia. This is basically when the patients start to develop some complaint and can be objectively evident, but there is no evidence of dementia, and the stage is reversible, and if intervened can lead to prevention of dementia. The reversal rate was 25% in the study done, a meta-analysis study done on 25 studies. So in India, there is dearth of literature on MCI, and therefore I intended to study the prevalence and multiple risk factors associated with it. The aim and the objective. The aim is to identify the MCI. The aim is to identify MCI and the risk factors, and my objective is to find a prevalence in the age group of 40 to 60 by using Edinburgh Cognitive Examination Scale, which is third one, to know the association between the variables and the socio-demographic variables and MCI, and to explore the risk factor for predicting MCI. It is a community-based cross-sectional analytical study on the age population of 40 to 60. By using a convenient sampling, I have gathered the sample from different societies, recreational area, workplace in Pune district of Maharashtra, in the sample size of 605. With the inclusion criteria of 40 to 60 age group, male, female, both were included, and individual who had some cognitive issues like the one who is suffering from TBI or Parkinson or stroke patient were excluded. The one who is having any psychological disorder or are on antidepressant or antipsychotic drugs were excluded. The cognitive function was assessed by Edinburgh, which is very sensitive and specific scale with a cutoff of 88. It assesses the 5 domains of cognition and are available in different languages of India. The study was approved from the institution ethical committee, and therefore the individuals were selected as per the inclusion and exclusion criteria. Written informed consent was taken from each of the participants. Socio-demographic data was interviewed with each individual on age, gender, education level, marital status, and living arrangement, and cognitive function was assessed by ACE3. The data gathered was put in Excel and analyzed by EpiInfo. The frequency and percentage tables were calculated. Mean and standard deviation was taken for quantitative data, and for categorical data, chi-square test was applied. Odd ratio was calculated by binary logistic regression to assess the risk factor, and the level of significance was kept at p less than 0.05. Next, please. Next, please. Change the slide, please. Next. The prevalence of MCI in age group of 40 to 60 in a middle age was seen to be 27.7%. Next. When compared with gender, females were more affected than the male with P less than 0.01. That shows highly significant. Next, please. Age group. When I divided the age into 4 categories from 5 in each, so I've seen that there was an increasing trend of MCI as the age advances. So at the age of 46 to 60, the percentage was 40.6. Next, please. The level of education in MCI, when it was compared, it was seen the one who has higher education were less likely to have MCI or decline in cognition as compared to one who has just done their schooling or were in the primary group. Next, please. The marital status and MCI. Next slide, please. The marital status, when compared with MCI, it was seen that the one who has lost their spouse had greater cognitive decline, followed by married people, and less likely in unmarried and divorced people. The living arrangement and MCI. Next slide, please. Living arrangement and MCI, when compared, it was seen that the one who is living in an extended family had more cognitive decline, followed by the one who is staying alone and less likely in the nuclear and the other group. Next slide, please. Next slide, please. Take it next.
1 minute is left.
Next slide, please. Slides are not getting changed. The risk factor, when calculated, it was seen that age and level of education were the more were at the risk of predicting the MCI. Next slide, please. In the discussion, I would say that it was a cross-sectional study with the prevalence of 27.7. And in India, the prevalence rate is ranging from 8.8% to 33% in the age group of 55 and above. And there were very limited study done or explored in this age group, that is 40 to 60. Next slide, please. There were studies which state that there are structural and functional brain changes in the gray matter volume, which had begun from the age of mid-20s, as there is change in the temporal lobe, which is related to hippocampal volume reduction, and therefore the memory loss was seen. Also, with aging, there was changes in the brain function. There was decreased capillary density, narrowing of the lumen. Therefore, we saw in this study also, as the age advances, there was decline in the cognition. As we saw that females are more affected. So there was a last study done in 2019 abroad, which states that female undergo a lot of stressful event, and therefore those hormonal changes has a direct effect on the brain, on the hippocampal area, and therefore maybe females are more affected as compared to male. Also in the study done in India, it supported the same, that females are more affected than the male because of the hormonal variation. There are certain studies which also says that gender and cognition may not be eventually related. Next slide, please. A level of education has an impact. They say the more the person is educated, the cognitively charged environment, which helps the brain structure and function, which is beneficial for the brain structure and function, and therefore the one, yes, ma'am, I just concluded. And therefore the conclusion is that there is.
Session will not be held if you will continue.
Just I'll conclude it, ma'am. The prevalence rate is alarming, and therefore we need to include cognitive assessment also as one of the tool in this age group. Thank you. These are the references. Thank you, ma'am. Next slide.
Judges, over to you. Judges, over to you.
I always have this issue of, whenever the study is conducted on normal, healthy individuals, and, they are otherwise normal, and with your study, they become the patients.
Ma'am, it's not regarding that, but I think so we need to explore this age population also, because the studies are saying that it's always the geriatric which have been focused for cognitive decline. We are not labeling them as decline people, but then definitely we need to screen them so that early intervention can be given. And these are the certain risk factors which we can take care of later on. And maybe further more risk factors like the one which is modifiable can be taken into consideration.
I think that whenever you are including the participants in your study, they should be thoroughly screened for everything, unknown depression, unknown things which are not set in your inclusion and exclusion criteria can have an effect on your MCI, right?
Yes, ma'am. Yes, ma'am. Very true.
When said that there is staying in a group or in a family, extended family, death of a spouse.
Extended family.
So that may mean that there is an unseen, unnoticed depression which is there, which may have an effect on MCI. So before labeling, it's not that you are labeling them as having MCI, but before having this conclusion, a thorough evaluation of everything has to be there.
That was my recommendation, that I have just taken Edinburgh, and those non-modifiable factors we can also consider for many. Hello. So this I had put for my further recommendation, that we can include more modifiable factors like depression, stress, diet, role of exercise, and we can go for more screening tools.
Yeah. Nice.
Yes. Thank you, ma'am.
Ma'am, we are done with the senior categories. And now we are moving to our junior categories, ma'am. So code number 01 is ready. Junior. JR Neuro 01 code is ready.
Yes, ma'am.
Your time starts now.
Good morning, ma'am. My title for today's presentation, Rehabilitation for Rare Form of Infantile Hemangioma.
Introduction. Hemangioma is the condition seen in premature infant. It is the birthmark that grow during initial year of life and remits over time. It is commonly seen in face, scalp, back, and chest. Most of the time, hemangioma interferes with the vision. Infantile hemangioma is the most common benign tumor affecting infants characterized by swelling. However, this fibrofatty tissue and formations of hamper patient's psychosocial development. It affects the physical appearance and possible health complications. Next step. Patients and observation. A 9-month-old female child brought with the complaint of swelling over back since child was 1 month of age. After 1 month, there is development of swelling over back. Initially, it was size of pea and then gradually progressed in a size and attained the presence of size over time, and child had developed ulcer or overswelling. The history of delay milestone, gross motor skills present. Investigation. USG local site was done suggestive of heterogeneous lesion of size approximately 15 to 30 mm is noted, and subcutaneous plane of neck showing multiple vessels with the slow flow. MRI neck with the contrast and MRA was done suggestive of well-defined homogeneously enhancing lobulated mass lesion extending from lower end plate of C4 up to upper end plate of C5. With altered signal intensity showing low signal intensity on T1 and heterogeneously high signal intensity on T2 with the flow void visualized on all sequence of infantile hemangioma. MRA reveal possible feeding artery arising from preforaminal segment of the left vertebral artery. Clinical finding, a history of bleeding and white discharge from the ulcer present, gross motor skill delay, a single round swelling of size 7 into 7 centimeter is seen over back at the suprascapular area. Signs of inflammation present, redness present, skin around the swelling also shows redness, and ulcer of size 5 into 5 centimeter is seen at the center of swelling. Sleep sign positive. Physiotherapy rehabilitation. Usually, children whose minds are slow to develop are also slow in the learning to use their bodies, and they begin later than other children and lift their heads, roll, sit, use their hands, stand, walk, and do other things. They are physically delayed because they delay the mental development. In other children, the opposite is true. Their minds are basically complete and undamaged, but certain physical disability make it harder and slow for them to develop use of their mind. Step in designing program special learning and early stimulation. First, observe the child closely to evaluate what he or she can do and cannot do in each developmental area. Second, notice what things he is just beginning to do or still has difficulty with. Third, decide what new skill and teach or actions of encourage that with help of child build on the skill he already has. Fourth, divide each new skill into small step activity and the child learn a day two and then go to the next step. Caution, do not expect too much at once, be realistic and start with what child can do well and encourage him to do a little more by giving the right help and right time. Both the helpers and child will feel successful and happy. Suggestions of doing learning activity with the child. Be patient and observant. Children do not learn all the time. Sometimes they need to be rest. When they are rested and they will begin to progress again. Observe the child closely and try to understand how she think, what she know and what she use her to new skill, and be orderly and consistent. Plan special activity to progress naturally from one skill to the next, and try to play with the child at about the same times of each day and put his toys or tool, cloth and so on for the same place. Use variety. While repetition is important, so is variety. Change the activity little every days, and so that the child and her helpers do not get bored and do things in a different way and various place inside and outside of the house. Be expressive. Use your face and your tone of voice to show your feeling and thought. Speak clearly and the simple. Praise, encourage the child of 10. Have a good time. Look for a way to turn all the activities into game that both the child and you enjoy. Be practical whenever possible. Choose skill activity that will help the child become more independent and able to do more and himself for other. Be confident. All the children will respond for the some way to care and attentions love with the help, and childhood delay becomes more able to independent. Discussion. The study was done to the patient with the hemangioma, which show a multidisciplinary approach is required for remission and prevention of secondary complication. Oral propranolol has significant good result and is now first line of treatment along with the topical beta blocker to improve superficial lesion. Other drug used were steroid with the physiotherapy rehabilitation approach. On the previous studies, clinical outcome include recovery rate and hemangioma activity score, adverse effect and relapse rate were compared on patient treated with the atenolol and propranolol for the infantile hemangioma. A retrospective review of medical record was done on the pediatric patient with the hemangioma with the propranolol. Most of the time, hemangioma interference with the vision and other physiotherapy approach help to improve delay milestone. Okay, ma'am. Ma'am, we come.
Judges, over to you. Judges?
No questions.
No questions.
Thank you, ma'am.
Code number 02. Are you ready? 02, are you there? Zero two, unmute yourself. Please change your login ID. Your login name, please change that.
Hello, am I audible?
Yes, yes.
Can I start?
Just a second. Your time starts now.
Good afternoon, everyone. We can't wait for the day to hear COVID-19 is finally gone. But what if we came to know that the further complications, or say the COVID sequelae or the complications, will remain for years? Unmasking the COVID-induced global threat to nervous system. I have chosen this topic after I came across a case in our IPD, and it's not that case which I saw 6 months ago, but later on, similar cases, similar complications we came across. These are the contents which are included in this. Next slide, please. COVID-19, the coronavirus disease or the COVID-19 or the SARS-CoV-19 was first reported in Wuhan city of China in December 2019. Since then, it was exploded and uncontrollably all over the world, taking a heavy toll of life and economy. Novel coronavirus invades the respiratory system primarily and is diagnosed by the oropharyngeal or the nasopharyngeal swabs. The incubation period is 1 to 14 days for the symptoms to appear, but the case can be asymptomatic too. The common symptoms are cough, breathlessness, and shortness of breath. The COVID-19 can attack our nervous system or the CNS, and there are very much emerging evidence about the same study in the past. There are approx 36.4% of the COVID-19 patient which developed some sort of neurological complications. The first case of COVID-19 associated viral encephalitis came on 4th March 2020, and it showed that the potential of the SARS-CoV virus to invade into the CNS, it does not only affect the epithelium of the lungs, but also can cross the blood-brain barrier and affect its epithelium too. The mild symptoms like the loss of taste, loss of smell, these signs say that the COVID affects the olfactory functions of the CNS and peripheral the cranial nerves also. In severe complications include the seizures, epilepsy, encephalitis, the peripheral nerve disease, and intracranial hemorrhage too. First, before going further, let's talk about the coronavirus. Ma'am, last slide, please. Previous one. let's talk about the coronavirus. We can learn it from the mnemonics MEMS. M stands for membrane that is responsible for the structural integrity of the virus. E stands for the envelope that is responsible for the production and maturation. N stands for the nucleoplasmid protein, that is the RNA, that is the virus assembly, and S for the spikes. The two parts of the spike help in the binding and also the fusion. Let's see about the virus. Ma'am, next slide, please. This is how the virus enters into the cell. The S protein helps present on the spikes helps to bind the virus to the cell. Next slide, please. The virus releases the genetic code into the cell once it fuses with the cell, and the strand of RNA is released, and it is instructed to make different copies. Then the genetic code is converted. Tiny parts of the host cells called as ribosome are equipped to read the genetic code where the ribosomes are formed. Next slide, please. The viral protein copies are made, and the protein proliferate and make exponential more copies that fill up the cells. Next slide. The viral parts get assembled, and the new virus cells are formed within the human body, and which thereabout come out of the cells, and they show the symptoms. Next slide, please. Remdesivir is a drug that mimics the part of the viral DNA. It attaches itself to the RNA strand, and when attached, it prevents the further prevent further coping and leaving the RNA strand incompetent and unable to produce the critical viral pathway. Next slide, please. Routes of the CNS invasion. There can be different routes of the CNS invasion. It can be hematogenous neuronal transport, ACE2 receptor enzyme transport, or the cytokine storm in the CNS. Here, we can, ma'am, last slide, previous slide. Here we can see it in 4 parts. The leukocyte release autoantibodies in the bloodstream outside the blood-brain barrier along with pro-inflammatory cytokinins. After the leukocytic infiltration into the blood-brain barrier, it also releases the pro-inflammatory cytokinins in the perivascular spaces. With the help of ACE2 receptors, virus bind to the CNS parenchyma, invading into the nervous system, primarily causing phagocytosis, pathogenesis, and inflammation. The cellular stress is increased and later on leading to degeneration. Next slide, please. This is the pathophysiology of the CNS involved in the COVID-19.
1 minute left.
Okay. Ma'am, next slide, please. Next slide, please. Next. After the inflammation, it reaches to the brain. It can next slide, please. It can produce psychological complications. We have seen the anosmia and aglysia, but encephalitis, encephalopathy, neuronal degenerative disorders can also occur. Next slide, please. Ma'am, next slide. Next. The virus use the retrograde and axonal transport to reach the neuronal cell bodies, thus invading the CNS. This is how I told the virus crosses the blood-brain barrier. Next slide, please. These are neuropsychiatric manifestations and how the CNS and the PNS are affected. In the CNS, dizziness, headache, and the alteration of the acute cerebral vascular diseases occur. Ma'am, next slide. And in the PNS,
time is up. Excuse me, your time is up.
Okay, ma'am.
Over to judges. Over to judges.
No questions from my side.
Over to judges. Suvarna ma'am, are you there?
Yeah, no questions.
Yeah, ma'am. Thank you, ma'am. Are you ready?
Yes, ma'am, I'm ready.
You there? Okay. Your time starts now.
Good afternoon to all the respective faculty. Reliability of Gujarati version of back depression inventory scale in stroke patients. Next slide, please.
Next slide, please. Introduction. Is a sudden loss of neurological function caused by the blood flow to the brain. As depression is the most common psychiatric complication of the stroke, significant prevalence and incidence rate. And according to epidemiological studies, nearly. Sorry.
Please hold your mic closer.
Sorry.
You're not audible.
Now,
Yeah.
is it audible?
Yes, yes.
Now it is audible.
Please continue.
Hello. Now it is audible.
Yes.
You're audible. Please start.
Okay. Next slide, please. Depression in the stroke survivors has been associated with the delayed resumption of the pre-morbid physical and social activities, poor functioning, and a decline in leisure activities. Researchers found that stroke survivors had post-stroke depression with moderate to severe being post-prevalent. PSD, that is post-stroke depression, is the most frequent psychiatric complication after stroke. Next slide, please. The most consistent predictors of PSC have been physical disability, stroke severity, and history of depression and cognitive impairments. Although PSC is prevalent, uncertainty remains regarding predisposing risk factors and optimal strategies of prevention and treatment. Therefore, further studies are needed to evaluate the depression in stroke population. There is a need to evaluate amount of depression in stroke patients. Next slide, please. Next slide, please, ma'am. Need of the study. Use of the English version may lead to misinterpretation of the items, particularly where patients are concerned, as most lack the English language proficiency to read and understand the questions. The need of the study is to translate back depression inventory scale in Gujarati language, so later on can be used to assess depression in Gujarati population after stroke. Methodology. Source of data was different hospitals of Ahmedabad. Population is stroke patients of any stage, acute, subacute, as well as chronic. Study design was observational study. Sampling technique was purposive sampling. Sample size is 30. Duration of the study was 2 months. And tools were back depression inventory scale. Inclusion criteria, willingness to participate. Only ACA, that is anterior cerebral artery, and MCA stroke, chronic stroke patients. Age criteria was 50 to 70 years. Both males and females can participate, able to follow commands. Next slide, please. Unconscious stroke patients are unwillingness to participate, already diagnosed with psychiatric illness, patients with MMSE score less than 24, patient with any visual impairment. Procedure. BDI was translated to Gujarati language by 2 independent translators who were native speakers of Gujarati language fluent with English language. First translation copy was reclined from 2 translated copies and reports were prepared for required changes. Next slide, please. Translation of the first copy back to English by independent translator. Documentation of difference between the translated copy and the original English version are documented. Process of forward translation continued with acceptable second Gujarati copy obtained. In the process of retest translation, 30 patients of stroke were approached and their consent and convenience was taken. After all modification, final version of Gujarati translation was prepared and was assessed in 30 chronic stroke patients. Next slide, please. Second translation copy was given by experts who were working in respective fields with experience 8 years. Each analyzed and accepted with or rejected. Report of item questionnaire regarding modification was prepared and modified till common consequences. Next slide, please, ma'am. Next slide, please, ma'am.
Are you able to see slides?
Next slide, ma'am.
Which slide? Outcome measure slide is there on the screen. Are you able to see the slides? Are you there? Are you there? Code 03, are you there? Code 03, are you there?
He seems to have disconnected, ma'am.
Okay. Excuse me, judges, because of some technical error, code 03 is not able to complete her presentation. So should we proceed with 04?
Yes. Suvarna ma'am?
Yeah, no questions.
04, are you ready?
Yes, ma'am, I'm ready. Yeah. Good
04,
afternoon.
your time starts now.
Good afternoon, ma'am. Today's my topic is on effectiveness of physiotherapeutic approach on rare case of Goldenhar syndrome, also known as a vertebral dysplasia. Introduction. Goldenhar syndrome or a facio-auricular vertebral dysplasia is a rare developmental disorder, a rare congenital condition characterized by abnormal development of eye, ear, and spine. Its pathogenesis is caused by MSX homebox gene. It's a gene localized on a human chromosome 5 that are encoded a transcription repressor and activator responsible for craniofacial and limb birth development. Its etiology is unknown. Beside maternal diabetes can be a causative factor. Its incidence lies between 1 ratio 3,500 or 1 ratio 5,600, and where male to female ratio is 3:2. In 85% of Goldenhar syndrome cases, the unilateral face is affected, the right side being commonly involved. There are rarely bilateral involvement. Typical clinical findings are ear irregularities with or without hearing loss, facial impairment, cardiac syndrome, central nervous system involvement, and skeletal alteration. Patient and observation, a 12-year-old female who was first born of non-congengious marriage was diagnosed with atonia on the left side and facial asymmetry at birth. The patient grew with normal development and scholastic performance and doing well in school, but had restriction on physical exertion. Moreover, she had a moderate growth failure. Patient started to have a deformity of upper back at the age of 10, which was progressed and caused mild left shoulder elevation with neurological defects. Investigation. Upon audiogram, right ear mild conductive hearing loss and left moderate severe conductive hearing loss was found. High resolution computed topography of petrous temporal was suggested of non-visualization of left external ear means pinna, and left auditory canal suggests of agenesis of left external ear. On finding of 2D echocardiography suggested of patent ductus arteriosus and ventricular septal defect. On X-ray, the spine shows kyphoscoliosis. Both left thoracic curve and right proximal thoracic curve were rigid with a rib hump in finding. MRI of a whole spine showed a congenital fusion of C2 and C3 vertebra with the presence of rudimentary discs in between C5, C6 vertebra showed partial fusion. D1, D2, and D7 level showed the presence of hemivertebrae, while D5 and D6 show
vertebrae. The cervicodorsal region had marked kyphoscoliosis. The patient underwent posterior scoliosis correction with a posterior instrumented fusion from D1 to D10 for the correction of double thoracic congenital scoliosis with D2 and D7 wedge vertebra. Clinical findings, absent ear cartilage and external auditory canal on left side. The patient was advised left pinna construction by plastic surgery for a cosmetic purpose to augment symmetry of a face, although it would not improve hearing ability of left ear. Patient feel tiring and breathlessness after climbing stairs to OPD and posterior scoliosis correction with posterior instrument fusion. Physiotherapy treatment, management of for scoliosis. Rolling is taught as one side rolling, log rolling to avoid trunk rotation. Isometric exercises is advised. Hydrotherapy is performed to achieve mobility of spine. Turning in a bed to facilitate safe rolling, which is later progressed to tilt table activity, corrective mobilization and strengthening of the back. And for management of BSD, lower limb movement, example walking forward and backward, stepping and side stepping, alteration legs to side before side stepping. Continuous training is performed like brisk walking, cycling, stepping up and down on the bench, running on treadmill. Interval training consists of bouts of aerobic exercise with period of lower intensity work, and lumbar and thoracic spine mobilized by bending sideway and turning. Next slide, ma'am. Discussion. Guldana syndrome is a rare inherited condition of uncertain etiology. This condition is characterized by multiple abnormality that affect the first and second bronchial arc of first pharyngeal pouch. And this condition developed towards the end of 7 to 8 week of embryonic life. They are finding Revell chromosomal imbalance that indicate multiple pathogenesis pathway involved in this syndrome. Guldana syndrome comprises of sensorineural hearing impairment, vertebral defect, CNS, and renal deformity. Urinatrial facial hypoplasia occur as a facial defect. Anomalies of ear include periauricular skin stages of blind fistula with aplasia and external auditory meatus atresia. CNS involvement accompanies with maternal retardations, and 60% of the cases has cervical vertebral union. Most patients with spina bifida, hemivertebra, and butterfly anomalies. In other patients, the correction of double thoracic congenital scoliosis with D2 and D7 wedges vertebra was performed by posterior scoliosis correction with instrumented fusion from D1 to D10.
Time is over.
Yep.
Okay. Over to judges.
Question. Was there any musculoskeletal or neurological involvement involved with the spine? The correction was done, right, for spinal scoliosis and all, but was there any neurological involvement there?
No, ma'am, there was not neurological involvement. There were.
Was it any of the functional involvement, functional limitation which was there? Because
Yeah,
the breathlessness was because of the VSD, I suppose, right?
Yeah, ma'am.
Yeah, so any of the surgery which was done, the scoliosis planning, do you know or have you assessed for any functional limitation?
Yes, ma'am, I have assisted her and she had problem in bending.
Bending?
Yes, ma'am.
Pre-operation, like pre-surgery or post-surgery?
Ma'am, post-surgery. Actually, there was some restriction at initial stage.
Fine.
Yeah, ma'am.
Shall we proceed to next candidate? Zero 05, are you ready?
Yes, ma'am, I'm ready.
Thank you, ma'am.
Hello.
Yes, 05, we can hear you.
Your time starts now, 05.
Okay, thank you, ma'am. Good afternoon, everyone present here, and thank you for giving me this opportunity to present my presentation in front of you. So, my today's topic is post-COVID-19 complication associated with Guillain-Barré syndrome. It is a case report. Next.
So let's start with an introduction. As we all know, the novel coronavirus, or as we call it, COVID-19, was spread like a wildfire on 31st December 2019 in China. Had common symptoms of fever, cough, dyspnea, myalgia, and some neurological symptoms. Um, First case was reported in India on 30th January 2020 in Kerala. On March 11, 2020, the World Health Organization officially declared coronavirus as a pandemic. So, coronavirus we had seen some neurological symptoms in coronavirus, and Guillain-Barré syndrome. It is an polyradicular neuropathy. It is an acute immune-mediated disease of peripheral nerves and nerve root. Next. In this case report, we will describe how patient which was affected by COVID-19 was then diagnosed with Guillain-Barré syndrome, and how we all overcame those complications and tried to rehabilitate the patient. So next, patient information. Patient was 16-year-old boy who came to medicine OPD with a complaint of weakness over right lower limb, and he gave a history of cough with expectoration 3 to 4 days back, which was sudden in onset and gradually progressing. As he was having cough, RT-PCR test was done, which came positive for SARS-CoV-2, that is COVID-19. Following 2 weeks of COVID-19 treatment, he was then diagnosed negative. In those 2 weeks, he was admitted to isolation medicine ICU. At the same time, when he was admitted there, he started experiencing progressive weakness in both his lower limbs. The weakness was gradually progressing from distal limbs to proximal limb. Then he was then shifted to normal ICU, where he was having difficulty in breathing and maintaining saturation. So he was then put on ventilator for 13 days. There was no involvement of central nervous system. Next. When after next, then about a month or so, he was then shifted to medicine ward, where physical examination was done. Before that, oral consent was taken from the patient and his parents. On physical examination, patient's vitals were stable and within normal range. His saturation was 93% in room temperature, and patient used to get breathless in position change or any functional activity. Patient was conscious, oriented, and comfortable in supine line. Patient's body type was endomorphic, and visible muscle wasting was there. Motor examination revealed there was decrease in muscle strength when graded on with use of manual muscle testing. Muscle power was loss of muscle power was more evident in distal muscle group as compared more evident in proximal muscle group as compared to distal muscle group. And respiratory muscle was present. There was no facial muscle involvement. There was presence of the patient gave a history of weight loss. Deep tendon reflexes were intact. Superficial reflexes were diminished. Sensations were intact, and patient had dull aching pain. Patient had breathlessness of grade 4 on MMRC. Next. Lung CT was done, which revealed ground glass opacity and diffuse consolidation. Electrodiagnostic test revealed there was a decrease in amplitude at compound muscle action potential level. The findings was consistent with acute motor axonal neuropathy. Patient's active problems were deconditioning, immobilization, decrease in lung volume and capacity, and related impairments. So our treatment protocol was we divided our treatment protocol in phases. Our short-term goals were to decrease pain, increase range of motion, mobility, muscle strength, reduce stiffness and pain, chest clearance, and also to minimize secondary complications like chest infection, muscle contracture, improve chest mobility, improve lung function. Okay, thank you. Long-term goals was to maintain all this range of motion balance training. Next. So in phase one, our main focus was on to relieve dyspnea and to activate all the major muscle group. For dyspnea, we gave him various breathing exercises such as diaphragmatic breathing, pursed breathing, glossopharyngeal breathing. Special type of breathing exercise that was breath stacking exercise was done, and frequent prone positioning was of great help for the patient. Then in next second phase, which was 2 to 4 phase, modifications were done in breathing exercise. Patient had good cough reflex, so active cycle of breathing technique. Then spirometry was done. We gave stretchings to all the tightened muscles. Mobilization was carried out in shoulder and hip joint. And at the end of 4th week, patient was able.
Time is up.
Okay, thank you, ma'am.
Judges, over to you. Judges, over to you.
Proximal muscle weakness was more as compared to the distal muscle weakness.
Yes, ma'am.
But the description of muscle testing you have not given.
Ma'am, more muscle weakness was found on shoulder and hip. Muscle.
Don't give now, because for us as a physiotherapist, the muscle strength or manual muscle testing assessment is the most important thing, and that would help us to diagnose the condition also.
Yes.
And with proximal muscle weakness, would you label the patient as Guillain-Barré syndrome?
No, ma'am. In Guillain-Barré syndrome, there is ascending. There are types of Guillain-Barré syndrome, and according to those types, we can classify that. But we can confirm Guillain-Barré syndrome only after electrodiagnostic test or after cerebral spinal fluid examination. We cannot tell for sure just based on physical examination.
You want to rely only on the investigations?
Not completely, but yes, those are confirmatory tests. We can cross-check using investigations.
Okay.
Thank you, ma'am.
06, are you there?
Yes, ma'am. Please. Am I audible?
Yes, yes. Your time starts now.
A very good afternoon to all. My topic of study is the comparison of high intensity and low intensity mirror therapy for the hand function. So introduction, please next slide. Stroke is a sudden loss of the neurological functions caused by an interruption of the blood flow to the brain. The motor deficit is characterized by paralysis or the weakness. It is mostly on the opposite side of the lesions. So the middle cerebral artery supplies the entire lateral aspect of the cerebral hemispheres and the subcortical structures, including the internal capsules. So hemiplegia leads to the loss of the functions, which results in the decrease in the participation and activity of the daily living things, and these thus affecting the quality of life. Next slides. There are the different treatments. Next slide, please. There are different treatments options for the improving the upper extremity functions. Mirror therapy is the one of the with potential, and these mirror therapies demonstrated that improvement of the range of motion. There are the many evidences found that it improves the range of motions, and there is also some evidences present that reduction in the pain and the posture is also improved. There are the different protocols of the mirror therapies available, but no comparison found between the protocols. So hence this study is needed between differences between the high intensity and the low intensity mirror therapy. So this study is aimed to see whether there is any significant difference between the results of the high intensity and low intensity mirror therapy protocol in stroke patients. So methodology, RCT, its subject type was, study type was RCT. The sample setting is prevalence of patients with cerebral vascular accident in physiotherapy, rehabilitation and fitness centers. Sample size is 20. Then the sampling method is random sampling. Then there are two groups, control group and experimental group. In each group, 10 subjects were there. The group A is the low intensity and group B is one is then high intensity. The study population was severe with proximity deficit. The inclusion criteria were the patients having stroke within the previous 6 months, when the minimental score was greater than the 21, then the intact cognition and the verbal abilities, then patient is able to see the unaffected extremities, then patient is able to sit on the chair during the treatment session, then the Broomstone score between 1 to 4 for the upper extremity, and the patient without any deformity or injuries to the non-affected extremity. Next slide. Exclusion criteria were patient with orthopedic disorders, apraxia, or an upper limb fracture or the peripheral nerve injuries, and the rest were excluded from the study. Next slide. Next slide, please. The total 25 patients were screened for the this study, and 3 were not made to the inclusion criteria, and 2 were dropped out from the studies. The consent form to the participant in the study was taken from every individual ones, and there was the lottery system was done. And in group A, there were 10 repetitions for each movements were done for 15 minutes and twice a day for 5 times a week, and for 4 weeks protocol was there. And group V, 20 repetitions for all movements for 30 minutes twice a day, 5 times a week, and for 4 weeks. So the procedure, the single therapist assessed the motor performance of the hand by the Broomstone scales, and the range of motion was assessed by the goniometry. Then the therapist visually or verbally demonstrated the motor exercises so the patient can execute the movements. Then the patient is the mirror was made to sit on the stool, position the perpendicular the patient's midline, and the affected hand was put into the mirror box, whereas the unaffected hand was placed on the front of the reflective surface. So the uninvolved upper extremity of the patient was put in front of the mirror so that it can make a visual image by the reflecting itself. So by doing this, the patient was visualized the illusions limb instead of the actual limb. So the next slide. Patients were told to do the exercises like flexion and extension of the finger and wrist movement for first 2 weeks. Then combination of the movements like wrist extension and the finger extension were added. For example, the unimpaired limb should be positioned in a similar position at the impaired limb as this facilitates the intensity of the mirror illusions. Then the treatment was progressed to the start with the range of motion that can also be achieved in the affected site. Then the statistical analysis. Here the statistical analysis.
1 minute left.
Yes, ma'am. The paired t-test was used to do in the intergroup, and the unpaired t-test is performed to intergroup analysis for the post-treatment. So the result were 25 subjects were there. 3 was meant to the inclusion criteria, exclusion, and 2 was dropout. They were divided into 2 groups and by the lottery method. These were the groups. There was taken group pre-treatment and post-treatments. So in that wrist flexion, wrist extension, wrist ulnar derivation, and wrist radial deviation were performed. So this figure shows that the pre and post treatment changes in the wrist range of motion in group A. Here the same position, but pre and post treatment was done, and these were showing the pre and post treatment changes in the wrist movement range of motion in group B. So the discussion.
Your time is up.
Okay, ma'am.
Your time is up. Over to judges.
Scale score of 1 to 4 that you have mentioned in the inclusion criteria?
Sorry, ma'am. Hello. Hello.
Gargi, did you hear the question?
Hello.
What is Brunstrom scale score of 1 to 4 that you have mentioned in the inclusion criteria?
Yes, ma'am. First 4 stages. Flaccid and synergy, some spasticity, and marked with some spasticity, and out of the synergy, unless spasticity grades were mentioned.
So any of the 4 grades can be taken in your study, were taken in your study?
No, ma'am. After the when spasticity begins to develop, then we can add it there.
So which patients you had included in your study? Which scale patient you had included in your own study?
And Bloomstone grading scale, and it's synergies in some patients who develop who get started developing the spasticity, they were included.
Which grade?
Grade 2.
But that is not mentioned in the inclusion criteria.
Okay, ma'am. Okay, ma'am. Thank you, ma'am.
08, are you there?
Yes, ma'am.
Your time starts now.
Okay. Good afternoon, ma'am. My topic is effect of proprioceptive neuromuscular facilitation, hold and relax versus muscle energy technique on hamstring muscle flexibility in male football players with perceived hamstring tightness. Next, introduction. The hamstring muscle complex described group of 3 muscles located on posterior thigh. The hamstring is example of muscle group that have tendency to get shorter. Inability to achieve greater than 160 degree of knee extension with hip at 90 degree of flexion considered as hamstring tightness. The most interesting events during a football match happen because of high intensity work such as sprints, turns, jumps, shots, or tackles. The basic movement pattern in football required rapid force development and high power output, as well as ability to efficiently utilize the stretch short knee cycle in ballistic movement. Next. Okay. Football injuries are common and range of for mirror annoying a minor range of annoying aches and pain to serious traumatic injury. In fact, around 17% of injuries in football have been attributed to muscle tightness and lack of flexibility that increase the risk of acute injuries. The most common type of injury in knee and legs are ACL and PCL, meniscal injury, groin pulls, hamstring pull, IT band syndrome pull, or strain in calf muscle. PNF is defined by Sherrington of neuromuscular facilitation and inhibition, which subsequently lead to the development of clinical PNF stretching by Kabat. Today, PNF stretching is more advanced for flexibility training that involves both the stretching and contraction of muscle being targeted. PNF techniques are based on the hold and relax technique that involve lengthening and the muscle to the point of limitation, at which point the individuals perform at isometric contraction for the 10 seconds, followed by passive movement of the limb into the new and range. The hold and relax method PNF stretching is facilitated by the Golgi tendon organ to allow the reflexive relaxation of the muscle. Amity is a manual technique developed by osteopaths that is now used in the many different manual therapy professions. Amity is based on principle to reciprocal inhibition therapy that explains that muscle on one side of joint will always relax to accommodate the contraction of muscle on the other side that joint when indirect pressure is applied. The processive lengthening and shortening muscle this procedure will directly improve range of motion. This procedure is performed when patient is asked to contract a muscle for approximately 5 seconds against the resistance force applied by the therapist. The muscle contraction is performed by subject 3 to 5 times in a row. The hope of stretch and muscle further each time. Need of study. There are different stretching techniques and protocol for improving hamstring flexibility and extensibility. Many studies have reported that techniques of like PNF, hold and relax, and MET are effective for improving the hamstring muscle flexibility and thereby improving the range of motion. But there are very few studies they conducted that to find which one is more effective. Therefore, the purpose of this study in to compare the effectiveness of PNF, hold and relax, and MET on hamstring muscle flexibility in male football players with perceived hamstring tightness, and to conclude which treatment is more effective between the two techniques used. Aim of the study to compare the effectiveness of PNF, hold and relax to hold and relax and MET on hamstring muscle flexibility in male football player with perceived hamstring tightness. Objectives to evaluate the effectiveness of PNF, hold and relax techniques on hamstring muscle flexibility in male football players in perceived hamstring tightness. To evaluate the effectiveness of MET on hamstring muscle flexibility in male football players with perceived hamstring tightness. To compare the effectiveness of PNF, hold and relax techniques MET hamstring muscle flexibility in male football players with perceived hamstring tightness. Next, next, next. Methodology, source of data. Data were collected from the subjects on football players, football club. Method of collected data. Research design is comparative study. Sampling method is random sampling. Sample sizes of 30 subjects in 15 subjects divided. Study duration is 3 weeks. These are the material used in my study. Inclusion criteria are next. Age between 18 to 25 years of age, gender as male, subjects who are playing football since 5 years, tight hamstring means inability to achieve greater than 70 degree of hip flexion,
Left.
extension knee, or inability to achieve greater than 160 degree knee extension with hip 90 degree of flexion. Exclusion criteria: acute with chronic low back pain, age below 18 years and above 25 years, acute chronic hamstring tightness and contracture deformity, neuromuscular and cardiovascular deformity, swelling a region, hamstring region, a recent injury in hamstring muscle, trauma at lower limb, and subject are involving other physical fitness program. This is my procedure. 30 football players are taken, and they are divided in two groups. In group one group, 15 players are included. The duration is 3 times a week and 3 weeks. The in procedure in PNF, to ask the patient to first of all, therapist take hold patient flexion the hip joint, and then the ask the patient to hold the contract the hamstring muscle. This procedure is done for 3 to 4 times, and in MET, the ask the first of oh.
Over to judges. Over to judges.
What was the outcome measure?
My outcome measures are active knee extension test and straight leg raise test.
Can you repeat again?
My outcome measures are active knee extension test and straight leg raise test.
Okay.
How many repetitions of hold relax you had given? And for how many sessions?
In for 3 weeks.
In a week, how many times?
In a week, 3 times, ma'am.
So 3 to 5 sessions of 3 times in a week for 3 weeks.
Yes.
You get the result?
Yes, ma'am. Ma'am, both techniques are affected, but the MET is more affected than PNF.
Okay, since how many years you are giving this PNF technique?
Ma'am, from last 4 to 5 years.
Since 4 to 5 years you are giving PNF?
Yes, sorry, ma'am. For 3 to 4 years. Sorry.
3 to 4 years.
Yes, ma'am.
Okay, and even MET also you are giving since 3 to 4 years?
No, ma'am.
No. MET?
MET from last 1 year, ma'am.
1 year.
I'm whole take workshop from MET.
So what was the position of the patient when MET was given in this case?
A patient in a flexion position, in supine position and in relaxed position, and then ask the patient to do flex their hip, and then therapists give resistance to the patient at end range of that, and then ask the patient to contract the resist the muscle. Therapy is given.
Tell again.
Sorry.
Tell again.
Okay. Patient in supine position, and then ask the patient to flex the hip joint, and then therapist hold.
Hip joint.
Yes. Ma'am,
For
flex
hamstring
joint. Yes, ma'am.
For hamstring tightness, you are asking the patient to flex the hip joint.
With assistance of therapist.
But then flexion of the hip joint, na?
Yes.
Very good.
Ma'am, should we proceed?
Yes, please.
Code 10. Are you ready? Are you there? Code 09. Code 09. Are you there? Code 09. Mr. Piyush, can you unmute him?
Yes, I don't know. I can't find him. There's no 09 in the list anymore. But
Sir, Piyush,
if that person can raise his hand or let us know in the chat box. Okay, there's someone raising the hand. Okay, I found him.
Hello.
Yes, it's a her. Yes, we can hear you. Please hold the mic a little closer.
Yes, sir.
Okay.
Your time starts now.
Good afternoon, all. My topic is the relationship between body mass index and cognitive function in younger adults, a correlational study. And my code is 09. Introduction. Obesity is a paramount public health concern and represents a clear health risk in younger adults. Body composition is defined as the relative proportion of fat and fat-free tissue in the body. Although dementia is known to be associated with atherosclerosis, controversies still exist about adverse effect of obesity on cognition. Body mass index, also called as Cutlets index, is used to assess weight relative to height or BMI, has a similar association with body fat. There are different mechanisms put forward in the literature that might explain the association between overweight and cognitive function. Next slide. The term cognition can be defined as the thinking process of brain using both sensory input to the brain plus information already stored in memory. Cognifit is an application which is developed by the experts in neurosciences of California, San Francisco, USA. The application provides full assessment of a large number of cognitive skills. In total, 22 cognitive skills are measured by this assessment. The domains used to determine cognitive functions are reasoning, memory, attention, coordination, perception. Under each domain, there are wide range of tests which are used for assessing the particular domain and further obtaining results for the same. A positive relationship between BMI and cognition has been demonstrated, although some other reports have showed an inverse association between BMI and cognitive performances. Next slide. Adults with obesity have elevated level of circulatory flow inflammatory cytokines, and there is growing evidence that over systemic inflammation leads to change in brain structure and cognitive function. So there is a need of finding correlation of it, which is the focus of this study. Therefore, the comprehensive goal of this study was to exemplify the relationship between body mass index and cognitive function in younger adults by examining data from the Cognifit application. Next slide. Materials and methods, study design and participants. Healthy community dwelling adults of age between 22 to 35 were recruited. Potential participants were screened to exclude individuals with neurological conditions, dementia, alcohol, psychotic disorders, and pregnancy. The sample size for the study consisted of 300 young adults and was determined by WinPeppy software putting the R value of the mother article. Measures, BMI, height and weight of the individuals were measured and the values were put in the formula to calculate BMI, and it was used as a continuous measure in statistical analysis. Cognitive assessment. Participants completed 16 general cognitive assessment tasks on Cognifit mobile application. that focus on 5 components of cognitive function, that is reasoning, memory, attention, coordination, and perception. And composite scores of these 5 cognitive domains and total score was used in statistical analysis. Next slide. Method: an informed consent from all the participants was taken prior, and information of the study was conveyed to them. Individuals were selected according to the quota sampling. BMI was calculated and the participants were divided into 4 equal groups as underweight, normal, overweight, and obese. The participants attempted a general cognitive task on the Cognifit application. The relationship between BMI and cognitive function was seen on the basis of scoring, and data was correlated depending on the statistical value of R, that is coefficient of correlation, and accordingly correlation between BMI and cognitive function was found out. Statistical analysis. The result was expressed as rho. The data was analyzed by the Spearman rank correlation test using the Medicalc software. Next slide. Result: the association between BMI with reasoning, memory, attention, coordination, perception, as well as the total score was analyzed using the Spearman coefficient of rank correlation, which is given by rho. Next slide. Next slide. This shows the scatter diagram of BMI with each component, that is reasoning, memory, attention, coordination, perception, and total score. A total of 300 participants completed general cognitive assessment tasks on Cognifit mobile application, of which 75 participants were of underweight, 75 of normal, 75 of overweight, and 75 of obese. In the table 1 and the figure 1, that is the scatter diagram of BMI and reasoning, it shows a negligible correlation with a rho value of 0.0605, and the line of regression show no linear relationship. The association between BMI and memory show a poor correlation with rho value of 0.129. Association between BMI and attention also shows a poor correlation with rho value 0.104. Between BMI and coordination with rho value 0.00224 with a negligible correlation. BMI and perception, which is a poor correlation. Rho value is equal to 0.106. Next slide. Next slide. Next slide. Interestingly, the age into BMI effect on cognitive function are also reflected as a tendency for younger individuals with lower education and high BMI to perform more similarly to older adults than to the other younger adults. The highlight of this, the significant impact of high BMI on cognitive function even at young age. This results also suggest that overweight or obese young adults also have a lower education and are particularly at risk of cognitive deficits. Next slide. Thus, this study concluded that there is no significant correlation between body mass index and overall cognitive function in younger adults. Next slide. Limitation. As we use the mobile application, manual tests were not used to assess the cognitive function. So individuals with frequent smartphone use had good response compared to non-frequent smartphone users.
Your time is up.
Ma'am.
Over to judges.
What was your hypothesis?
Ma'am, there was no alternate and null hypothesis set priorly.
No alternate or null hypothesis. Why did you think of the study? Because
Ma'am,
and if you label them with cognitive impairment, they would have all the more negative impact.
Ma'am, actually, there were lack of evidences in of the study in younger adults, and majorly all the studies were in older adults. Therefore, we just wanted that how the BMI affects the cognition in younger adults, because age-related physiological changes occurs after some time. So we just wanted to find the correlation at the this young adult.
Yes, dear, but then age-related changes would not occur in this age group. Why do you want to label them? Age-related changes would occur after 60.
Ma'am, but that's what the need of the study was, that In some, there were some studies which showed a positive correlation between BMI and cognition. But in the studies happen in school adolescents also, but there was no lack of evidences in this age group. Therefore, we did this.
So that's why I asked you what was your hypothesis. So you said there was no hypothesis.
Yes, ma'am, there was no.
ठीक.
Ma'am, we are done with all the presenters of the senior and the junior categories. So, ma'am, from the on behalf of Rehab-Con team, I would like to express my deep gratitude to our today's judges, Dr. Suvarna Ganveer ma'am and Dr. Saili Pardikar, for patiently listening and the presenters and judging them. I would like to thank you for accepting the invitation and making yourself available for judging this neuro research paper. Thank you so much, ma'am, for this. And I request you, ma'am, so to please share a few words or give a feedback of this neuro research presentations.
Okay, so first of all, let me thank the organizers for giving me the opportunity to be a part of this particular research conference. And I always love to, be a part of research presentations, may it be as a listener or may it be as a judge. So it was really enjoying for me to see how the young researchers are growing in the field of neurophysiotherapy. And I was happy that really there are some good research papers that I could hear to. So I would like to thank all the participants for giving me the opportunity to listen to their research studies. So, and I congratulate all the participants for their hard work that they have done while conducting these studies. And as usual, there would be some winner or some loser, but in the end, it is the hard work that pays rather than the first or the second rank. So I wish all the participants very good luck in their future endeavors. And Dr. Varsha, Dr. Kargi, I congratulate you for organizing this particular conference in a most effective way. So congratulations.
Dr. Saili, can you please give us the feedback? Dr. Saili, please unmute yourself.
But doing research, particularly in neuro with so many limitations itself is a winning thing. So it's a pleasure to be a part of this conference, and I congratulate and thank Dr. Varsha and team for giving me this opportunity to be a judge in the conference. Thank you.
Thank you so much.
I owe my sincere thanks to all the presenters, and the result will be declared in the validatory function, and the link for the validatory function will be the day one link only. We have already mailed you all. We have sent it on the group also.
It's an earnest request to the judges. Please join the validatory link so that we will announce the winners. Also, it's a request to the judge to please fill the score sheet and WhatsApp us with their signatures. Hello, am I audible to all? Hello. Good evening to one and all. Rehab-e-Con 2021 participants. I extend a warm welcome to the last session of the conference. It was an amazing paper presentation session. I know all the participants have given their best. It's all that the score numbers are the steps for improvisation. I stand hereby to announce the winners of the paper presentation in senior category and junior category. In musculoskeletal paper presentation, the winners for the senior category are: second prize goes to Dr. Neha Kulkarni. I repeat, Dr. Neha Kulkarni from Dr. D.Y. Patil College of Physiotherapy, Pimpri, Pune. The first prize goes to Dr. Hina Jain. Dr. Hina Jain from CMF College of Physiotherapy, Chinchwad, Pune. Hearty congratulations. The next junior category in MSK paper presentations. The second prize is for Namrata Mali. Namrata Mali from Dr. D.Y. Patil College of Physiotherapy, Pimpri, Pune. First prize is for Akash Mulchandani from College of Physiotherapy, Ahmedabad. Heading towards the CBR paper presentations. Senior category CBR paper presentation, the second prize goes to Dr. Muzahid Sheikh. Dr. Muzahid Sheikh from DMIMS Nagpur. And the first prize, there is a tie between the first prize. First prize goes to Dr. Ankita Chitre, the oncophysiotherapist, Tata Memorial Hospital, Mumbai. And it is shared with Dr. Pallavi Vakode, Kashibai Navle College of Physiotherapy, Pune. The junior category CBR paper presentation, second prize goes to Sabiha Haradwala. Sorry for the thing. Sabiha Haradwala from Swami Narayan College of Physiotherapy, Gujarat. The first prize goes to Jigyasa Talwar from Dr. D.Y. Patil, Pimpri, Pune. Congratulations, winners, for the CBR paper presentation. The fourth category, the fourth subject, cardiovascular and respiratory sciences. The senior category, second prize goes to Dr. Ashirvad Mahajan. Dr. Ashirvad Mahajan from APJ Abdul Kalam College of Physiotherapy, Pravara. And the first prize goes to Dr. Prajakta Patil from Kashibai Navle College of Physiotherapy, Pune. From the junior category, the second prize for cardiorespiratory goes to Dr. Vaishnavi Siroya from RNPC College of Physiotherapy, Varda. And the first prize goes to Sharvari Saman from Dr. D.Y. Patil College of Physiotherapy, Pimpri, Pune. The next winners of neurophysiotherapy senior category. The second prize goes to Dr. Pallavi Taide, CMF College of Physiotherapy, Chinchwad, Pune. And the first prize goes to Dr. Ramya Shetty, Maimar College of Physiotherapy, Talegaon, Dhabade. The junior category, second prize goes to Manpreet Kaur, RNPC, Varda. And the first prize goes to Dhanashri Ghoradekar from RNPC, Varda. My heartiest congratulations to all the winners. Virtual applause to all the winners. Thank you. Well, I extend my warm welcome again for the last session. To quote the Irish author James Joyce, better pass boldly into that other world in the full glory of some passion than
fade and wither dismally with age. I believe we as an organizing team have exemplified this statement. Through these past few days, I have seen us all discover and devote ourselves to our passion conference and organize it to give its best result. I am very happy and also much humbled to address the wonderful 450 participants who have registered for the conference. They have supported to spread the umbrella of cherishing success. Thank you for the registration participants. I hereby would like to extend my heartfelt gratitude to all the principals of the different colleges and in NUHS Nashik, also with the other state principals who have timely notified all the flyers and circulated for the race in the registrations. Thank you to all my dear and respected principals. I am honored that our chairman of Allied Health Sciences, the Board of Studies head, the Dean Principal of Lokmanya College of Physiotherapy, Mumbai, Dr. Rajashri Naik ma'am, who humbly accepted our invitation amidst all her busy schedule to be virtually present with us for blessing and gracing the Rehab-e-Con 2021, a radiant recovery. Thank you, ma'am. I am overwhelmed. I take an opportunity to also pay my gratitude to Dr. Sham Ganbir sir, the BOS member, also Dean Principal of Dr. V.K. Patil College of Physiotherapy, Nagar, Ahmednagar, to be virtually present for extending his wishes towards the conference. Thank you very much, sir. It would definitely not be scripted if our eminent speakers would not be there. I am fortunate that every speaker had, without any second thought, accepted to be a part of our conference. I thank all the 5 incredible gems of our Rehab-e-Con 2021. I respectfully pay my gratitude to Dr. Bhavna Matre ma'am, the HOD, Musculoskeletal, Lokmanya College of Physiotherapy, Mumbai, Dr. Sanjay Parmar, the Vice Principal and HOD Neurophysiotherapy Department, SDM College of Physiotherapy, Karnataka, Dr. Sudeep Kale, Professor Cardiorespiratory, Terna College of Physiotherapy and the Chairman, Maharashtra OTPT Council, Dr. Manisha Rathi ma'am, Professor HOD in CBR Department in Dr. D.Y. Patil College of Physiotherapy, Pimpri, Pune, also, Dr. Arunmaya sir, the Dean Principal of Manipal College of Health Professionals, Manipal, Karnataka. My millions and tons of sincere thank you to all the esteemed dignitaries. The chariot of conference were supported by the distinguished moderators, Dr. Snehal Godi ma'am, the Principal of Maimur College of Physiotherapy, Talegaon, Dr. Vimal Telang ma'am, retired Principal, AIMPR College of Physiotherapy, Mumbai, Dr. Tushar Palekar sir, Dean Principal, Dr. D.Y. Patil College of Physiotherapy, Pimpri, Pune, Dr. Parag Ranade sir, Professor HOD Neuro in Sihagarh College of Physiotherapy, Pune, also Dr. Vijay Kumar sir from Dr. D.Y. Patil College, Pimpri. I solicit my heartfelt gratitude for attending the conference and being the moderators for the speaker. Thank you. The tough taskers were the kind judges of this conference. Listening to 75 paper presentations patiently, our judges have scrutinized the winners for the best presenters with all the transparency. I owe you all a great thank you. Dr. Chaya Verma ma'am, Professor HOD MSK Department from Nair College of Physiotherapy, Dr. Seema Saini ma'am from Dr. D.Y. Patil College of Physiotherapy, Dr. Chandu Basavraj sir, he is a principal at Dr. M.S. Gosavi College of Physiotherapy, Nashik, Dr. Deepali Hande ma'am from APJ Abdul Kalam College of Physiotherapy, Pravara, Dr. Suvarna Ganir ma'am, Professor HOD Neuro Physiotherapy Department in Dr. V.K. Patil College of Physiotherapy, Ahmednagar, Dr. Saili Paldekar from the Professor HOD, Neuro Department, Maimer College of Physiotherapy, Talegaon. Dr. Shilpa Param, ma'am, the Principal, Chaitanya Medical College of Physiotherapy, Chinchwad, Pune. And Dr. Afle, Professor HOD at Cardiorespiratory Department in Modern College of Physiotherapy, Shivajinagar, Pune. I owe you all my sincere gratitude. It was indeed not possible with an unconditional support, trust, and belief put on us by our esteemed late Shri Fakir Bhai Education Foundation, with Chief Patron Azam Bhai Pansare sir, the trustee Mr. Nihal Pansare, the directors Dr. Zoya Pansare and Sham Ahirrao sir. Hope we have come up to their expectations. I also would never dream to see this conference to this glorious success if I would not have the professional technical services given by Mudijishil to us. The timely changes and unidentified hurdles were like petty stones for us in this journey of conference. I'd like to extend my gratitude to Mr. Dipen and Mr. Piyush for their consistent alert support. Thank you very much, Digishil. To conclude, now words will fall short, pages will end, the pen will break its point. Yes, my Rehab-e-Con 2021 team, the team with myself, Dr. Vashai Kulkarni being the organizing chairman, Dr. Virendra Meshram being the organizing secretary, Dr. Shweta Pajpute as the organizing co-coordinator, along with the program head and the college technical team, Dr. Gargi Bhalekar, Dr. Pallavi Chisolikar, Dr. Neha Deshpande, Dr. Ruchita Kiledar, Dr. Shruti Mulaukar, and the treasurer, Mr. Raju Shingote, are all a promising team. The clouds of tensions or incoordination were never seen. It was a smooth and a mind understanding which helped us all to get away through this conference. I am proud to have such an eminent gems with me to go far off. Last but not the least, our college enthusiastic students were always there for their untiring support and help. I also thank my gratitude to the non-teaching faculty for the sincere help. Thank you once more to the Rehab participants, the moderators, judges, speakers, and whoever. If at all I have forgotten anybody, please pardon me. I would like to end up with this conference. Thank you once more. Thank you. Also, I would like to extend my thanks to all the participants, the paper presenters who have definitely given their time and efforts to give the best presentations. Once more, congratulations to all the winners. All the winners, thank you so much. There is a display on the screen. Can you please check? Please check for the prize winners. I would like to give you a kind reminder. You people have to those people have registered for the conference have to give the feedback form. Until unless your feedback forms are not received, you will not be able to receive the certificates. So you will be receiving the e-certificates within 2 days. Is it clear? This is a kind and a humble reminder. Please fill the feedback form which will be mailed to you, and only then you will receive the certificates. The e-certificates will be soon issued to you through mail on your mail accounts within 2 days. Thank you so much. I declare the conference to be closed. Thank you.